Hello. Hello. Good morning, everyone. Respected doctors, esteemed professionals, and dedicated guests. I am Dr. Asif Rahman, and I welcome you back, all of you, to the third and the final day of this conference, Clinics in Hepato-Biliary Diseases 2023, organized by Institute of Liver, Gastroenterology, and Pancreatico-Biliary Sciences, Sir Gangaram Hospital, organized by Dr. Anil Arora, and co-organized by Dr. Ashish Kumar and Dr. Praveen Sharma. Over the past 2 days, we have delved deep into the world of gastroenterology, exploring new ideas, discussed emerging trends and concepts, and strengthened our clinical approach. Today, we'll continue this journey, bringing together the experts to exchange ideas and insights. We have again an impressive lineup of speakers today, covering a wide range of topics. We have a pulsating debate also in the session to make it even more interesting. Thank you all of you again for being here. As a team, we are committed to ensuring that this final day is as informative and as emerging as the previous ones. So without any more delay, let's start the today's session. So the topic of today's first session is day-to-day problems in gastroenterology. So for today's first session, I would like to call upon the stage the chairpersons of this session, Dr. Bharat Bhushan Gupta, Dr. J.C. Vij, Dr. Neeraj G. Joshi, Dr. Roshan Kafle, and Dr. Surakshit T.K. And for the moderators, I would like to invite on the stage Dr. A.V. Sivaprasad, Dr. L.B. Gupta, Dr. Pankaj Tyagi, Dr. Priyanka Udawat, and Dr. Rakesh Kanchan. I would now request the respected chairpersons to call the respective speakers on the stage for their talks. Thank you.
Good morning, everybody. Next 1 hour, we are going to have 6 presentations. And the first presentation is management of alcohol dependence in patients with cirrhosis. May I invite Dr. P.K. Agarwal for the presentation?
Good morning, friends. I bring greetings from the hill state of Uttarakhand. And probably I think, after yesterday's ASH program that started in the evening at around 9 o'clock, followed by now today's talk, it's a big controversy. So I'll have to here come out and say that, alcohol definitely is not good. So we all know that, we go by the spectrum of the disease process, right from the normal liver, and you go down having, steatosis, which is now becoming very common, the most important part of today's practice. The people, with alcohol can have, the cirrhosis developing, which is almost to the tune of around 20%, with decompensation to the tune of 40%. And of course, we just keep on seeing on daily routine the alcoholic hepatitis. And how to recognize it? We normally say either we have got a rise in the ALT, AST levels, the deranged albumin, the increase in INR, the patient's developing, a chronic liver disease, which can always be given us a doubt from an ultrasound process. A good thing which has come up nowadays is a local scan in the form of fibroscans which are coming up and give us a lot of ideas about it. A word about a steatotic liver disease classification, which is very important. It could be because of alcohol with and without alcohol. And a new terminology which has almost come up, which we all know about, that is M.I.C.E. the metabolic dysfunction associated steatotic liver disease. Friends, here basically the idea was to say that, how much alcohol can do, how good and how bad. And definitely it is bad almost most of the times. The amount of alcohol right from 140 grams a day, in men or in women, and 210 grams of alcohol a day, in females, they usually cause some amount of disease process to come up. So it could be a macelled or it could be even a metalled. That is, the metabolic dysfunction along with an alcoholic intake. Specific other etiologies do cause steatotic liver disease. We have got DILI, we have got, and the monogenic diseases and other miscellaneous diseases. So I thought, why not first of all know what is the conversion of alcohol, which normally one should have it. And this slide basically tells you how much amount of alcohol is equivalent to what, A fortified wine, 5 ounces of wine is how much, a beer is around, equivalent to 12 ounces. The whiskies, which are being taken, the scotch which you all had in the night yesterday. So you have to just calculate yourself and find out, for a rough idea, it is 1 gram of alcohol is equivalent to around 1.5 ml. It is said that alcohol-related cirrhosis, is inversely related to the educational status. And the more we are educated, the chances of developing cirrhosis, we feel, is less because, we know what type of alcohol is to be consumed. Rather than the desi daru, which has been taken over, the people who are uneducated. जो आप daily paper में पढ़ते हो कि आज there was a lot of spurious alcohol causing death and other things, in the daily routine. So the commonest drink in our country, which we all know in an educated group, is a scotch or a whiskey. And there is nothing called a median alcoholic number of drinks, or the drink which has got what. But it is said that the indigenous alcohol is the one which causes most of cirrhosis. The number of things, which have come up, and we always say a guy has gone alcoholic, banda beoda ho gaya. It's not so that. The thing is that, we basically, should not use such a rough terminology, and idea is to use a terminology which should not be harming the guy's sentiments also. So, the term has been coined as alcoholic use disorder. That is, if you get a disorder, it is all because of the consumption of alcohol and nothing else. So, identifying the things, there are different questionnaires, which has been taken over by the psychiatric associations, both in India and abroad. And the most common thing which we all know about is a cage questionnaire, where we really have to think about the need to cut down drinking, a guy, whether he really gets annoyed when being criticized for drinking, whether really a guilt comes up or not, about drinking, and a thing called eye-opener drink. Friends, I think you all know about what is eye-opener. It means a guy when gets up in the morning, his first craving is to have, a peg of alcohol, so that, he feels good and comfortable in the mornings. The other questionnaire which came up was an audit one, in which an alcoholic disorder was basically because, we needed to identify the alcohol abuse. And the most efficient one is the audit C criteria, where basically at least, one need not diagnose it, but you can do a formal assessment. So not to, bugger you, Paul, a thing about what is heavy drinking. If a guy takes more than 4 drinks a day, or maybe 14 drinks a week, it is considered to be heavy drinking. In case of males, in case of female, of course 3 drinks a day or more than 7, that is almost half of the male counterpart. But nowadays, we keep on seeing, things are almost again getting inverse. Binge drinking is something, if a guy has a drink, more than 5 drinks in 2 hours, followed by, the other drinks which are coming up. So the term was coined, from alcohol abuse, to alcohol use disorder, and of course, this can be classified as mild, moderate, and severe. So different tables, came up, and different questionnaires came up in the form of cage questionnaire, in the name of audit questionnaire. Multiple things are there. I don't think, I need to go into the details about it, as time won't permit about that. And the most important thing is that one should consider a drink to be a drink, whether it's a glass of wine or a cocktail, or a hard scotch or gin or whiskey or vodka whatsoever. these things, can definitely be classified as mild, moderate, severe, depending on the number of symptoms, whether the guy has got, a withdrawal symptoms coming up for craving of alcohol, or the alcohol basically, the dependence gets better after use of either a benzodiazepines or something else. So many things to be asked about, what is about the alcohol abuse, or the use of alcohol, the negotiation, the goal settings, which are important, the behavioral modification techniques, and of course, if a guy is really interested into getting better, then a self-help bibliography can be done. That is, a guy can be given, the educational materials where he can, really come up for his betterment. So other tables, which are there, I'll skip on those. Now, most important things, in such a case, if a person is already into alcohol or into a real dependence of alcohol, so definitely what is important is we need to have drugs on it. And what drugs basically are importantly being FDA approved are the ones, like acamprosate, disulfiram, which we all know, naltrexone, baclofen is the one, which has not been FDA approved, but in real practice, I think all my esteemed seniors and colleagues, will agree that is one of the most wonderful drugs, which have been used in the clinical practice. Topiramate, as was said yesterday, by some of our speakers, I would definitely say that, this is not a bad drug, though it has got a partial hepatic metabolism, but the safest drugs, I would again put up here is that the best would be acamprosate and disulfiram. Drugs for treatment of alcohol dependence in a patient who might develop a cirrhosis or may develop a cirrhosis, which is to be considered are to be the ones which are liver safe. That is lorazepam, oxazepam, and temozepam. Temozepam is of course not available in the country. And with caution drugs which are really good and to be used are chlordiazepoxide, clonazepam, alprazolam, and diazepam. Friends, all these, they act basically on the brains, and it really has to have, what we call as the brain adrenal axis. The drug which is normally to be used with caution and nicely in a person who is not into child C or more is naltrexone and disulfiram. Acamprosate is wonderfully good. Baclofen has got the metabolism through the kidneys, so not much of a defect in any manner. So an algorithm basically was coined that how much drug, and this is a clumsy slide of course, but one thing I would say that here the number of things, the drugs which are mentioned are the ones, which are need to be done. What we need to understand is the doses, we normally feel that our psychiatric friends have given us the doses, which probably might be much more and the person may be doped out, but not so. Chlordiazepoxide 25 milligram is equivalent to 1 milligram of lorazepam, 0.5 milligram of clonazepam, and 0.25 milligram of alprazolam. So we can go for a person on alcohol dependence to a dose of up to 75 milligrams of chlordiazepoxide a day, and an equivalence can easily be given to the patients. A word about harm reduction. If a person is basically addictive and has got a lot of addictions, we are not supposed to bring it out suddenly, a big barrier out there. These substances have to be scientifically tapered off. And the persons who have really developed what we call as an alcoholic liver disease, the idea is naltrexone is the best drug. In alcoholic hepatitis, that they are to be given what we call as a motivational enhancement therapy, and the drugs which are to be given is acamprosate. In alcoholic cirrhosis, again the drugs which is to be given, the best drug would be acamprosate, which is quite safe because it has a minimum hepatic metabolism. And the take-home message I would say here is, friends, that alcohol-induced psychiatric symptoms are usually being treated with acetabulum and carbamazepine. The cornerstone of an alcoholic dependence treatment is abstinence, and if a person really gets abstinent, for more than a month's period, then definitely the idea is the guy can be taken care of. The drug of choice is benzodiazepines. For sleep problems, the best drug would be zolpidem. Obesity definitely increases the risk of alcoholic liver diseases. And after a lot of ash, one can really think that you have to go for an ESLD, that is end-stage liver disease. And and last line I would say that all physicians into the practice, though we are gastroenterologists, we should know that we need to learn much about addictive medicine also, so that we can treat our patients properly, and rather than sending them, for psychiatrists' opinions directly to be doped down. And I stay here by saying that say no to alcohol. You have got one liver and one life. Thank you.
Thank you, Dr. P.K. Agarwal. Very nice presentation. Any comments from audience? Professor Chawla, please.
I'd just like to make one comment. I think what we should emphasize is that the easy part is the management of withdrawal. So with baclofen and benzodiazepines, getting the patients, in our practice especially, from the liver side of view. But I think the difficult part is keeping them off alcohol. So that part is without, and whatever drugs are used in the long term, I think without proper behavioral support, this counseling services, the family support, that has been shown that even the trials have said with camprosate, only in the presence of proper supportive services, it is effective.
What
and
I wanted to mention out here, sir, was that, disulfiram is being so easily used to attempts by people, and one should know that how to be used.
Yeah.
The idea behind is that in patients of alcohol dependence, one should not start disulfiram like drugs, especially for at least 48 hours before the guy has taken not even a single drink of alcohol. Because 48 hours of abstinence is very important to start disulfiram, otherwise you really get the side effects.
My point was the initial phase of managing withdrawal symptoms versus the later phase of preventing the patient from again
motivational therapy is very important. Motivation is very important. Thank you, Dr. Agarwal. We move on to the next session.
Practical thing. It is not easy to de-addict a patient who has come to you on repeated basis with repeated episodes of alcohol intake. Sometimes he comes with varicose bleed, sometimes he comes with encephalopathy. Irrespective of whatever counseling you do, 90 to 95% of these type of patients, they do not quit alcohol. This is a general practice. So where we are wrong, we are wrong because we are not sending this patient to the psychiatrist. Even we send them, they repeatedly come back without any de-addiction. Or the problem lies somewhere else. Maybe there is some problem in the gut, there is some problem in the mind. But what practical tips do you want to give so that if the patient comes to you, what exactly you do? We do counseling every time. We do counseling of the relatives also. And multiple times you keep on counseling, and some time of your maybe practice you say, okay, this patient probably will not quit, and whatever is the fate, then we accept that. Well, what exactly you do in your practice?
So normally, see, the idea behind is that we need to really tell them the bad effects of alcohol, which most of us know very well, and we try to get it. The only problem is that busy practitioners are not giving full time to the patients, counseling them properly. So we need to give them time, if you give time to your patients, definitely the idea behind is that behavioral therapy gives them some amount of counseling, the rest of it depends on the family circumstances and other things. The drugs, in fact, probably according to me comes next, and of course we need to have a holistic approach. Gastroenterologist is there, a physician is there, so also the family, and of course the need of a psychiatrist cannot be, thought of. It is very much important, a psychiatrist is really good, but they need to take a detailed history and then start that drug whichever is good. Like yesterday it was said that naltrexone is not a good drug, but as on date that is one of the best drugs which can really, if started, if the person is taking properly, then naltrexone from 25 milligrams to 50 milligrams a day continues for maybe 6 months, then good effects are taken, and it has been seen that these patients, they do reduce their alcohol consumption over a period.
Thank you very much. Next presentation is on management of disrupted pancreatic duct syndrome. Speaker is Dr. Shrihari Anikandi. Please.
Very good morning to this august audience. I would be discussing on the management of disconnected pancreatic duct syndrome in the next 10 minutes or so. And disconnected pancreatic duct syndrome is an extremely common problem that is present, but I think there is a general lack of awareness, or we don't seek for a disconnected pancreatic duct when we are dealing with patients with acute pancreatitis, and we have to be aware of how to manage a disconnected pancreatic duct. So what is disconnected pancreatic duct syndrome? It is basically the necrosis of the main pancreatic duct, leading to disconnection between the viable upstream pancreatic parenchyma and duodenum. So you need 3 essential things to call it as a DPDS. 1, there is a necrosis of more than 2 centimeters of the pancreatic parenchyma, because anything less than that is likely to lead to a stricture but not a complete disruption. Second, there has to be a viable pancreatic tissue which is upstream and which is able to drain the pancreatic secretions into this disrupted duct. And third, you should be able to demonstrate, though this is not essential, but if you are able to demonstrate a free extravasation of contrast through this disrupted duct, that is the sine Q norm. So how does a patient present? A patient with disconnected pancreatic duct syndrome usually presents with some of these sequelae, and that is when you realize that this patient has a DPDS, because usually you don't seek out for this in the beginning. The patient either presents with a refractory fluid collection, or an external pancreatic fistula if a drain has been placed, or internal fistula like ascites or effusions, or there is a history of recurrent pancreatitis. So these are the situations where you suspect that this patient probably has a disconnected pancreatic duct syndrome. So how do you diagnose? So in the initial stages of the disease, it is very difficult to pick up because the radiological changes take time to appear, and usually around the second week or later on the radiological changes appear. You will see a necrotic area. The investigations of choice are a CT abdomen or a secretin MRCP. You would see a necrotic area of at least 2 centimeters. There is a viable pancreatic tissue upstream. So how do you say it is viable? Because it is enhancing on an intravenous contrast, and you are likely to see a dilated main pancreatic duct upstream. This might be dilated or non-dilated. One important feature is that in a disconnected pancreatic duct, the main pancreatic duct usually enters the pancreatic fluid collection at 90 degrees. In non-disrupted duct, there is a chance that the collection is compressing. Here, the MPD would be at an oblique angle. ERCP is considered the gold standard. On an ERCP, you will be finding an obstructed MPD at the site of a pancreatic fluid collection, or you will have a contrast extravasation without any upstream filling of the pancreatic duct. The most common sites for a pancreatic ductal disruption are the pancreatic neck, because this is the area which is prone to ischemia because of the blood flow. However, ERCP, mind you, is not recommended for just a diagnostic purpose in today's era. It is more for a therapeutic purpose, because you can introduce infections into a sterile pancreatic bed and there is a chance of inducing pancreatitis. So as with all cases, management of DPDS relies on conservative methods, surgery or endotherapy. Now for DPDS, a conservative management is unlikely to result in complete resolution. Antibiotics and nutritional therapy, though, are important in all cases. Enteral is always better than parenteral nutrition, and there is no proven role of a somatostatin analog when there is a draining fistula. Now the surgical options are either resection or internal drainage. Internal drainage, you have options of a cystrogastrostomy, a cystogegenostomy, pancreatico-gastrostomy or a pancreatico-jejenostomy, or a fistulojejenostomy. The problems with resection are they often lead to endocrine or exocrine insufficiency because you're already dealing with a necrotic pancreatic tissue. So internal drainage is the preferred choice when you're thinking of surgery. But the problem with surgery is that it is often very challenging because there is a lot of ongoing inflammation. There are presence of collaterals in many of these cases because of splenic vein thrombosis, and there is especially a high recurrence rate when you do an internal drainage procedure which is surgical. So that brings us to endoscopic management of DPDS. So when we talk of endoscopic management of DPDS, the best choice of treatment depends on whether there is predominantly a pancreatic fluid collection that you are dealing with a DPDS, or there is a fistulizing disease which you are dealing with. Now, if it's an associated pancreatic fluid collection, this makes things easier for us. Now, to drain a pancreatic fluid collection, you usually have 3 options. One is a percutaneous drain. Second is a transmural drainage, which is endoscopic. And the third is a transpapillary drainage through a conventional ERCP. Now, a percutaneous drain, which otherwise is used frequently when there is no DPDS, in disconnected pancreatic duct syndrome, percutaneous drainage has a high risk of formation of an external pancreatic fistula. So this is not preferred when you have a DPDS. You should not go for a percutaneous drain. Sometimes you might use this. It might be indicated if you're dealing with a sick patient as a temporizing procedure, but not as a procedure of choice. Transpapillary drainage is also not recommended because it is very unlikely that you will be able to completely bridge the disconnected pancreatic duct, which is possible in only 9% of the patients. Moreover, you are likely to introduce infection in a sterile pancreatic bed, and the very small caliber of stents are unlikely to drain the necrotic pancreas. So mind you, DPDS occurs in necrotizing pancreatitis. In just interstitial pancreatitis, you are not likely to get a DPDS. So transpapillary drainage is out. So the best modality for a DPDS associated with fluid collection is a transmural drainage. So transmural drainage is either through plastic stents, or now that the lumen opposing stents are available. If you go in for a plastic stent, what we are basically doing with a transmural drainage is we are creating a iatrogenic internal fistula. So when you use a plastic stent, it is recommended that it be kept indefinite or as long as possible, because once you remove the plastic stents early, it has been seen that there is a recurrence of pancreatic fluid collection because of the DPDS, and this is seen in a very high proportion of cases, up to 38%. Long-term stent placement, the risk of migration is not very high, 15% over 2 years with a very negligible adverse event rate. A single 10 French stent might be good enough. It works as well as a double 7 French plastic stent, which is used in most of the centers. Now with the use of lamps, when we put in a lamps for a disconnected pancreatic duct with with a wand, it has to be removed at 3 to 4 weeks because there is a high risk of bleeding or buried stent otherwise. It is generally recommended to replace the SEMS with a plastic stent after removal, but there are studies which have shown that after lamps removal, the risk of recurrence is also not very high. It is only 9% as opposed to the removal of plastic stent. That is because the SEMS are longer, are wider diameter, and they do a complete drainage. One more additional advantage is you can do an endoscopic necrosectomy when you are using a lamps. There is also a hybrid drainage which might be required when you have large collections or extensions of collections with lot of solid debris. These work synergistically. We are using the transmural stent to prevent the EPF, and the PCD allows you to irrigate and aspirate the cavity. Okay, so if there is a fistula formation and there is no PFC, now this makes things a bit more difficult. Here the options are either surgery or some complex endoscopic interventions. Few of the interventions I would like to highlight here. One is by creating an artificial pancreatic fluid collection where you clamp the PCD if it has been placed in a fistula. A PCD is there, you instill you clamp the PCD, see if there is any collection, or you instill 100 to 300 ml of saline through the PCD and create an artificial PFC, and then under endosono guidance, you put in a guide wire and then dilate the tract and place the stent. There is outside in transluminal puncture where a percutaneous tract through the PCD is cannulated, and across that a TIPS needle is taken over, and you go near the stomach or duodenum and then puncture it and then put in a guide wire into the lumen, and this tract is dilated and then a stent is placed. This is done by the interventional radiology. You also have a pancreatico gastrostomy. This is attempted if you have a fairly dilated duct in the upstream pancreas. At least a 3 to 4 millimeter duct should be available. And here under endoscopic endosono guidance, you puncture the pancreatic duct, place in a guide wire, and then you can place in a stent across into the pancreatic duct. Okay. So DPDS is a common, but it is a very unrecognized or an unsought entity. A keen understanding of pathophysiology is important to treat effectively. Associated pancreatic fluid collections make the management relatively easier. Endoscopic management should always be preferred for such cases in DPDS. And DPDS associated with external pancreatic fistula often need complex endoscopic therapies or surgery. Thank you very much.
Thank you for exhaustive presentation. Any
excellent talk. I know it's a very difficult situation to treat. You only sort of pray that you got we had one patient, had a duct destruction in the distal part of the pancreas. We do distal pancreatectomy and got rid of it. That's the best situation you can do it. And otherwise, preparing a lamp stent is the best solution to these patients. That's the best way to treat these patients. Very difficult once you get the patient, but lamp is works in large number of patients. We had one patient, we had a same patient, who had even pancreatico fistula, did distal pancreatectomy and got rid of it. Thank you. Now we invite Dr. Pradeep Bhaumik to give a talk on coagulation liver diseases.
Good morning, everybody. Respected chairpersons and moderators, and my fellow delegates. At the outset, my sincere thanks to the CHBD organizing team for organizing such a member and for inviting us to attend this program. We know in our day-to-day practice, some of the simple tests are very important, like prothrombin time, INR, and platelet count. We really advise almost in all patients of liver disease this test, and sometimes it is to evaluate what is the coagulation status of the patient, sometimes only to diagnose the status of the liver condition, or that is the status of the chronic liver disease. And here I am to discuss mainly the coagulation issues, that is coagulation liver disease, fallacies in assessment and solutions. In a normal situation, in a normal individual, what are the coagulation components? There are three basic components. Once there is hemorrhage, platelets comes in action, that is the platelet phase or first phase or primary phase. Second comes the coagulation phase, that is the clotting cascade comes in action, and the third is the fibrinolysis. So these three stages works in balance so that there is no bleeding or no thrombosis and the system goes on. But what happens in liver? Because as we know, liver is the important organ of our synthesis of the coagulation factor, and it has a pivotal role in hemostasis by synthesizing all clotting factors except one Willebrand factor and natural anticoagulants as well as several fibrinolytic proteins. And liver disease results in complex alterations of all three phases of hemostasis, that is primary hemostasis, coagulation and fibrinolysis. So conventional coagulation tests do not fully reflect the derangement in hemostasis and do not accurately predict the risk of bleeding. And that's why in what we see in the ESL or ancillary liver disease, that in one side, if there is a high portal pressure, there is a chance of bleeding. On the other side, if there is a low portal venous pressure, there is a chance of thrombosis. In between, there is a balancing act what liver maintains even when it is failing or a patient is in a chronic liver disease. And this revalence hemoptysis is the most important factor in a patient of chronic liver disease. Though patient has all these complications or problems like deranged PTINR or platelet count, but patient maintains the hemoptysis. That is a revalence hemoptysis. Hemostatic alterations that occur in results in new balance within the between procoagulant, anticoagulant and fibrinolytic system. Because of the related deficiency of procoagulant and anticoagulant factors, the hemostatic balance is more precarious and may tip toward bleeding or thrombosis at any given time. And that is the cartoon for the procoagulant factors and the anticoagulant factor, and what happens in the liver disease, it reduces, but still balance is maintained. And what are the tests we can do normally, or what we normally do to see what is the status of the patient? The majority of the coagulation tests are aimed at assessing the patient's procoagulant condition only. Correct assessment of the bleeding and thrombotic risk in cirrhotic patient should take into account several aspects, which is sometimes not very much possible. Sometimes cirrhotic patients frequently bleed for non-coagulant reasons also. What are the primary hemoptysis factors like platelet count, bleeding time, platelet function analyzers, and newer tests like thromboelastography and platelet function assays are also equally important, but not available in most of the centers. What are the secondary hemostasis tests? These are prothrombin time and INR and activated partial thromboplastin time. What are the important, what are the fallacies in this test? What we do day in and day out? What are the fallacies? We do platelet count, but platelet count detects risk of bleeding only at extreme levels. Because if it is normal, probably it is not giving any idea, or it is reduced, that it is not giving idea regarding the bleeding status. Similarly, bleeding time is not important as far as the liver disease is concerned. Platelet function analysis is difficult. Thromboelastometry is not available in most of the centers, and platelet function as the thrombopenia makes the interpretation difficult. What about the secondary test? There is PT and APTT insensitive to plasma levels of the anticoagulants, thromboelastometry, no standardization of the parameters in cirrhotic patient. There is another problem. We do have a standardized level or method or a guideline regarding PT, INR and thromboelastometry in normal individuals. What it will be in a cirrhotic patient, that is not very clear. Similarly, for test for fibrinolysis, that is fibrinolysis markers in hemoglobin is also not very clear till now. So what are the difficulties in major investigations? Mainly it's just to say a few lines because we do only platelet count and PT, INR most of the time. And we have seen that platelet number and platelet function both are adversely affected. But in 76% of the patients of cirrhosis, although platelet count is rarely less than 30 to 40,000, the etiology of thrombocytopenia in liver disease is multiple. One is sequestration in the spleen, and second is there is bone marrow suppression by antiviral therapy, alcohol and folate deficiency, and third factor can be impaired hepatic synthesis by thrombopoietin is also important. And finally, platelet count less than 50 to 60,000 is usually can cause problem, but if it is more than 50,000, even in cirrhotic patient, it doesn't cause bleeding. PT-INR, conventional coagulation test PT-INR APTT do not fully reflect the derangement in the hemostatic mechanism. INR was not validated in patients with the liver disease. Patients with chronic liver disease have a more complex and less predictable coagulation profile. So at this stage, another important issue is this hemodynamic alteration caused by the portal hypertension, platelet dysfunction, renal failure, and bacterial infection. They may derange our so-called rebalance hemostasis. So what is the solution? There are newer tests are there, but which are again not available in most of our centers, like global test of hemostasis, global coagulation assays are now available. Thrombin generation test dynamically measures the total amount of thrombin generated during in vitro coagulation. And thromboelastography and thromboelastometry are now available commercially, and these are mainly done before the liver transplantation, not usually done in our routine patient evaluation. So there are some common clinical problems of coagulation in liver disease which we should know all. Assuming the spontaneous bleeding is always associated with the altered coagulation parameters. No, it is not. In case, particularly in case of variceal bleeding, probably it is not the altered platelet count or elevated INR is responsible for the variceal bleed, and it is the variceal size of the varix, it is the status of the portal hypertension, and the red sign on the varix is responsible for the bleeding, not the PT, derangement of the PT and INR. Similarly, believing an altered INR is associated with an increased risk of procedure-related bleeding, like if you are going for a biopsy or any extra hepatic surgery, most of the time PT or altered INR may not be responsible for any bleeding. Correction of thrombocytopenia, a prophylactic to decrease the risk of procedure-related bleeding, yes. If it is less than 30,000, it's fine, it is required. If it is more than 50,000, probably it is not required. Clinical relevance of altered coagulation parameters in acute and chronic liver failure, and this is one of the very difficult situation or complex situation where we do face a lot of problem, because if there is SCLM, we can have endothelial dysfunction and there can be thrombosis. On to the other side, one can have bleeding due to neutrophil activation, and SIRS or sepsis, one can multi-organ failure. So that is the problem with the multi-organ SCLM and coagulation dysfunction. Portal vein thrombosis and anticoagulant therapy was discussed earlier. Normally, if it is asymptomatic, anticoagulant therapy is not required. If patients are symptomatic, patient is having pain abdomen or any other signs of portal thrombosis, then it should be treated with the anticoagulant or heparin as per the requirement. But if patient is we are planning for a renal transplant, liver transplantation, one should go for this treatment. Hyperfibrinolysis sometimes may require, and sometimes treatment like tranexamic can be required for a hyperfibrinolysis situation like bleeding from the mucosa or puncture wound or cutaneous oozing. Managing active bleeding, again, usually for active bleeding like variceal bleeding, there is no role of managing PT, INR or coagulation profile or platelet count until unless platelet count is less than 30,000. Main treatment of active variceal bleeding is mainly a combination of vasoconstriction and endoscopic therapy. Transfusion is most of the time not required until the hemoglobin is less than 7 to 8 gram per DL, and FFP may sometimes be given, but in acute phase probably it is very difficult to give, Again, regarding the platelet, if it is less than 50,000, one can try for that. Recombinant factor 8A, again not available in most of the centers, I mean in smaller centers, but one can try, result is not very satisfactory. Prothrombin complex concentrate is a good hope. It has several advantages over FFP because amount is less, so one can use this molecule. And for bleeding prevention, it was for the treatment. Prevention of vitamin K is not being used nowadays. Platelet, as I said repeatedly, the thrombocytopenia, if it is less than 30,000, platelet transmission is required. More than 50,000, it is not required. Fresh frozen plasma is, we are using day in and day out, but result is again controversial. Thrombopoietin receptor antagonist, particularly for thrombocytopenia, yes, it is useful. L-Thrombopec is useful. It should be given 50 milligram per day for 14 days. It is a costly drug. One tablet costs around 2,000 rupees, but it can be used. Similarly, the second generation drug, Eva-Thrombopec, can be used for 7 days or shorter duration, that is 7 days. To summarize finally, a rebalanced hemoptysis is the key of the stability in patients with advanced liver disease, though less robustly than in healthy individuals. This can be unbalanced in either in bleeding or thrombosis by perturbing events like infections or acute kidney injury. Cirrhotic patient bleeding is generally portal pressure driven. Inappropriate clotting made evident by peripheral venous thrombosis or portal mesenteric thrombosis or portal vein thrombosis. Conventional coagulation test may not be very much hopeful or helpful, but global coagulation assay is a big hope for the tomorrow. There are no evidence-based guidelines for hemostatic therapy of acute hemorrhagic in liver disease. Thrombopoietin receptor antagonists like L-Thrombopec can be used, but we do really need more evidence with liver-centric investigations and management protocol in future. Thank you very much for your patient care.
Thank you, Dr. Bhomik, for giving a talk on such excellent on a complex subject. I think rightly emphasized, when patients, you get a case of GI bleed.
M.I.C.E. Can you? Yeah.
So when you're dealing with a portal hypertension problem, rushing to give a fresh frozen plasma, your platelet is not necessary. Better to treat the portal hypertension disease, the variceal bleeding, and rarely you have to give the FFP and the platelet concentration. Thank you.
Thank you very much.
May I ask a question, Dr. Pradeep? Excellent presentation, Dr. Pradeep. My question is, if the patient with cirrhosis has acute portal vein thrombosis, and this portal vein thrombosis is more likely to occur if you have an advanced disease. So if INR is more than 2, platelet count is 40,000, would you still anticoagulate? What is the cutoff beyond which you say no anticoagulation?
Sir, if patient is asymptomatic, usually most of the time they have found that 76% of patients.
No, symptomatic. Symptomatic. Yeah.
Yes, sir. In symptomatic, they should be treated. In acute cases, you can even give heparin, or in otherwise NUAC or anticoagulant can be used in patients with thrombosis.
Even if PT is prolonged, even if platelet count is low,
yes,
you can anticoagulate.
Yes, sir. You have to anticoagulate, but depends what you are giving. So if patient is in acute crisis, then we can go for heparin or low molecular heparin. And if patient is in a chronic patient, like we are preparing the patient for liver transplantation, probably we can use NEO. That is better.
Similarly, there are certain patients who have underlying coronary artery disease and they have cirrhosis also. And sometimes they have a coronary event. If the platelet count is maybe say 40,000 and similarly the INR is, would you like to use the aspirin or antiplatelet drugs in these type of patients?
Yes, sir. There is a very debatable question, but it is said most of the cardiologists believe if it is more than 50,000, we can safely use aspirin. Because if we do not aspirin, maybe the patient is already on stand. Or drug-eluting stand, we have to use aspirin or clopidogrel, whatever we do use, it has got action on platelet. If it is more than 50,000, yes. If it is less than 50,000, stop for some day. And if patient is on dual antiplatelet, use only one and raise it first to more than 50,000, then use only one, either aspirin or clopidogrel. Probably aspirin is better than the clopidogrel. Thank you, sir.
Now we invite Dr. Gaurav Chawla.
Thank you.
Hello, to give a talk on endoscopic management. Now increasingly we are seeing more GAVE. Maybe we have become aware of it. All patients with cirrhosis liver with anemia, presenting anemia, we find GAVE is a very important cause for anemia. And Dr. Chawla is going to tell us the management of these patients. Dr. Chawla.
Good morning, chairperson, good morning audience. At the outset, I would like to thank Dr. Arora sir for giving this opportunity. So, straight away, presentation is not moving. So, when we come to GAVE, as the sir told, we often see these pictures when we scope our CLD patients, when we scope CKD patients, when we scope autoimmune patients, patient with diabetes, patient with iron deficiency, anemia. On the left side is the honeycomb pattern, and on the right side is the watermelon pattern, which we come across. How this pattern helps, this is a small study of 16 patients followed for 2 years, and they found that patients with punctate pattern usually are seen in cirrhotics, and striped pattern are seen in non-cirrhotic patients, and usually this striped pattern bleeds more than patients with punctate pattern. Exact cause why this happens is not known, maybe mechanical stress, maybe abnormal antral motility, hypergastremia, associated hormonal imbalances, or vasoactive mediators, and 70% will present as iron deficiency anemia requiring transfusion. Around 13% may present with malignant, and small subset will even present with upper GI bleed, and sometimes we pick up routinely for varicose assessment, or we scope the patient for other reasons. And usually they are nothing but dilated ectatic capillaries, both in the mucosa and extending till the submucosa with microthrombi and minimal inflammation. If we manage, literature has done pharmacological studies with lot of agents, with thalidomide, hormonal therapy, bevacizumab, tranexamide, and they found nothing worked. Surgery for our patients, CLD patients, CKD patient, is a very morbid procedure, and usually they are not willing, and mainstay of therapy is endoscopic treatment. So first modality is argon plasma coagulation. Usually a forced APC mode is used, 40 to 60 watt, and flow rate of 0.8 to 2 L per minute is used. And what it does, it causes coagulation of the tissue surface using a high frequency electric current conducted via this argon gas. It's a non-contact ablation, and depth of penetration usually ranges between 1 to 3 mm. And usually in studies, 80% success rate is there in reducing transfusion requirements, but we should know that it requires multiple treatment sessions. And usually it has become the modality of choice in most of the endoscopic units because it's easy to use, safe, and everyone is familiar. But APC has the limitations. Coagulation effect rarely ablates the entire thickness of the lamina propria. For that, usually we require very high settings, 90 watts or so, which is not available. And there is always a problem of recurrence rate, 35 to 78.9%, and if studies have shown 1, 2, and 3 years, recurrence rate up to 50 to 65%. So some patients will have refractory cave which keep on coming up with anemia, and then we should think what we can do. Then second modality is endoscopic band ligation, which has been tried in literature. Usually distal to proximally, in a session up to 12 to 15 bands can be applied, and what band does, it causes submucosal necrosis followed by formation of ulceration and ischemic fibrosis. So if you see APC, we are just ablating the mucosa, but when we are doing banding, we are catching over submucosa and applying the band there. So theoretically it's a more sound as compared to APC if you see here. So this was a long-term follow-up of patients with GAVE after EBL study from Canada, 33 patients, and they found that recurrence-free survival was 88% at 1 year. But problem is, again, as the time goes by, recurrence rate went as high as 48% at 18.2 months. So this was a randomized controlled trial where they have evaluated both APC and endoscopic band ligation, and they found that EBL has decreased the number of sessions significantly, and EBL group had significantly small number of unit of blood transfusion than the AP, and there was no significant difference in complication. There is another RCT from Egypt, 40 patients, pediatric population of 2 to 16 years, 20 in each arm. They found that EBL group had significantly lower number of sessions compared to APC group, and EBL was superior to APC in terms of shorter procedure time, lower blood transfusion requirement, less hospitalization, and significantly lower recurrence rate. So again, systematic review and meta-analysis, 143 EBL patients with 146 APC 8 studies were there. So, and they compared endoscopic success and improvement in hemoglobin. Endoscopic success was higher with requiring few treatment sessions. Then they also found out greater increase in post-procedure hemoglobin, greater reduction in transfusion requirement, and few rebleeding events with EBL. So, is endoscopic band ligation a superior treatment modality? So, from Ireland, they did a retrospective study and brought with 117 patients with 161 APC procedure and 57 EBL procedure. They found that if they did APC at index required 5 subsequent therapeutic interventions. When they did EBL, they found only 2.9 treatment sessions, and this group had a mean rise in hemoglobin which was greater. So this was a systematic review and meta-analysis only of randomized controlled trials where EBL scored over APC in terms of transfusion requirement, number of sessions, endoscopic eradication, and recurrence of bleeding. So is endoscopic band ligation the gold standard for gastric enteral? So this was an editorial from Romania. They found that research as well as recent trend showed EBL is promising, but we need more prospective data to that tells us that EBL scores over APC, and if we can expand a good randomized control trial, then we may have a new gold standard in this. Now there is another concept of hybrid APC in which when we are doing ablation in submucosa, we can inject polytoconol, which is a sclerosant we commonly use for esophageal varices also at times. So we inject submucosa in the first sittings, submucosa was injected with polytoconol. Then after 2 to 3 days, remaining areas which were not ablated, that time they did APC. So this concept was from Japan and Hiroshima University. They did this technique for 15 patients and a good follow-up of 42 months, and they have very good outcome. Median number of injections was just 1.5 plus minus 0.8, and APC sessions also was decreased to 2.1 to plus 1, and no significant side effects. There is one more modality, radiofrequency ablation, which usually transmits high power energy in short bursts to ablate these lesions. And it usually gives a very uniform depth of ablation of 0.5 to 1 mm, and it involves superficial layer of the mucosa. There is a Halo 60 system, Halo 90 system, which ablates an area in which 1.2 centimeter, 1.5, 2.6, even 5.2 centimeter. But this radio frequency ablation is not available in India. So this is how it looks like. So usually Halo system came for Barrett's and they have used for APC also. So basically these systems were used only when APC was not working and was refractory. And so they found endoscopic success rate of RFA was good to the tune of 100 to 90%. And but studies are small. Numbers, if you see, number of patients in each group is very small. And there is a problem of recurrence rate with RFA also in this group, all small groups also 21 to 33% recurrence, and no major adverse effects with this technique is also there. So this was a study from United States where in their unit they used both APC and RFA in 81 patients, and they found that when they compared this cohort, both were effective, but both required similar number of treatment sessions, both similar procedure times and similar time between the sessions. No matter what treatment modality they tried, both had similar outcomes. To summarize, I think APC will remain the mainstay of therapy, but data for endoscopic band ligation is encouraging. We can definitely use for refractory cases, even can be tried as first line therapy in units where APC is not available. It's easy to perform, safe, and whatever literature we have, it has shown to be superior to APC in terms of hemostasis, treatment sessions, and recurrence. Now, hybrid APC also can be used when we are facing a case of refractory GAVE where we can inject polytoconol and then subsequently do APC, but we need more data for this technique. RFA technically better because we can give a uniform ablation with the settings, but not available in most, and we need in this field more high quality randomized trials where we have endpoints are clearly defined, when to give hemoglobin, what is the treatment success, and so when we call recurrence, and then we can have a more gold standard. Thank you.
I think we have started with APC, most of us do it. But recently you started doing band ligation, and I find you can cover more area with band ligation.
Yes.
APC is time-consuming process. It's extensive area.
We
And
are
I
doing-
think the results are very good. I think we shifted to EPL now rather than the...
So in audience, I can have a poll whether we are still doing, how many are doing APC right now for first line, and how many are started doing banding as the first line.
Dr. Chawla, one question. In refractory GAVE, any role of thalidomide, number one? And secondly, any sort of, in literature there is mention of cryotherapy for GAVE.
Yes, sir. So both, sir, none of the drugs have worked. Even thalidomide has not worked for GAVE. Or whatever drugs they have tried not worked. And among the endotherapies, sir, cryotherapy and NDYR laser therapy has not worked. Only these therapies have worked.
Gaurav, excellent presentation. See, these two things are not comparable. APC is primarily done for the lesion which are superficial and which cannot be sucked into a cuvette. It is only in the nodular GAVE or antral varices that you tend to band them. Routine banding is not usually recommended in patients with antral gastropathy or GAVE. You have to have a big varus which can be sucked into a cuvette, or it is a nodular in variety. Short of that, APC is the best answer. My question is, patients who are destined to have antral gastropathy or GAVE versus those who are destined to have varices, what is the difference in pathophysiology? Why is it somebody develops a severe GAVE, no varices, and vice versa? And secondly, maybe Shiva can answer that. If you eradicate esophageal varices, do you have more GAVE, or vice versa? If you eradicate GAVE, do you have more varices?
I think the pathophysiology of GAVE is not really related to portal pressure. There's something else happening in the mucosa that's probably related to hormonal or other inflammatory mediators that are working there. So the eradication of GAVE really doesn't affect varices, or the eradication of varices doesn't really affect the development of GAVE. The processes seem to be separate.
Autoimmunity feels like more for the GAVE when there is a chronic inflammation because of various factors. And I have seen patients of GAVE with celiac disease. And sometimes we may miss celiac because there will be iron deficiency, and we'll think because of GAVE. And 2-3 patients, even without doing APC, GAVE has been spontaneously resolved after stopping the gluten-free, all the gluten from the diet. So sometimes the underlying etiology in GAVE is very important, and sometimes we may miss. Because portal hypertension, we all know the causes. But we should always look for autoimmunity, and probably now, especially in children, celiac also.
Yeah. Now, my question was different, Shiva. My question is, in a non-cirrhotic, with not only GAVE, but even portal hypertensive gastropathy, does it get aggravated after eradication of the varices? You see, if it is GAVE alone without cirrhosis, then you look for other causes like CKD, autoimmunity.
So that's
but
exactly...
in established cirrhosis.
Anil, that's exactly what I was saying. GAVE is not dependent so much on portal pressures. So you have portal hypertension, you have PHG, you have fundal varices, you have esophageal varices. The development and their recurrence are independent of GAVE. So you worry in patients who have gastric varices, if you eradicate esophageal varices, what will happen to the gastric varices? There's a valid reason to worry. But for GAVE, that is not really an issue, because portal pressures are really not driving the formation of GAVE.
Can I just ask? So you put 10, 12 bands on a patient with GAVE. How bad are the side effects? Nausea, vomiting, pain?
So no, I think whatever I have also tried at times when we are faced with refractory GAVE, and patients tolerate the therapy very well. So some mild abdominal discomfort can happen, but otherwise in literature also complications both are same. And my personal experience also same. They will tolerate the EVL also very well.
I would like you to comment on Anil's remark that EVL is not necessarily a first choice. I mean, he was trying to say that it's only, but I would think, my perception is that it's equally effective, equally valid in all patients with GAVE. Would you?
Yes, actually, it's the capillaries which we want, and if we are doing APC, we are ablating only the mucosa. We don't know how much depth we are going exactly, and when we are sucking, we are already hitting the submucosa. So theoretically, EVL is the better choice, but I also use first line as APC, and whenever I am faced again, then I will go for EVL. But if everyone starts doing EVL and if we have a more data, then I think, sir...
Yeah, conceptually the evidence may not be there, but because APC came in first, but conceptually EVL is perfectly fine for all patients with GAVE. That would be my interpretation also.
Yes.
Do you have a sickness banding? How you do you band distally first and then?
Yes, yes. As I told, first we have to band distally and then come proximally, and in a session up to 12 to 15 bands can be placed.
Basically, two patterns, a stride pattern and nodular pattern. For nodular pattern, I think EVL is fine. But for stride pattern, I think APC is better. The last presentation in this session is interpretation of abnormal LFTs. Dr. Sudhanshu, please come and deliver.
Good morning. At the outset, I'd like to thank Professor Arora and his team for kind invitation. Today, my job is to talk about the interpretation of abnormal LFT. It is very common for us to see the patient with abnormal liver function test coming to our clinic in our day-to-day practice. However, it is we should bear in mind that this abnormal LFT can be due to simply physiological changes, like in pregnancy we can have raised alkaline phosphatase, or it can be due to non-hepatic causes. There are so many causes. It is sometimes challenging to evaluate abnormal LFT in a symptomatic patient, and in some cases, though there is normal LFT, the disease may be severe. Maybe we all agree that this liver function test is a misnomer because it does not evaluate the liver function every time. So this LFT, what we commonly refer includes biochemical tests like AST, ALT, alkaline phosphatase, bilirubin, total protein, albumin, and I'm sorry for the missing prothrombin time. While some of these tests do provide information about the liver function test, most of the time we use it to evaluate different liver diseases. So instead of liver function test, what we can use is these markers like necroinflammatory markers, synthetic marker, cholestatic marker, bilirubin as a multifactorial marker. There are marker of fibrosis and other tests like ICG-15 that can say the functional reserve of the liver before liver transplantation. Now let's move to the elevated transaminase. Why we need to see this elevated transaminase? Because it is associated with increased mortality and morbidity due to liver causes. The normal level is very difficult to define, and it is different in different countries and defined differently by different society. But however, 30 and 32 are regarded as the normal level. And there is arbitrary definition of elevation. Like we can have borderline, mild, moderate, marked elevation, but this is also not uniform in by every society. So if we get an ALT of more than 500, this is acute hepatitis. The most common cause of acute hepatitis in this region is the viral hepatitis. So we should know about the exposure history, prodromal symptoms, and if we do serological tests, then we can diagnose it. The next most common cause is the alcohol-associated hepatitis. Though alcohol-associated hepatitis, we have AST, ALT less than 400, but when it is associated with herbal medicine intake and if somebody is taking paracetamol or NSAID, it can be as high as 500. So diagnosis is most clinical. Besides these two, drug-induced liver injury and autoimmune hepatitis are the most common cause of elevated ALT more than 500. Now another situation is there where there is severe acute elevation, that is elevation more than 1000 IU of ALT, or if it is more than 20 times the upper level of normal limit. It's mostly due to acute viral hepatitis, paracetamol poisoning, acute bile duct obstruction, ischemic hepatitis. But we should also take into consideration that acute rhabdomyolysis can have this high ALT and AST. So if we see the pattern of very high ALT, so this is the pattern. So we can see that in ischemic hepatitis, the rise is very rapid and there is high rise and it comes to normal in few days. Similar is the case with cholelithiasis, where pattern is similar, but the ALT, AST is not as high as ischemic hepatitis. And in case of viral and drug, it increases slowly and also decreases very slowly. Now, to establish the acutely elevated aminotransferase, what we can see is that we can have clinical setting and lab finding, and then we can diagnose with some markers. Like if we have hypotensive episode, acute HCF, the diagnosis can be ischemic hepatitis. If the people are living in endemic zone, there is high risk behavior, it can be acute viral hepatitis due to A, B, C and E. If we have concurrent presence of different the diagnosis is negative for hepatotrophic virus and we have different symptoms. It can be systemic viral infection like dengue infection, COVID infection. If there is history of alcohol abuse, AST, ALT ratio more than 3, elevated MCV, then the diagnosis can be alcoholic hepatitis. If there is history of recent ingestion of some medicine or change in some drugs, then it can be DILI or even HILI in case of herbal medicine intake. And if there is serology is positive for ANA, asthma, elevated IgG level and this biopsy is consistent with acute autoimmune hepatitis, then it is AIH. So similarly, we can establish the diagnosis in chronically elevated aminotransferase in similar manner. If there is family history of chronic hepatitis B infection or high risk behavior, it can be chronic hepatitis B or C. If there is presence of features of metabolic syndrome and if we rule out drugs and autoimmune hepatitis, it can be MASL or MASH. If there is serology is positive for autoimmune markers, it can be autoimmune hepatitis. If there is history of alcohol abuse, high bilirubin, prolonged INR, it is alcohol associated liver disease. And finally, if there are history of taking methotrexate for a long time, amiodarone steroid, ATT, then it can be DILI. Now these are the commonest situations that we account for. This chronic mild elevation where the ALT level is less than 150 or within 5 times of the upper limit. Most of the causes are the chronic hepatitis B, autoimmune hepatitis, steatohepatitis, DILI, hemochromatosis, Wilson's disease, but there may be non-hepatic causes like hyperthyroidism, myopathy, Turner's exercise, and AST more than ALT is commonly associated with liver cirrhosis as well as AALD. Now moving to alkaline phosphatase, whenever we get abnormal alkaline phosphatase, we should inquire about whether it was done in fasting stage or not. And we should also consider different causes of non-hepatic causes of raised alkaline phosphatase. Certain tumor can give rise to raised alkaline phosphatase. There are isoenzymes available, but it is not readily available and not cost effective. So these are the most common causes of raised alkaline phosphatase like PVC, drug-induced liver injury, biliary obstruction, PSC and other. So how we evaluate? So if there is raised alkaline phosphatase, first we should rule out a physiological cause. If there is mild rise, repeated and better in fasting stage, and if it is high, then determine the source, that is by doing gamma GT or 5 nucleotidase. If it is normal, then it is from bone origin and evaluate for the bone disease. Then if it is abnormal, then it is from Hepato-Biliary origin as we should investigate. So first thing we do is Hepato-Biliary ultrasound. If there is dilated biliary tree, then we go for MRCP or ERCP. If biliary tree is normal, then go for AMA or antimitochondrial antibody. So if AMA is positive and normal USC or AMA negative abnormal liver parenchyma, then go for liver biopsy. So if AMA negative and normal USC, then assess the degree of elevation. If it is more than 50% elevation and if there is systemic feature, we should go for liver biopsy. MRCP or ERCP. If there is less than 50% elevation, then we can follow it and we can observe for longer period of time. So next, raised bilirubin. We have direct and indirect bilirubin, so there can be direct or indirect hyperbilirubinemia. Previously, it was regarded that 50% is direct and 50% is indirect, but now any rise more than 20% of direct bilirubin is direct hyperbilirubinemia, and jaundice is evident clinically when it is more than 3, but we sometimes tend to see less than 3, and which is not correct. So how we approach? If there is jaundice, so we will decide whether this is indirect or direct. If it is indirect hyperbilirubinemia, we have to check for the anemia. If there is no anemia, then it is Gilbert syndrome or Crigler-Najjar type 2 syndrome, which needs no treatment. If anemia is present, then we go for hemolytic anemia, and we know that there is hemolytic anemia due to red cell abnormality, so we can check for membrane defect, enzyme defect, or breakdown. So if there is direct hyperbilirubinemia, we should calculate R value. What is R value? This is the ratio of rise in ALT by rise in alkaline phosphatase. So it can be more than 5, 2 to 5, or less than 2. If it is more than 5, then it is hepatocellular. So diagnosis can be viral hepatitis, drug-induced hepatitis, autoimmune hepatitis, or acute biliary obstruction. If it is mixed, that is between 2 to 5, it can be alcohol-associated liver disease, drug-induced liver disease, viral hepatitis in later stage, or overlap syndrome. And if it is less than 2, then chronic biliary obstruction, granulomatous disease, and sometimes we can get it in sepsis and when the patient is taking TPN for the long time. So to conclude, ladies and gentlemen, the abnormal liver function test is common scenario encountered by physician in clinical practice. Although a misnomer, it can be used to diagnose various liver conditions. Stepwise approach along with clinical settings and other appropriate laboratory testing can lead to proper diagnosis. Thank you for kindness.
Thank you for excellent presentation.
It was nice demonstration. I wanted to add one more thing. Like sometimes cholestasis can present because of intestinal failure related fatty liver disease. And sometimes we don't give history that much importance that there is a chronic diarrhea. And we think that it is a cholestasis and it may be maybe autoimmune etiology or maybe fatty liver disease. And sometimes the cause is in intestines. So we had a very rare diagnosis post-COVID autoimmune enteropathy coming with 80% of hepatic steatosis with severe itching and cholestasis. So the hepatologist will work up on the autoimmune side and some polyps. So nobody took the duodenal biopsies. So sometimes the intestines itself will cause the fatty liver disease, and when we treated with the autoimmune enteropathy, the 80% of steatosis went to 8% without any other. So it may be sometimes the cause may be intestines also. Thank you. Thank you, sir. It was a nice demonstration.
It is well taken. Yes. In celiac disease also, we can have
hepatic steatosis.
So intestine is, as you told, that it is one of the important factors, and also that abnormal alkaline phosphatase, it can sometimes be due to intestinal cause. That I agree.
And in pediatrics, we order sometimes serum bile acids also, because sometimes there are adult onset progressive familial intrahepatic cholestasis. So if GGT is normal, not high, ALP is high, cholestasis, itching, sometimes we have to order serum bile acids also to differentiate whether it is PFIC or bile acid synthetic defect. Thank you.
Actually, the problem was I was given only 7-minute time. That's the reason.
Just to add, it was some interesting case.
Actually, I wanted to discuss something about ICG 15, which is not easily talked about, but because it's a time constant, I could not do it. Sorry.
Thanks for the nice talk. I would just like to add two things in your differential diagnosis. If you have a patient with abnormal liver functions and patient has high WBC count, always rule out sickle cell hepatopathy, particularly in areas where sickle cell anemia is very common, and the other will be Epstein-Barr virus infection. You might have atypical lymphocytes in these patients, but sickle cell anemia is very often missed in this differential diagnosis, so that should be considered.
Yes, thanks.
If there are no comments, we can close the session, and thank you speakers for excellent presentation, and thank you moderators for excellent conduct of the session.
Thank you all our speakers for such an educative session to start the day with. Moving on, the topic of our next session is Beyond the Scope, Advancements in Endoscopy Revolution. For this, as chairpersons, I would like to invite on the stage Dr. Sanjay Sikka, Indraprasth Apollo Hospitals, Delhi, Dr. Adnan Rafiq, Center for Liver and Digestive Diseases, Jammu, Dr. Ashok V. Kumar, KIMS Hospital, Andhra Pradesh, Dr. Lokesh Anand, Manipal Hospitals, Delhi, Dr. Kishan K. Khannal, Kathmandu, Nepal. And as moderators, I would like to invite on the stage Dr. Pradeep K. Gupta, Subharti Institute of Medical Sciences, Meerut, Dr. Harsh D. Sahani, Pediatrics and Gastro Institute, Dr. Rajneesh Verma, Deva Memorial Hospital, Faizabad, UP, Dr. Indranil Saha, Manipal Hospital, Kolkata, and Dr. H.S. Saluja, Deep Hospital, Ludhiana. I would now request the respective chairpersons to call on the respective speakers for their talks.
Okay, to begin session, the first talk is a debate on artificial intelligence in endoscopy. Are we ready for prime time? And the speakers for is Dr. Saurabh Pukewar, and against is Dr. Vikas Singla. So may we have the speakers, please.
Hi, good morning everyone. I'm Dr. Saurabh Pukewar, and thank you Dr. Arora for inviting me and for a wonderful event here. So I'll give you 5 reasons why artificial intelligence in endoscopy is ready for prime time. So my worthy opponent will try to convince you otherwise with perhaps videos like these where I try to tell you that AI will take over. So this is how robotics and AI will take over humans to create electricity or even kill humans in the future. But let me tell you, artificial intelligence is here to stay. So the first reason why AI is ready for prime time is there's a lot of progress in research and development. So if you see, the first landmark paper was from 2017 in Nature, where artificial intelligence could differentiate different lesions on skin with a high rate of success. It was better than average dermatologists and equal to expert dermatologists. And this has led to a lot of research in artificial intelligence, as you can see illustrated by this PubMed search, and also in artificial intelligence in endoscopy over the last few years. Several tools have come in the market from various companies with artificial intelligence tools in endoscopy, as you must have seen in most conferences where you meet the vendors. Just to go over some basic terms, we have CAD-E, which is for detection of polyps, and CAD-X, which is for diagnosis of the possible histology. The reason we care about this is because 25% adenomas are missed on colonoscopy, certainly very applicable to the Western world, but also in India, where we do see our share of polyps. It starts with the initial study showing that artificial intelligence can, in an excellent manner, detect polyps. And this has led to the World Endoscopy Organization position statement this year in 2023 that CHBD, which is detection of colorectal polyps, is likely to improve colonoscopy effectiveness by reducing adenoma miss rates and does increase adenoma detection. Not only that, but we can do polyp characterization with artificial intelligence, and this is a paper from 2018 looking at polyp characterization with very high accuracy rates, as you can see above 90% in a very short diagnostic time. Not only that, but we have AI for early esophageal cancer with 90% accuracy, for H. pylori gastritis with 95% accuracy, early gastric cancer 92%, capsule endoscopy 95%, cholangioscopy 90%, and ulcerative colitis severity assessment 90%. So the second important reason why a technology can be ready for prime time is clinical validation. So the technology has to work in humans. So this is the first randomized controlled trial from 2020. It's 700 patients allocated in AI versus non-AI with Medtronic GI Genius. And what they could see is clearly AI, there was a higher rate of adenoma detection, and this was especially relevant in small polyps less than 1 centimeter in size, regardless of polyp morphology or polyp location. Another randomized controlled trial, larger study, almost 1,400 patients, different AI use, iterative scopes, increase in 27% adenoma detections per colonoscopy. To put it all together, a meta-analysis of almost 4,300 patients, overall suggesting that artificial intelligence is better than standard white light endoscopy. And if you see in this meta-analysis, AI was better than humans for all polyp sizes and all the locations, right or left colon. Another meta-analysis here, now this is practically speaking, yes, we can detect more adenomas, but does it impact your surveillance intervals? Say of adenoma is missed here and there, and it suggested that there is a 2.9% increase in intense surveillance recommendations with the help of artificial intelligence. Now, how about real-world applications? Those were controlled studies. Some paradoxical findings. This is a retrospective study. They compared, not a great study, but they compared pre-AI colonoscopies versus post-AI colonoscopies. And what they could see is that after use of artificial intelligence, the polyp detection rate actually went down. The adenoma detection rate went down. And advanced adenoma detection rate also went down, but there was no difference in colon cancer detection. And what the authors found was the withdrawal time was shorter in AI procedures. So perhaps the colonoscopists were relying too much on artificial intelligence and forgetting that they have to withdraw the scope slowly and observe the mucosa carefully. Other studies, positive results. This is real-world application of CHBD, that's detection in endoscopy suites. This is from Singapore, prospective cohort study of almost 4,000 colonoscopies. There was no difference in procedure time, but increase in polypectomies when AI-assisted colonoscopies were performed. And this was consistently seen across in multiple studies. I won't show you all, but this is what was the finding. How about CAD-X, characterization of polyps? This is not as good as CAD-E, which is detection, but this is a prospective multi-center study where what they did was there was optical diagnosis made by experienced endoscopists, and then they used CAD-X for diagnosing with AI. Overall, there was moderate inter-observer agreement. Now you can see neither AI nor endoscopists are excellent at this. We are looking at the rates between 70 to 80%. In fact, expert endoscopists are a little better than AI in this. But then there's something interesting, concordance, where AI and endoscopists together were better than AI or endoscopists alone. And this has led us to believe that maybe we can look at augmented intelligence. How do doctors behave with AI? And this is a very, very interesting study where they actually studied this. They've thought of different biases when doctors are using AI. And over-reliance, where doctors completely rely on AI and ignore their judgment. Or under-reliance, where doctors do not trust AI at all and ignore the AI findings even when accurate. So these are the possible biases. And what they did was they considered two categories, expert and non-expert colonoscopists. they were given videos to review. Only CAD E for polyp detection, they asked them to characterize. And then they showed the videos 2 weeks later. Then they did CAD X with AI diagnosis and then said, what do you think about the diagnosis? Do you believe in AI or do you believe in what you think? And they aim to determine how humans interact with AI assistants. And what they could see is that endoscopists was certainly influenced by AI, but importantly, not erratically. So when endoscopists are looking at AI, they were influenced, but yes, in more cases when AI was correct. So when they had a doubt and AI confirmed it, that this is actually an adenomatous polyp, they said, yeah, fine. But when they did not believe it as much, but AI said it is an adenomatous polyp, they refused it. So AI and humans can probably work together, and we could have augmented intelligence where AI and humans is better than AI or humans alone. The next thing important for any technology to come of age is regulatory approvals. And FDA has actually approved, FDA, as we are aware, is a very strict authority, and they've approved the first device using artificial intelligence, that's CAD-E. And just a little briefing on how FDA does its clearances, and basically you have the lowest risk, which requires general controls, and moderate risk, which requires special controls, which is actually what AI fits in, and then highest risk, which requires high level of safety and efficacy. And the approval process is tough, and modifications require a pre-market submission approval. So this is fine for softwares, but not for artificial intelligence because it keeps evolving. And for that reason, FDA has also changed its rules to cater to newer technologies. So therefore, the regulatory authorities are also coming of age. And this applies to European Data Protection Supervisor, even our Indian authorities are taking lead. Last thing, second last thing here, I guess, integrating AI in clinical practice. This is evident. 87% gastroenterologists believe that AI will improve their performance, especially the younger gastroenterologists. And this is evident. This is news reports from India, Middle East, different countries. Even we are doing it at our center. And this is reflected by the performance of the pharma company which owns this AI with higher earnings consistently through the years. And lastly is the cost effectiveness, which is a matter of concern. Now, the thought is that with AI, you're increasing the cost for the healthcare system with more polypectomies, but reducing the cost with CAD-X, where you're finding the polyps which are hypoplastic. But overall, the cost reductions will take place because of cancer prevention with the help of detection of more polyps. So India, of course, we don't do it because screening colonoscopies are not cost effective, but this is data from models performed in the US, and basically they considered pretty much every factor that can be considered. And bottom line is what they found out was that screening colonoscopy with AI is cost effective in the American context, with reduction in 5% of colon cancer, 3% reduction in colon cancer mortality, and $57 per person reduction in cost. And this also was seen in Japan, so I'll just end my talk here. So AI is here to stay. There are different reasons I feel why so, because of research and development progress, clinical validation of AI, regulatory approvals, integration now happening in clinical practice, and it's cost effective, at least for screening colonoscopies in the Western world where it's done. Thank you.
We should first hear Dr. Vikas Singla before taking any comments or any questions. Dr. Vikas. Yeah, please.
Very good morning to all of you. At the outset, I am thankful to Dr. Anil for the kind invitation. There is no doubt that AI is playing a crucial role in our lives. We can download the Digi Yatra on our mobile, we can download the boarding pass on the Digi Yatra. Then we go to the airport, we just scan our face, and then we can have an entry inside. And that will save you around 15 to 20 minutes. So it's playing a crucial role. But there are other side of that also. So this is a automated car. You can see there is an accident. and then it's the interior view. You can see this is the driver. He is not alert. It's an automated car, and he is not alert, and the accident occurred, and he couldn't apply the brake on time. So there are pitfalls of AI also, and similar thing can occur in the endoscopy. So during endoscopy, if you are not alert, the accidents are bound to occur. So in this accident, if you see the detail of accident, the distance between car and the victim when detected by AI was 115 meter, and the time was 6 seconds before the accident, and when we will see the time, brake was applied at 4.7 seconds. So that much time was wasted. If it was a manual human driven car, the brake could have been applied at 6 seconds and the accident could have been avoided. So I think with the AI, the decision making can go wrong and it can lead to accident. So first we have to understand what is intelligence. Intelligence is ability to solve complex problem to make decisions which should benefit the situation. Like in our OPD, we analyze the situation, we make a diagnosis, that's all intelligence. And when the computer does it for us, it's the artificial intelligence. It's a branch of computer science that develop a machine which can perform a task which requires the human intelligence. And not all the machines are artificial intelligence. On the left side is a calculator, it just calculates. It cannot tell you about the profit or loss, so it's not an artificial intelligence. On the right side, it's a face recognition, it can decide. It will either let you go inside or it will stop you. So it's a taking a decision. It's the artificial intelligence. So there are two types of artificial intelligence. It can be either a machine learning or it can be a deep learning. In the machine learning, it receives the training data, it's built algorithm. So first we, for the machine learning, like in endoscopy, we can feed the pictures of polyps. Then it will, based on the size, shape of the polyp, it will build an algorithm and makes a decision. On the other hand, deep learning, there is a multi-layered algorithm and it thinks like a human brain. In machine learning, there is no thinking like human brain. In deep learning, there is thinking like the human brain. So this is the deep learning. When the data is fed to the software, then there is a hidden layer in which it will analyze the situation in the deeper manner. Like when we feed a picture of polyp, if you see the surface, if you see the size, so and then it will give a decision. So it's a deep learning. So if we compare machine learning, the deep learning, machine learning is a subset of AI, and deep learning is a more advanced type of AI. The machine learning requires a small data, deep learning requires larger data set, and it thinks like a human brain. It requires a longer training, and it's a more accurate. Now in the active intelligence in the endoscopy, we use the deep learning. So the examples of machine learning is the video recommendation. When we see the YouTube video, and based on the time we have seen the video, they recommend the next video. It's the machine learning. And deep learning is like Alexa and Siri. And this is another example of the deep learning. So it can create the highlights. So over the duration of 5 hour match, so the deep learning will see the face of the player. He will see the emotions. So when there are different emotions, he will capture that moment, and with that they can create the highlight. So one big issue with the artificial intelligence is the bias and the fairness. So the model decision depends on the data that has been fed to the software. The training data may be incomplete or unbiased if the not complete data has been fed to the software, and the performance can be compromised. Now coming to the AI in endoscopy, as Dr. Sora mentioned, there are two types of AI. One is detection, it's called CAT-E, and other is the differential diagnosis called CAT-X. On the left side, I think as of today, AI has a limited role in the clinical practice. It's not an essential tool. There is extra financial burden on the endoscopy unit. It's like a simulator lying in the endoscopy room, and we have invested on this. And it just provides the basic information in the endoscopy, and doesn't take into account any clinical input. It just sees the image and will give you the diagnosis. It doesn't take into account any clinical history, any clinical examination, and doesn't have any role in the clinical decision making as of today. And as it is not taking the clinical inputs, is likely to make errors. Like in patient with a mass in the head of pancreas, it can be an inflammatory mass or it can be a malignant mass. So if it's a patient has history of alcohol intake and high CA19-9, it can be more likely to be malignant. On the other hand, in the non-alcoholic, it's likely to be malignant. But the AI doesn't take into account the clinical inputs, so it's more likely to have error. So AI has been used in the endoscopy, US and the esophagus and the capsule. So I will be discussing in the endoscopy. Most of the literature has been on the endoscopy. So the literature is there, but mostly are the single center studies, retrospective studies, and they are based on the still imaging. But colonoscopy is a dynamic study, so study should be on the dynamic colonoscopy to have a better outcome. And the other limitation is it detects the smaller diminutive polyp. If we see detection rate is higher in the colonoscopy with the AI, but it detects just extra diminutive polyp, and we know in the patient with the diminutive polyp the extra risk of malignancy is only 1%. So even if you remove them, it's unlikely to prevent the interval cancer. It doesn't detect more larger polyp because they can be easily diagnosed without the AI. So this is a study, prospective study. We showed real-time prospective study, single arm study, 6 centers, and the mean polyp detection was 1.35 in the AI and 1.07 in colonoscopy without AI. The difference was not significant, and mostly the added polyp for the diminutive polyp, not the polyp larger than 1 centimeter. Only the polyp larger than 1 centimeter has a risk of malignancy. So there was no difference in detection of large polyp. And similar seen in a meta-analysis of randomized controlled trial. The extra adenoma detection was 6 to 15% across various studies. And again, polyp only up to 5 mm were detected extra in patient undergoing colonoscopy with the AI. And the withdrawal time was similar in both the groups. In the AI, it took longer time for the colonoscopy because more polyps were diagnosed and they were dissected during the colonoscopy. And when we see the data regarding colonic characterization, we see the accuracy is between 75 to 90%. I think the similar efficacy can be achieved without any software. We can do the NICE and the genetic classification, which is very easy, and we can have the same accuracy. So we don't require AI to get better than this. So if AI can give us result better than this, reaching close to 100%, we should use the AI. But right now the accuracy is only 90%, which can be easily achieved by using the other classifications. And this is the study regarding the interest of endoscopists in AI. We can see initially 83% of endoscopists, they have interest in the AI, and only 50% were comfortable when AI was diagnosing hyperplastic polyp. So their confidence in the AI was only 50%. And only 50% thought that it will lead to higher patient satisfaction. So neither the patient nor the doctor was satisfied with the AI, and they were worried about the cost of additional cost while using the AI. And again, there was a worry about the dependence on the technology while using the AI. Another indication is the withdrawal time. As Dr. Sora mentioned, it ensures the withdrawal time. Its recommended time is the 6 minutes. I think the stopwatch can be used to monitor the withdrawal time. We don't need any complicated software to monitor the withdrawal time. And it can also localize the site of slippage. Again, we don't require any software to detect the site of slippage. We can just push the scope inside, go beyond the site of slippage, and do the complete examination. Another role is in the endoscope AI in the EUS, and it was seen that in a focal pancreatic lesion with the EUS elastography, the sensitivity is 87%, specificity 82%. Again, this is similar to a skilled endoscopist. It's not different from a skilled endoscopist, not adding any extra information. So if it can detect inflammatory versus malignant in alcoholic patient, this can be useful, but in this condition, it's unlikely to be useful to detect the inflammatory versus malignant lesion. Again, in the esophagus, the problem is limited literature, and it's based on the still images. We don't have a data based on the dynamic studies. Other issue is the distraction of the endoscopist. We can see in this patient there is a lesion lying on the left side, but AI is focusing on the small diminutive polyp in the center. So endoscopist may just focus on the innocuous lesion and may miss the malignancy, which is in the other part of the field. So it can also lead to de-skilling of the endoscopy, which is a serious issue. So when the endoscopist is using the AI, he may lose the interest, he may not use the intelligence to diagnose the lesion. It can lead to de-skilling of the endoscopist, and the critical thinking of the endoscopist may go down, and it can lead to hampering of development of the new ideas. And another problem is the diagnosis. When sometimes there can be two different diagnoses. AI is not taking into the clinical inputs into the account. AI can have a different diagnosis and the endoscopist can have a different diagnosis. Like in pancreatic cystic lesion, it can be either a pseudocyst or it can be a cystic neoplasm. Endoscopist may say it's a pseudocyst because patient taking alcohol. AI may say it's a cystic neoplasm. So which diagnosis you will choose, endoscopist diagnosis or the AI? It's a real dilemma and it can have a legal implication. Another is the sometimes there can be a wrong diagnosis. Who should be sued? Who should be accountable for the wrong diagnosis? Is it endoscopist or it's a software or it's a manufacturing company who should be liable for the wrong diagnosis? So to summarize, I think as of now AI has a very limited role in the clinical practice. It can just diagnose innocuous small polyps during the colonoscopy. It may be useful for the beginners, but I think it's better to learn from the mentors and from the literatures. Again, it's giving very basic information, and it may have accuracy for differential diagnosis of polyps around 75 to 90%, but I think this can be easily acquired by learning from the mentors and the learning from the literature. AI is not using the clinical data to make a differential diagnosis. Clinical data is foremost. I think any diagnosis without using clinical data is prone to errors. And when there is a wrong diagnosis, who should be accountable? Still it's debatable. And I think in future, the AI should be focused in more complex situations, like in Barrett with dysplasia. So if the accuracy is more than 90%, only then AI should be used in the complex situation. Thank you very much for your patience here.
Thank you, Dr. Singla. It's a very interesting topic, and I'm sure, like me, everyone got wise by both the speakers and wonderful rebuttal. And I would request Dr. Mukherjee also to join. Any question from the audience, from the moderators?
I think Saurabh has to rebut.
Yeah. Yeah, you can.
Okay, I wasn't sure about the rebuttal, but anyway. So I think Vikas has made some very good points. I'd like to suggest a few things here. I think number one is the several, well, of course, number one, we have to be careful with technology because it's not 100%, right? I think if you look at numbers, it's all 70 to 90%. And experts are similar, 70% for polyp characterization and 90% in some ways. So I think what's important for all of us is to recognize that it's something that may augment your work. And I think that's very evident based on data, that it will certainly assist and help, yes, definitely more novice endoscopists than experts, but it's going to help. So that's number one. Second thing is you have to be careful with the technology because you cannot solely rely on it completely. And I think this will happen as we learn to use it. As all of us will have these tools in hand, we'll learn to recognize where to ignore it and where not. So we are still in early days. So that's two. And three is as far as the studies and the quality and everything else goes. In terms of the polyp detection, I think there's no doubt that it is superior. Polyp characterization, it's fine, but it's not fantastic, but it's not much better than an expert endoscopist too. But other studies are coming of age. Now, upper GI cancers, Barrett's, and I showed you so many other studies and data showing that it works quite well. Of course, those are early days because we don't know the real world performance of this. And the real world performance will tell us as to where they will really fit in. But I suspect that what is happening with CAD-E, which is detection of polyps, should probably happen with cholangioscopy or EUS over time. And that remains to be seen where it actually works. And of course, screening colonoscopies, whether we can do it in India or not, that's of course a government decision, and we can't afford at this point for screening colonoscopies for a population level. But regardless, for a private practitioner out there, I think in India we are not really trained very well because there are 2-3 factors. One, we don't sedate our patients oftentimes in a lot of centers. So therefore what it leads to is slightly inferior quality procedures with upper GI and colons, which are not as good when you sedate the patient, number one. Number two, your training programs in India are not training physicians and budding gastroenterologists to do a screening procedure, and that's not part of our training. So therefore, when a withdrawal in colonoscopy done in India is very different from done in the West. Because here, you are basically looking for macro lesions. You're not looking for those small polyps. And if you don't go behind the folds, go left, right, up, down, you'll not find them. So in these contexts, AI will be very beneficial because the eyes of the trainees are not, are not geared towards finding polyps. So AI will actually significantly increase your polyp numbers is my guess. We'll see the performance in India, what happens. But I'm sure Dr. Reddy is here. I know you guys are using a lot of AI. I would love to see what your experience is. But I suspect that will increase your polyps. Now, not only that, but AI actually is fantastic because I didn't show you in my presentation that you can actually see the quality of the procedure done. So there are now tools which will tell you for an upper GI, and especially in our context, we have a lot of upper GI cancers. AI can actually tell you if the quality of the endoscopy is done correctly. Means, did you see the whole esophagus? Did you retroflex? Did you see parts of the stomach? And that tells you if the upper GI quality was done well. Now, if you can have it in your suite, because we have some big centers and there are some junior doctors who are doing, if they don't do a good quality exam, it will be reported, number one. And number two, if the tools actually have good performance, then you can really do those upper GI cancer pickups and we can do more ESDs and save lives. So I suspect when these rules come into play, we'll have excellent quality, upper GI and lower GI, number one. And number two, potentially early detection of various lesions, and then eventually, hopefully, save lives by doing ESDs and reducing cancers. So I suspect AI has a lot of role to play. There are some things which are good, there are some things which are evolving, but it's, again, I think it's here to stay. So thank you.
I think the AI may be the future, but right now it's solving just the basic problems. So if it can, it can take into account the clinical history, and it can solve the complex situation like Barrett's esophagus with the dysplasia, or the early gastric cancer or pancreatic head mass. It may have a role in the future. Right now it has very limited indications.
I think there's a question from Dr. Anil.
I must congratulate both the debaters for an excellent debate. But at the end of the debate, I do not know whether I should be joining BJP-led NDA or Congress-led India, INDIA. So I need to be clear about it. And secondly, I like to differ with Vikas. I think if you want to skill the endoscopist in the beginning, so will not AI be de-skilling you? In fact, beginners should be given the training under masters rather than AI. Because if the beginners are put to AI, as you suggested, then their basic skill of retroflexion, looking behind and before and after fold will only disappear. If anything, AI should be offered to people who have already experted it so that they save time. They can compare their knowledge and their expertise in detection vis-a-vis what is the gold standard today rather than the beginners.
So that's the point I want to make. Expert don't require the AI. The accuracy of experts is as good as AI. And the beginners, I think they need the mentors and they have to read the literature to become a better endoscopist.
Okay, so I think it was a wonderful session. So we'll go to the next talk. Thank you. Thank you, Dr. Singla and Dr. Saurabh. Okay, so our next talk is on obesity. It's an endotherapy of obesity. We're still vying for its dutiful place. And the speaker for the talk is Dr. Saransh Jain.
Thank you. At the outset, I would like to thank Dr. Anil Arora and the team for giving me this opportunity. And the topic given to me is endotherapy of obesity, still vying for its dutiful place. I would like to cover this talk by mentioning the prevalence of obesity, the treatment options, the need for endoscopic therapies, results of these therapies, current status of the therapies, and what are the future prospects that we deal with. So when we talk about prevalence of obesity, we must understand that it's a pandemic and it's growing. And it is having increasing prevalence in India. Here we define obesity as BMI more than 28. The data from the obesity survey in India, National Family Health Survey 2019 to 21 was submitted and published in Lancet, and few findings came out. It has a massive socioeconomic burden. In the world, more than 2 billion adults, representing 44% of adults, are overweight or obese, and 70% of them reside in low-income or middle-income countries. India alone, with its 1.2 billion people, have a burden of 350 million people with obesity. What's more prevalent is abdominal obesity, which leads to furthermore complication. And obesity per se also has a lot of medical complications. It can have diabetes, hypertension, CAD, and increase the burden of these diseases. So we have a problem. We have a problem that is growing. What are the treatment options for that problem? When we look at therapies for obesity, we have lifestyle, medication, and surgical procedure. As you look from left to right of this graph, you will see that the efficacy of the procedures increase, but so does the risk profile. An endoscopy treatment can bridge this gap by providing more efficacy than medicines with a better risk profile than surgical procedures. So what constitutes endotherapy? It can be either intragastric balloons or bare house parts, or stomach volume reduction therapies like endoscopic sleeve gastroplasty, pose, or endonema. Here I would like to discuss endoscopic sleeve gastroplasty because it is offered in India and it leads to volume reduction of stomach by using a novel device known as Apollo endosuturing device. So what are the characteristics of treatment of obesity? It should be safe, it should be effective, it should be durable, it should be acceptable to the people and to the practitioner, and it should have favorable impact on comorbidity. Does ESG satisfy all these? I would like to discuss the results of MERIT trial, which is a prospective multi-center crossover trial, including 21 to 65-year-old obese patient with ESG or lifestyle modification alone. Lifestyle modification had a low-calorie diet and physical activity. The primary endpoint was at 1 year loss of excessive weight loss. So in ESG group, 85 patients had an excess body weight loss of 49% as compared to only 3% in control, with a total body weight loss of 13% as compared to 0.8% in control, with 80% having at least one comorbidity improvement. At 2 years, 70% of these participants maintained an excessive weight loss. So, and there were only 3 adverse events without any mortality, need for intensive care or surgery. So ESG is effective. But is it the holy grail? Have we found the holy grail? For this answer, we need some more data. When we look at number of bariatric surgeries in India, we find that from 2014 to 2018, the number of bariatric surgery increased, and there were 20,000 bariatric surgeries done in 2018. This is despite the fact that only 1% of eligible patients of bariatric surgery actually undergo bariatric surgery. And when we look at number of ESGs per year in India, we find that only 80 ESG in 2021, 120 in 2022, and projected 180 ESGs in 2023. When we compare it to surgery, not only we are doing less than 1% of surgeons what they are doing. So why this dismal picture? Why we are still vying for its useful place? The first factor is patient awareness. Despite high prevalence and associated illnesses, obesity is not considered a disease, especially class 1 and class 2 obesity. Mostly they reply like khate pite ghar ke hain, we don't feel like we are obese. They are ignorant of treatment options and the benefit of those options. They don't understand that even losing 10% of your body weight will lead to severe improvement in their comorbidities. They are fear of supposed side effect. What if we die? What if we alter a normal organ? And this leads to indecision on part of patients. Skill acquisition. Very few gastroenterologists or surgeons are performing ESG because there are no structured courses for it. The strategy has been watch a few, assist a few, and then perform a few, which might not be a good strategy in procedure which has technical nuances, and literature which shows that there is efficiency only after 35 cases and proficiency after 70 cases of ESG. Vis-a-vis in USA, there is a 1-year fellowship after advanced endoscopy where a person learns an ESG. Indian guidelines for patient selection, management and follow-up are also missing. Infrastructure requirement. The ESG procedure needs a specialized device, a double-channel therapeutic scope, and an Apollo and overstitch suturing system. It also needs a trained assistant and an OT and general anesthesia requirement. Obesity management is a dedicated specialty. When we look, it requires a multidisciplinary team. I alone as a gastroenterologist cannot do the obesity management. I need a surgeon, I need a dietitian, I need a psychologist, I need a physiotherapist. I need regular follow-up for lifestyle changes. And I also need a patient support group where I can address their concern and advise them regarding the management. Finally, the cost. For patient, this is an out-of-pocket expenditure because the insurance does not cover the expense. For the hospital, the accessories are costly. That is why the procedure has to be costly. So this creates a problem both for the patient and the hospital. So what is the future? There is a way forward, and not all looks grim as it seems. If so, recently endorsed endoscopic bariatric therapy. SGI has now created a special interest group on endoscopic obesity treatment with Dr. Rakesh. The objective of this group is to create Indian guidelines on patient selection, management and follow-up, multi-center collaborative data, especially Indian data, so that we can convince the insurance companies, collaborate them for coverage of this procedure, training guidelines and center of excellence development. To conclude, my dear friends, obesity is a growing pandemic with increasing prevalence in India. Endoscopic management of obesity is safe and effective treatment option for management of obesity, especially class 1 and class 2 obesity. And it addresses a large lacuna in management of obesity. Structured training, patient awareness and insurance coverage can increase the utilization of this procedure. I thank you for your patient hearing. We also have an International Diabetes and Metabolic Summit in 27 to 28 October 2023 in Hyderabad, where we can further discuss the management of obesity and the different therapies that are required for it. Thank you.
Nice talk, Dr. Jain. Any comment from the moderators?
Yeah. So you explained about ESG. So I'll like to know the role of endoscopic balloons. So we have a lot of balloons coming up. They are easy to insert and probably for 6 months or 12 months, and then you can remove them. So that is another good option for our patients. It's even less invasive than procedures like ESG that you just told.
So when I did not deliberately discuss balloons because we have had a lot of talks on balloons. Balloons have been there for many years now. New varieties come up every few years. But when we're talking about a balloon therapy, we are basically talking about a lifestyle therapy. Balloons are temporizing measure that can help you reduce the weight. Ultimately, your lifestyle changes have to occur for that weight to be maintained. Because once you put in a balloon, it is a foreign object, it has to be removed. Either you can remove it after 6 months, or now balloons are available which can be kept up to 1 year. But then you have to remove the balloon. After that, what maintains the weight is the lifestyle changes that have occurred in the patient during that 1 year. And if this is not followed, the patient invariably will gain weight. That is why it is important to understand that balloon is one part of a spectrum of management of therapy, which would include psychologist for eating disorders, physiotherapist and a dietitian for what to eat after the balloon has been removed, and patient support groups for their queries and management after and during the time of balloon placement. That is what will make you a successful balloon treatment rather than just placing and removing the balloon.
Balloons. Just wanted to ask you, we are placing this in a group where GLP analogs are equally effective. Yes. And with the advent of GLP analogs and better, do you think this will play the role you desire it to be playing?
Yeah, so very nice question, sir. And I am aware of the GLP-1 analogs, and the drugs are an essential part of management of obesity. But you can see as obesity is having multiple redundant pathways. So one of the 3 basic functions of human life is to eat, to reproduce and to sleep. And these three basic functions are governed by hypothalamus or the basic primitive brain. And that is very important to understand, that to keep them preserved, nature has made multiple pathways so that even if one pathway gets blocked, other pathways can take over. So all these therapies that are coming up will actually be complementary to each other. They will actually help each other and make sure that we maintain the weight loss that we have achieved, or we achieve the weight loss that we desire to achieve. That is why I believe that these are complementary and should be used together or sequential depending on the patient population that we are dealing with.
Balloons, I guess, have a lot of vomiting and all those problems. So how do you manage it?
So when we are putting in a balloon, we have to make sure that during the initial phase of placement, pre-operatively, intraoperatively and post-operatively, antiemetics are being given. And usually I like to give M.I.C.E, and apipritant is also a very good antiemetic that is being given. And we start them on a liquid diet for a few weeks. Then we move on to the semi-solid and solid diet. And we also tell the patient that you will have some sensation of fullness because it's a foreign object that is being placed in your stomach.
So I have one question. Now there is data that weight reduction, and particularly even in early compensated cirrhosis, also helps. So what is your experience the use of ESG in early cirrhotics?
So basically we have not done a subgroup analysis of patients who have early cirrhosis, but usually when we have F1, F2 fibrosis and without any varices, yes, we can do endoscopic sleeve gastroplasty. It's just that in the high grade varices, it's difficult for the instruments to go inside the stomach. We can have injury to the varices. Endoscopic sleeve gastroplasty causes weight reduction. Weight reduction improves the fibrosis and the fatty liver changes. That has been proven. So if you do in weight reduction in NAFLD, which has gone on to cirrhosis, cirrhosis improves. Even trial for balloon is available.
So why I'm asking the question, that there is also a study available which has shown that the bariatric surgery in cirrhotic can lead to liver failure also.
That is when you do malabsorptive bariatric surgery. So there are two types of bariatric surgery that we do here. One is a restrictive bariatric surgery, which is known as sleeve gastrectomy. And another is a malabsorptive bariatric surgery, which is a Roux-en-Y gastric bypass. So when we do Roux-en-Y gastric bypass in patients who have already a liver disease, then it leads to decompensation because the absorption of nutrient is also impaired. So when you are doing bariatric surgery in cirrhotics, you go for sleeve gastrectomy, and that leads to improvement in cirrhosis also. That has also been shown.
Excellent presentation. I wanted to add one more thing as a lifestyle medicine physician. We never talk on diet, and I feel that this is the time when we are talking on obesity. Now, vegetarian proteins, if the plant proteins we are having, then there are randomized trials. If we compare with the non-veg protein, it has an effect on major reduction in the fat mass in the body. So we should always guide the patient on even reducing the non-vegetarian diet, apart from talking about junk food and all, because there are a lot of studies and research going on that non-vegetarian proteins are not healthy protein when we are talking about weight loss.
So excellent point. The point here that probably ma'am is emphasizing is that the diet modification are an essential part of management of obesity. You cannot have a patient and tell them we have this procedure, we will do this procedure, you can eat whatever you want. That's a myth, that's a lie. You have to have lifestyle procedures, lifestyle modification for these procedures to work, be it any procedures.
Thank you, Dr. Sanaj Jain, for a wonderful talk.
Thanks. So next topic is future of therapeutic endoscopy. Are we venturing into the areas prohibited by nature? I request Dr. D. Nageshwar Reddy to please just talk for this.
Thank you. I'd like to thank Anil for this kind invitation. I've been asked to talk on a subject which is not very usual. It said that are we venturing into areas prohibited by nature. nature has done a fantastic job with humans. It's actually in the gastrointestinal tract produced a very nice barrier between the contaminated and non-contaminated areas, so that we as gastrointestinal endoscopists work in a contaminated area and gastrointestinal surgeons work in the sterile areas. So this neat compartmentalization was there till some time back. In 20 years back, Anthony Kallu and his group, Crazy Thinking Endoscopists, decided that they'll go through the stomach of a porcine model, enter into the peritoneal cavity and do a variety of procedures. So-called nodes came in. At that point of time, in our own unit, we had a patient who came with extensive anterior burns and had appendicitis. Dr. G. Rao is here. He and his team then decided that why not go through the stomach, make an opening in this patient, take out appendix through the mouth. So this was the first human nodes appendectomy that was done, and this created a lot of furore at that point of time, because we are doing something that is very unnatural, breaking the barriers of nature, going from a sterile area into an unsterile area, and produced potentially some problems that can occur. So this was the background with which we started, and in fact at that point of time there were several videos that came up like this, which showed that you could go through the stomach or rectum and then remove organs which you normally would do surgically through a surgical port. To some extent, there was limitations in technology to go forward, but it's improving further, and now we have reports coming in. For example, the Chinese are now routinely doing transrectal cholecystolithotomy, removing gallbladder stones, leaving the gallbladder intact there itself. They believe that it's nature's thing to keep it there. There's been some criticism among the surgical colleagues about this, but this is a large ongoing study now in Shanghai, where thousands of patients have been subjected to this procedure, and the follow-up has shown that these patients are not developing recurrent cholecystitis as they estimated. Again, something against our natural thinking. And of course, as endoscopists, they're also going against oncological thinking, again, nature's way of thinking. In fact, these are again early studies from China, where endoscopic full thickness resection of the tumor colon or stomach is being done, along with lymph nodal removal. So you see, all these things that were not in our natural way of thinking and are going out of the season. And then large against oncological studies going on to see if this can be done safely. So this gets us to this concept of third space, which came because nodes didn't progress much further. Chris Gustav and his colleague Sunyama from Rochester Mayo Clinic came up with this idea that they could create a third space in the GI tract. And what they did was they used carbon dioxide to create this third space and then do a variety of surgeries here. For example, the first space was the lumen of the intestines, second space was the peritoneal cavity, and third space was the small space between the mucosa and muscularis propria, third called submucosa. And a variety of procedures were created based on these early studies which came from Pankaj, who showed that in the canine model you can actually create a third space and then do a myotomy. In 2008, Harune did the first poem procedure, which took a long time. It took him almost 2 hours to do this poem procedure, which now has become the standard of care for patients with achalasia cardia. And then we have a lot of these third space procedures, which again are not what naturally you would think should be done, but are becoming more and more obvious. For example, in esophagus, you can do not only achalasia, but others. For example, achalasia now has become the standard of care. In fact, it used to be taught only for type 3 patients, now for type 1, type 2, for motility disorders with jackhammer esophagus, for esophageal spasm, everything is being treated in randomized control studies shown to be better than balloon dilatation or even better than surgical laparoscopic HLS techniques. We had the further dimension added with addition of nodes fundoplication, where in part of the poem, we actually bring the stomach fundus up and stitch it to the esophagus. Again, studies are trying to determine what are the true indications for this procedure and so on. Zenkas, we do a standard septotomy, but now I think more and more third space endoscopists believe that doing third space type of procedure, cutting the septum, is better. Again, studies are showing equivalence with the standard procedures, but this is something, again, going beyond. This is my colleagues who published this large series of patients with epiphrenic diverticulitis, which are very difficult to treat surgically because it requires surgical treatment which is very invasive. Endoscopically, you can even, now most of these patients have actually a disorder of myoelectrical disorder, so not only do a myotomy, but you can actually cut the septum also. Coming further down in the stomach, again we are interfering in an unnatural way. Refractory gastroparesis was treated surgically or medically, very difficult to treat sometimes, but G-POEM with M.I.C.E and all introduced in Johns Hopkins has now become the standard of care in some patients. You can actually do a tunneling and cut the pyloric muscle. But the most important thing we realize in these patients is to choose your patients very carefully, because if a lot of patients who come to gastroparesis, usually diabetics, and these patients can be treated medically. Some category where you demonstrate by endoflip or a nuclear scintigraphy or a EGG to have an abnormal gastric motility can be very effectively treated. Up to 80% of them can be treated with endoscopic therapy, and you can see the journey that has occurred in treating these patients from Botox injections to an 80% now effectiveness if you choose your patients properly for G-POEM. Submucosal tunneling is also being used for patients who have usually a muscle tumors in the stomach, either a GIST or other forms of rare muscle tumors. This has now become a standard procedure, so-called STER, which we are doing. And of course, for Hirschsprung's disease, you have the PRAME procedure, which is done to avoid very complicated repeated surgeries that are needed in these patients. So we have a huge impact by you doing these so-called unnatural procedures, which endoscopists didn't think were possible, using these so-called third space techniques. For example, intramural lesions, as I showed you, can be removed, and of course we have other indications as is expanding. You can take, now it's routine for us to take nerve and muscle biopsies by using this tunneling technique. You can get very good nerve biopsies in patients with suspected motility disorders. We can harvest stem cells from there, and I think more important, what's going to happen in future, a huge field that's opening up, is for us to go into this third space and put in stimulation devices. The whole gastrointestinal tract actually acts because of electrical stimulations. We can now put in this, already some early trials are there, electrical stimulators into this space, so that in all sorts of, even constipation could be treated by just putting these devices. Novel devices and equipment like better scopes, better imaging, better accessories are helping us, and in fact as the endoscopist approaches new horizons, its armamentarium is changing from primitive arrows to more sophisticated laser guns. I think this is going to be a major change that's going to occur in the next few years. In fact, the terminologies are also changing. We talk about ESD and so on, but now we have endoscopic muscular layer dissections, subserosal dissections, endoscopic full thickness dissection, and many of these are because we now have better techniques, especially closure techniques. My colleague Mohan is here. I think he routinely closes, he creates a lot of holes but closes all of them, so that you need not go for surgery. We now have good stapling devices. These staplers are now available. We attach the tip of the endoscope. You can actually use, if you're not as skilled as Mohan, you can still go in and close these openings using this device. Of course, we have full thickness dissection device. I think all what this has done is it has created the barrier between a surgeon and physician is completely gone now. We are no longer physicians or surgeons, but we are interventional endoscopists, and I think this is a new terminology has become firmly fixed. You can see the evolution that has occurred in this area from the surgical to medical. In surgery, it took almost 100 years to go from a simple HLS to lap HLS with fascial fundoplication. In endoscopy, it has just taken about maybe 15 years to go from a primitive first POEMs to more sophisticated POEMs and third space endoscopy, and the best is yet to come. Like Churchill famously said after the end of the World War II, now this is not the end, but it's not even the beginning of the end, but it's perhaps the end of the beginning. And I think the beginnings have finished now. We are going further on. I think more exciting things are going to happen. And my colleague, Dr. G.V. Rao, actually put this up, created this video to show what he believes is going to happen very quickly in near future. We can diagnose remotely now. Of course, we talked about artificial intelligence. We can directly remote this patient has an acute appendicitis. So hopefully a team takes off. Patient doesn't come to the hospital, goes in, and through using the notes procedure can go inside, remove gallbladder or whatever organs or appendix which is diseased. And you can see here going through the stomach, you can actually remove this. So this is not natural. This is not what endoscopists normally do. But with all the technology that's happening, and hopefully we could probably see it in lifetime. Thank you for your attention.
So, nice talk, sir. Any questions from moderators? Any question from audience? Thank you, sir. Thanks. So we close this session. Thanks.
Thank you all our speakers. That was quite a session. We learned definitely a lot about endoscopy and its advancements. So moving further, the topic of our next session is navigating challenges in endoscopic management. For this, as chairpersons, I would like to invite on the stage Dr. Sudhir Maharshi, SMS Medical College and Hospital, Jaipur, Dr. S.K. Mehrotra, Muradabad, Dr. Mayank Gupta, M.I.C.E. Super Specialty Hospital, Dehradun, Dr. Ashish Kumar Jha, Medanta Hospital, Patna, and Dr. Ankush Bansal, Joshi Hospital, Kapurthala, Jalandhar. And as moderators, I would like to invite on the stage Dr. Sameer Taneja, Synergy Plus Hospital, Agra, Dr. Naresh Agarwal, M.I.C.E. Super Specialty Hospital, Patparganj, Dr. K.K. Rawal, Prime Hospital, Rajkot, Gujarat, and Dr. Vijendra Kirnake, Acharya Vinoba Bhave Rural Hospital, Wardha. I request our respected chairpersons to kindly call upon this stage the respective speakers for the talks. Thank you.
So we'll start this session on navigation challenges in endoscopic management. So without wasting time, I'll invite Dr. Manoj Sahu to deliver his talk on post-transplant biliary stricture, the lesson learned over the last 2 decades. Dr. Manoj, please.
Very good morning, respected chairpersons, moderators, seniors and friends. I am extremely grateful to Dr. Anil and Dr. Ashish for this opportunity. We will be discussing very briefly on post-transplant biliary stricture, the lessons learned over the last 2 decades. Biliary anastomosis has long been considered as the Achilles heel of liver transplantation. Biliary strictures are the most frequently described complications. Different studies age high as 15% of patients after liver transplantation. Anastomotic is the most common 85% and non-anastomotic biliary strictures. Anastomotic stricture appear and more frequently seen with LD-LT compared to DD-LT, various studies 13 to 36 versus 5 to 15%. So what is important? Prompt and systematic evaluation of abnormal liver enzymes after liver transplantation surgery should identify biliary stricture at an early stage, because if you are delaying the diagnosis, the response becomes poor. Non-anastomotic strictures is ischemic type biliary stricture proximal to the anastomosis. Always proximal to the anastomosis, because anastomotic stricture happens at the anastomosis or within 5 millimeter of the anastomotic site. They are longer, complex, usually multiple, can affect both intra and extrahepatic ducts. Treatment response is worse than anastomotic strictures. Diagnosis and assessment. MRCP, CT or ERCP. This is a systematic review. 13 retrospective, 8 prospective studies. MRCP correctly diagnosed post-transplant biliary stricture with an excellent pool sensitivity of 95%, pool specificity of 90.3%. So evidence is in favor of MRCP as an acceptable diagnostic test for detecting post-transplant biliary stricture, and it's recommended to do an MRCP for the diagnosis and assessment. Functionally significant obstruction, FSO. Most LDLT recipients we may find narrowing of the anastomotic site in the absence of FSO. What is FSO? It is a critical obstruction at the anastomotic site that results in a clinically significant impedance to bile flow, which resulting of derangement of LFT and symptoms. So it is useful to use the ratio of the proximal duct diameter to the recipient duct diameter to signify FSO. Management. Early days liver transplantation, surgical revision of bile duct anastomosis was the preferred approach. More severe complication, retransplantation, tube insertion during creation of the anastomosis to prevent biliary stricture. If you see, there are various studies, one randomized trial, no difference in stricture development, higher complication rate, so it is not practiced now. Construction of biliary anastomosis over an internal stent. There are many complications, so which led to discontinuation of the practice. ERCP or PTBD as the initial therapy. Systematic review of 4 retrospective study, 1 multi-center nationwide study, 275 ERCP, 157 PTBD. The meta-analysis showed the adjusted odds of failure of liver allograft 8.47 greater for PTBD. PTBD, longer hospitalization, fewer procedures with ERCP, no difference in technical success or composite of adverse event between 2 procedures. So the patient advocate is ERCP, which favored ERCP. So there are different scenarios. One modality preferred over the other. ERCP when the difficulty for the caregivers to manage percutaneous strain, risk of dislodgement, multiple intrahepatic strictures in different hepatic lobes. So difficult for PTBD when there is lack of significant biliary dilatation, ERCP might be a good option. PTBD when there is difficulty in endoscopic access or increased risk of adverse event to anesthesia. So ERCP scores over PTBD as initial therapy of management of post-transplant biliary stricture. This is a study from India, a single center experience of PTC for biliary stricture after endotherapy failure. What they found of right lobe, right posterior sector transplantation, the graft is from right lobe, the chances of getting biliary stricture are more. So they found the PTBD success rate is 87%, the morbidity as high as 15%. ERCP, this is a retrospective study, 1585 liver transplant patient. The success rate is very good, 92%, and ERCP related mortality was 0% in this study. Whether to go ahead with balloon dilatation alone or a combination of dilatation followed with stenting. Balloon dilatation is less promising, 30 to 40% success rate. Combination is more effective, success rate as high as 70 to 100%. This is a balloon dilatation followed by stenting. Aggressive endoscopic dilatation and multiple stent. This study 307 patients. If you are putting more stent, if you see the success rate is excellent. Success rate is very good and very promising. Plastic or metal stent. Retrospective study 31 patients. A trend towards no difference in clinical success and adverse event. So success does not appear to be affected by various stenting paradigm in the long term. So whether to consider multiple plastic stent or a self-expanding metal stent as the initial therapy, because the AGA recommends putting self-expanding metal stent, so they are telling it is better compared to multiple plastic stent. This is a systematic review for RCTs, no difference in the rates of stricture resolution, no significant difference in stricture recurrence. So metal stent, fewer procedure, fewer days of achieve resolution. But what is expected, most common adverse event is stent migration, but what they found in the multivariate analysis, they didn't find any significant difference like. And this metal stent might be associated with post-ERCP pancreatitis, but they didn't have any report from any of the RCTs. So metal stent or plastic stent. So metal stent over plastic stents, multiple plastic stents for initial therapy, we have only low to moderate quality of evidence, but if there is intrahepatic biliary stricture, anastomotic stricture just below the hilum, we should avoid using metal stent. Several factors influence the type and number of stents like duration of transplantation, stricture location, length, expertise, etc. Endoscopy should and must consider all the factors before putting stents. Magnetic compression and anastomosis. This is a hybrid technique for resolving very difficult biliary stricture. The technique can be applied in completely obstructed or disconnected biliary system. This is the study of 12 patients which achieved a success of magnet approximation in 84% of patients. Altered forgot anatomy, we have various other options like laparoscopy assisted, balloon assisted or US directed in transgastric ERCP. Spyglass DS for management of post-transplant biliary stricture. 21 biliary stricture in this study, benefit of cholangioscopy seen in 78.9% of patients. If you see the image, that guide wire, we not able to negotiate the guide wire across the stricture, but with the spyglass, put the guide wire, dilate and put stent is feasible. Cholangioscopy guided steroid injection for refractory post-transplant anastomotic stricture. This is the report of 3 patients. Technical success 100%, no adverse event, mean follow-up 26 months, 2 patients are stent-free, another 1 patient required another session of dilatation. So treatment of refractory post-transplant stricture is feasible and safe. It can be considered where we are difficult in ERCP. Surgical intervention where ERCP, PTC fails. Surgical therapy now used as a salvage therapy required in 1% of patients, retransplantation when there is when the progress to gut failure. Antibiotics, systemic review, pool incidence is only 1.1%. So we don't have high quality data. It should be individualized. When you are not able to adequately drain the biliary system might be considered. The prediction of post-transplant anastomotic biliary stricture using biomarker. Single center retrospective study. What they found, the variables identified is total bilirubin at day 14 and alkaline phosphatase at day 30. So they found they are associated with development of biliary strictures. Asymptomatic biliary stricture, asymptomatic biochemical alteration, liver biopsy inconclusive of rejection and your imaging showing stricture, whether to wait or consider aggressive endotherapy. But we have considerable data, you are delaying treatment, the response will be poor. Stenosis recurrence, this is the systemic analysis, DDLT have less compared to LDLT. Future direction, we need to understand the natural history, risk factor of biliary stricture, classifying biliary stricture, tailoring therapy, optimal therapeutic approach for forgot anatomy, and role of US guided because the indications are expanding. Biliary stricture are a common adverse outcome of liver transplantation associated with significant morbidity. With increasing experience in LDLT in Asian countries, in India, there has been decrease in overall incidence of biliary complication. Clinicians are advised to retain a high index of suspicion, especially in the first year after transplant, and investigate all liver function abnormalities with an MRCP to allow early recognition. Managing post-liver transplant biliary strictures require a multidisciplinary evidence-based approach. ERCP as the initial therapy for managing biliary stricture, endoscopies to ascertain the full operative details of the biliary and liver anatomy before planning the intervention. Rendezvous, magnetic compression, and spyglass DS, USBD are options in difficult scenarios. Thank you very much.
Thank you, sir, for excellent lecture. Actually, post-transplant strictures are difficult stricture. We all know that it is difficult to negotiate wire in these strictures. So, is there any tips to negotiate wire in these stricture, any specific technique or any specific wire we should use?
No. Basically, post-transplant stricture again divided into early stricture and late stricture. Early stricture, they are telling this pathology probably inflammatory narrowing, and the late stricture probably because of fibrosis. If the stricture is diagnosed late because of fibrosis, then what you are telling difficult to negotiate the guide wire. So there is nothing like that, no study that which guide wire, one guide wire is better than the other, but you can always try to use a Terumo guide wire in difficult biliary stricture, and various studies now, so with the help of spyglass DS, you can able to find out the very tiny stricture and negotiate the guide wire across. But there is no study, but we use Terumo guide wire while putting, negotiate across the stricture. And second thing, if the stricture is diagnosed very late, it will be difficult, but early stricture. But if the patient is presenting a stricture very early, what they are telling, you should delay ERCP for at least 1 month post liver transplantation. After that, ERCP can be done and stenting can be done.
Thank you, sir. Any comment?
Dr. Manoj, sometimes it's very difficult to differentiate between true stricture and narrowing due to inflammation and edema. How to distinguish between them? Any tips and tricks?
So you should be very careful now. So what they're telling, MRCP is a good imaging, but many times you may not able to know that narrowing because of inflammation, narrowing because of some compression, and narrowing because of some stricture. But they are telling that FSO is, if the stricture is there, so there will be significant dilatation of the proximal duct. And if you compare between two, proximal duct dilatation and the distal duct likely to be less dilated. If the ratio is more than 1, they are telling FSO is significant. So sometimes it's difficult to differentiate between inflammatory narrowing or a compression due to some outside structure, but you need to depend on imaging. Imaging, they are telling MRCP is a beautiful imaging for this scenario. We should do a imaging, and many centers are following now this guideline of finding out FSO. But sometimes you might be diagnosing one narrowing. The narrowing might not be very significant. The narrowing might not be having some clinical effect on the graft. That scenario you can wait for some time.
And what is your protocol for antibiotics during intervention?
Antibiotics, what they are telling for peri-procedure or pre-procedure antibiotic, we do not have great data as of now. This chance of getting infection is around 1.1%. So antibiotic, what is the recommendation of different guideline? If you are not able to adequately drain the duct, drain the biliary system, use antibiotic depending upon the clinical scenario. Otherwise, antibiotic not for every situation, every procedure.
Thank you, sir, for your excellent talk.
Thank you very much.
So if there are no further questions, I am inviting our next speaker, Dr. T.S. Chandrasekhar. He will speak on when and how to determine the etiology of indeterminate biliary stricture. Dr. T.S. Chandrasekhar, please.
At the outset, I would like to thank Dr. Anil and his team for this wonderful opportunity and great gathering. I brings warm greeting from Chennai. And my topic draws important attention, indeterminate biliary stricture, how we can fix this problem. The more often we tend to think is the malignant causes for indeterminate biliary stricture, so we tend to operate or we tend to stent it. There is a case I just want to draw your attention, we have seen recently. Here came as a case of cholangiocarcinoma, and there were pointers for benign stricture, and he was treated with a steroid because IgG4 levels, and see the resolution of the stricture. This is an eye-opener maybe for the audience, where all the indeterminate strictures need not be malignant. You must think of other benign causes like iatrogenic, autoinflammatory or chronic pancreatitis, infectious, vascular causes. There is a nice study available. 20% of the cases may be indeterminate. In that 28% will be benign and almost 2/3 malignant. So it is our responsibility to fix the etiology for. I am very glad that Dr. Anil has chosen this topic. So we need to distinguish what are the challenges we have. Early diagnosis, and ERCP is suboptimal with the breast cytology and biopsy, which most of the centers we do first. So tissue need to fix it for malignancy, and we need to have a multidisciplinary diagnostic approach. This algorithm will tell you clearly if the stricture is, we try to do the ERCP, the breast cytology, intraductal biopsy. If this diagnosis is not fixed, then it's indeterminate. If it is a distal biliary stricture, and the choice will be endo-ultrasonography with the FNA. If it is a proximal, then we have to go for cholangioscopy. You divide it, both visual impression and the biopsy is negative. and visual impression alone positive, you go for the repeat biopsy. If both are positive, then you go for the proceed to specific treatment. If both are negative, wait for 6 months follow-up, no progression considered as benign stricture. There is some progression of the disease, then again go for the biopsy. And if you are very highly suspicious, you don't have to wait for all these things, straight away go for cholangioscopy. Now my lecture can be ended here. Now the thing is, I need to justify this algorithm. How do I do that? That means I have to define what about the clinical features, tumor markers, radiology, ERCP, US guided FNA-M.I.C.E, spyglass and various combinations. And then I will justify with the conclusion of this algorithm. The definition is at the lab testing abdominal imaging ERCP are not able to fix the diagnosis. 20% of the time it is like that, it is non-diagnosed, that is the definition. Clinical features cannot distinguish confidently this is malignant, including the imaging, and CA99 is not elevated in 100% of the cases. It can be elevated in non-malignant cases, and CA90, CA also can be raised in 30% of the, only 30% of the cholangiocarcinoma. Serum IgG4, you want to fix the diagnosis with the autoimmune cholangitis. It is not elevated in 30% of the problem. That means there is a lot of challenges out there. So ERCP based stricture, the stricture morphology can tell you some pointers towards malignancy, and I have written, this worded, but however, for further proceeding we need to have that tissue, very important, that is being a big issue here. Tissue sampling is the only preferred technique to confirm the malignancy. I think it's a very challenging problem and day-to-day clinician problem for this. So you take the breast cytology alone, sensitivity and specificity, biopsy. So we need to have a thing where specificity is to the tune of 100% and sensitivity also, the combination of breast cytology and biopsy. Now you may ask the question, sir, we are doing routinely ERCP. Can we improve our diagnostic yield? Balloon dilatation of the biliary stricture prior to the forceps biopsy improved the sensitivity from 40% to 71%. Post-brushing biliary lavage fluid can also increase the sensitivity. So these are the important things we can practice here. And here the future is going to come with the next generation DNA sequencing also, that mutations can be assessed and biopsy specimen. This is one, I don't know whether Nagi is using this endoscopic scraper. Instead of the routine biopsy, the scraper is useful, higher rates of sample and first line tissue sampling tool. This is going to slowly will take over our biopsy. I think we need to resort to those who want to diagnose maximum with the ERCP procedure. So this is the ERCP. Even though this technique has come with a great hope and hype, but you know that it's not very cost effective in our scenario. You can miss to 1/3 of the cases still in situ hybridization. Intraductal ultrasound also can improve the yield from ERCP alone and ERCP plus intraductal ultrasound. Again, we don't have the tissue diagnosis here. Sensitivity and specificity, you see that improves with it. If we have the facilities and expertise, it will add value to this further. And bile duct endomicroscopy, I think only one center is having confocal laser endomicroscopy. Again, the problem here is the inflammatory changes on the biliary epithelium. From the prior stenting, brushing, biopsy could affect this bile duct endomicroscopy. This is again a very important thing. So you do not again yield, even though it will give some features about malignancy. Optical coherence tomography, low intensity infrared light, that will give a cross-sectional image of the bile duct. Again, we need to have a larger randomized trials to say that OCT may be there. So overall what is happening is we need to diagnose with the biopsy. So it's spyglass cholangioscopy. Now the spyglass, the benign strictures appearance is there, and this is the malignant biliary stricture, cholangiocarcinoma, tumor vessels, you can see that. And if the tissue occurred under vision is better than, yes, it is better than taking ERCP brush and biopsy. There's a very nice study available from cytology alone. ERCP biopsy, spyglass guided biopsy, improve the sensitivity and specificity. Very good now. And visual impressions. I am not able to take the biopsy for technical reason or some bleeding. Visual impression alone. I think Nagi and Mohan had demonstrated the visual impression is very good sensitivity. Again, biopsy improves the sensitivity, the specificity also better. But for treating with the chemotherapy, you need to have the biopsy. Even though it's visual impression, give the guidelines or guidance to that. So there is a nice trial available. The single operator cholangioscopy guided biopsy, superior to ERCP, the biopsy alone, more precise tissue sampling, more number of biopsies 2 to 5, no significant difference between on-site and off-site, but only difference is the greater number of biopsies required for the off-site cohort, and air embolism you have to be very careful, and the spyglass cholangioscopy biopsy is the most cost effective, reduce the number of procedures. So whenever it's possible, we are not able to fix the problem with ERCP, go ahead with the second line investigation. And there's another study clearly telling about all the modalities, brushing, cytology, phase, ERCP, the spyglass cholangioscopy, the scopy with the biopsy is the most cost effective modality. Now US in IDBS again, this is a very nice, most important slide here. For the hilar growth, US is not that effective. For distal, US is very good. This is a very thing. So you are able to make it needle track seeding also there. So if you are planning for liver transplantation or major surgery, please do not go for, most of the liver transplantation program contraindicate preoperative USFNA if it is an indeterminate biliary stricture. And same section US ERCP has got better combination, cost effectiveness, and this is again very important. If you have a tight distal CBD stricture, indeterminate, and cholangioscopy position is technically challenging, so US will be better. Proximal perihilar strictures, it is away from the duodenal wall, difficult to take biopsy unless there is a mass lesions available. So the spyglass cholangioscopy guided biopsy for proximal stricture and US for the distal biliary stricture. This is a nice study to tell you that. Now it's time for me to justify the algorithm. Indeterminate biliary stricture, if it is the distal, US with FNA. If it is if it is the proximal one, both positive, visual impression and tissue, go for the further treatment. Both negative, 6 months you wait, no progression biopsy, some progress towards the disease, then you have to go for further sampling. Visual impression alone positive, try once more with the biopsy specimen. This is what I want to tell you. So ladies and gentlemen, now time to give the take home message. The evolution of IDBS is complex, evaluation, multidisciplinary approach, right diagnostic modality. Each modality has got its own strength and weakness, and consider if you have the facilities, the other higher modalities. Otherwise, cholangioscopy and US next step in workup. Selection of cholangioscopy in US as per the stricture location and availability of the local expertise. If surgery or liver transplantation is contemplated, US guided biopsy is contraindicated. Thank you very much for this wonderful opportunity.
Thank you, sir, for the excellent talk. Any comment by the moderator?
Yeah, TS, if you have both available at your center, intraductal ultrasound and cholangioscope, which will you do first? Number one. Number two, when you will say enough is enough and subject this patient to surgery?
Okay, if you, my choice would be ERCP first. If this negative, still thinking more in favor of malignancy, spyglass only. And I don't think we do IDUS and other things. This is, I have to complete and say, I will tell you the thing. Now, important thing is most of the oncologists, they like to have the biopsy specimen. IDUS with the ERCP can improve the sensitiveness and the specificity. but the only thing you don't have the tissue diagnosis. So I think the next line of investigation after ERCP, most of the centers we do ERCP first, and second is the spyglass cholangioscopy. The algorithm has totally changed now after the advent of spyglass cholangioscopy. Now those who cannot go for biopsy for technical reasons, spyglass cholangioscopy, that is the reason we will give importance to this, the visual impression. If you want to go for palliative stenting, you can go ahead with the palliative stent. I think the spyglass cholangioscopy is the most important.
And surgery?
Surgery, if it is operable, definitely the surgery is the first model. All these things we are aiming at only one thing, it is malignant or not malignant. If it is curable and operable. If it is not curable, then palliative procedure.
Yeah,
And most of the centers in UK, I don't know where I have discussed with some of the oncologists there and gastroenterologists, that the success rate of surgery is to the tune of 60 to 70%. But in Indian scenario, we see most of the time advanced cancer. We don't get that number of cases for surgery. Mostly they come for palliative procedure. But the message here is, don't miss the benign causes like autoimmune cholangitis, IgG4 levels will be there. That's the reason I showed my first picture there. We have treated and we shown the resolution of this stricture. Had we thought of malignancy and operated that. So do not operate the treatable benign causes. This is a very important message.
Yeah, excellent talk, TSC, as always. My question is, what is the trick to avoid infection? Because as much as a gastroenterologist, you would love to have a tissue diagnosis, including the need of oncologists to have a tissue diagnosis. It invariably gets infected if you do a spyglass cholangioscopy, because to have a good visualization, you need to put in a lot of water, and it is a one-way track. Water keeps on going in, doesn't drain out.
Okay. You do the spyglass copy, if it is potentially malignant, operable, you want to establish the diagnosis. If before spyglass itself you are very confident with the tumor markers, ERs, MRCP, eccentric strictures, then you have to be very careful with that. Second thing, during spyglass cholangioscopy, I think my colleagues will agree with me, Sandeep, that if you see no features of tumor vessels or tumor lesion, I do not proceed further. I will just take a breast cytology and come out. And I will be very, very, very stringent in putting the water into that. So my aim is just to get a visual impression. If it is tumor vessels are there, nodularity is there, then I proceed with the biopsy. And this is how I see that, and be prepared to place a plastic stent in case of cholangitis. If you are very, that is also very important.
Thank you, sir, for an excellent talk, sir. Moving on to the next topic. Topic is Advent of Poem for Ecclesia Cardia, the lessons learnt in the last 1 decade. I'd like to invite Dr. Mohan Ramchandani.
Good morning, and at the outset I thank Dr. Anil for giving me this opportunity. I think we have been doing this procedure since last 10 to 12 years now, and let's see what we have learned. Can we have the slides, please? Yeah. So let's see what we have learned in last 10 years, and of course the procedure has been there for 10 years. We have been experimenting with various technical variations. The assessment of reflux has changed. There are many difficult situations during POEM, and we have learned how to circumvent those. Newer devices and also the AI has come up a big way. This is how the poem has evolutionized, and you can see there in 1980 it started with open poem, and then there was a big gap when the poem was described, and subsequently we are now much ahead. This was our first publication, but subsequently we saw that a poem is not only effective in adults but also in pediatric populations, and also effective for long. Now this is a 10 years follow-up study which showed that the effect lasts for 10 years. So it's a very efficient procedure, and our unit have seen for more than 5 years that it is not only safe, effective and durable disease, the procedure, and it works very well. So this was about the effectiveness, and also now we have much more knowledgeable about the GE junction. Now we know how to play at the GE junction so that we bring the maximum effect and minimize the complication, because here we are not doing any fundoplication and we have to prevent reflux. Now how to prevent reflux, we have clearly defined the anatomy while doing endoscopy. Myotomy, you can do myotomy posteriorly at 5 o'clock, or you can do anteriorly at 1 or 2 o'clock, or do a 8 o'clock the greater curve myotomy. Now once you are doing a posterior myotomy, you come towards the lesser curve and you have to avoid these sling fibers. Now these sling fibers are important to maintain the angle of His. Now these are the two penetrating vessels which defines the border between the clasp fiber and sling fiber. So we are not supposed to cut sling fibers. If you do not cut sling fibers, the angle of His is not disturbed and the reflux is minimized. And these are the two penetrating vessels in gastric cardia. The left side is in the red, we have defined these are the sling fibers. On the right is the clasp fibers. Clasp fibers contribute to the LES pressure, while sling fibers contribute to the angle of His. So if you cut blindly posteriorly without defining these vessels, you are supposed to cause more reflux. And that is what we have also described. Unfortunately, in this study, we said that there was no difference, but I think more larger studies are required to say that. During our 10 years, we also defined whether to do anterior myotomy and posterior myotomy. And I said, if you are doing posterior myotomy and you are not careful enough, you may damage sling fibers and cause more reflux. But subsequently, there were many studies which said that, and during the later part of the studies, once this procedure was defined, that we do not have to go more deeper into the stomach, you have to prevent the sling fibers, the effectiveness of anterior versus posterior myotomy was same. Then we also learned about whether to do short myotomy or long myotomy. Now this is very important, because if you are doing a myotomy in type 2 achalasia cardia, let's say for example this is a patient, and if you do a very short myotomy, sometimes there can be return of the peristalsis. This may not be a true peristalsis, there can be a vague peristalsis. But if you are able to make this happen, your reflux rate will go down, your dysphagia score will improve. So why to cut unnecessary long myotomies? And that's what we showed in our study, that if you cut shortest possible myotomy, muscle in type 2 achalasia cardia, you achieve the best results. However, the longer myotomy are reserved for the patient who are type 3 achalasia cardia or jackhammer's esophagus, where we calculate the length of myotomy required based on our manometric evaluation, and we can do as long as 20 centimeter or 25 centimeter myotomy, starting right from the post-cricoid region up till to the GE junction. So this is how the myotomy length is calculated. So short myotomy is equal to long myotomy in early achalasias, while spastic segment myotomies requires longer esophageal myotomy. We have been working with many new devices now, including the EndoFlip. EndoFlip is a device which will tell us whether the relaxation is too much, which will relieve the dysphagia but cause more reflux, or is adequate, which can cause least reflux but adequate dysphagia relief. So there are certain studies going on to calculate this. We are using with bipolar devices. Now the monopolar device cause lot of collateral damage, but bipolar device are device which use less low voltage and are precise. So more bipolar device are being used. One of them is this speedboat. I'll not go into this video, but This is a integrated device where you can inject, you can cut, you can coagulate with the same device. There is no grounding pad required, and this allows least collateral damage because you are working in a situation where the muscle layer needs to be preserved, the mucosal layer needs to be preserved. If you use high voltage, you may cause damage. And look at without exchange, you can do the coagulation of the vessels. We are using much more now red dichromatic imagings, which are reverse of narrowband imaging. Narrowband imaging are more better to delineate superficial vessels, good in detection of early gastric cancer, early esophageal cancer. But once you are doing therapeutic endoscopy, you need to have delineation of deep vessels, and red dichromatic image tell us that there is a deep vessel, you should not cut here, or in a pool of blood, you can clearly delineate the bleeding point and pinpoint your coagulation. Regarding the reflux, I think a lot of learning has happened in the last 10 years. Initially, we thought there is too much of reflux, ranging from 70%, and at the time there was a editorial which said that we should keep a close watch on reflux because will reflux kill POEM? But subsequently we did not see many Barrett's or adenocarcinoma, and POEM shop, which was supposed to close by reflux, has not happened. And why it has not happened? Because we were not assessing GRD correctly, and we published a lot on this and showed that if you use an automated machine, you may over-diagnose the reflux, but if you manually evaluated the reflux, you will reduce the reflux rate to 30% because there are many reasons of esophageal acidification in aperistaltic esophagus apart from the true reflux. So if you can differentiate between true reflux and non-reflux acidification pattern, you will at least assess whether the patient has reflux or not. And there are many ways we can now reduce the reflux rate by not going too deep into the stomach. We calculate exact length of gastric myotomy, which is 2 centimeter. If you go too deep, you will cut these sling fibers. So that's how we calculate and reduce the reflux as far as possible. We are now also doing fundoplication, though it is very primitive. I will not go into the detail of this video. Dr. Reddy has already shown where you can go into the peritoneum and bring a fundal wrap. We do not have the proper instrument, but the technique is there, and we are waiting for proper instrumentation. Till that time, we are using EFTP, that is endoscopic full thickness plication device in patients who develop too much of reflux, and they can be managed very well. Same day discharge is now more commonly done in patients who are undergoing POEM because such a non-invasive procedure or minimally invasive procedure, we take help of patients' comorbidities, age, status of esophageal mucosa, intraoperative complication. If these are favorable, we discharge them at the same day. Moreover, the AI has been now more commonly used. In fact, it will definitely come up where you will have a real-time annotations by computer that there is a vessel, be careful, there is a mucosa, you don't cut there. And this is one of the video which is showing clearly that in real time you can see, okay, this is not working maybe, okay. This is a very interesting video showing the vessels in real time. You can see there is a animation there, and you are dissecting in this plane. You will not inadvertently block this, damage this blood vessel and cause too much of bleeding, or you will have a signal from artificial intelligence that there is a mucosa, and you have to be very, very careful at that place. So in fact, this was my last slide, and I tried to summarize my talk in that 10 years what we have done. We have started from just mere POEM, then we learned how to prevent reflux. We are now using many devices including red dichromatic imaging, bipolar devices, and so on. And inclusion of AI has also helped us a lot. And I think there's much more to come, and this procedure is here to stay. We have 10 years follow-up study showing 92% response rate, And I'll show you my last algorithm if that can be brought in, the last one. Okay, I'll go to, so this is the algorithm which we prepared for the recent publication, where we say that the poem has to be done posteriorly initially, prevent the sling fibers, restrict the gastric myotomy to 2 centimeters. So this should be the initial, and then wait for some time. Reflux assessment has to be done. 24 pH metry should be to carefully seen. True reflux, whether it's a non-reflux acidification. If there is non-reflux acidification, no need to do PPI or fundoplication. You have to wait and watch. You can consider doing endoflip, whether sometimes inadequately treated achalasia can also give rise to acidification pattern, and there you need a retreatment rather than PPI. But if those patients who are really reflux, they are problematic, they are PPI dependent, they may be offered as laparoscopic fundoplication or device-associated fundoplication. With this, I'll end my talk, and thank you very much for your patience here.
Thank you, sir, for the excellent talk. Comments?
Sir, two questions.
Yes.
One is there any role of instillation of antibiotics in the tunnel after completion of the procedures? In literature, it has not been of any continuous use in your practice. Second, you say same-day discharge is now being practiced.
Yes.
So, starting patient oral diet, role of performing a gastrographin study before starting
Very important questions. And actually, in fact, when we first 2012, Dr. Inouye came to our institute, he used to instill some gentamicin. But subsequently, we realized it's like the Ganga gel for us. The last time we can instill, and it did not made any difference. So subsequently, we stopped that practice, and no more recommendation of instilling local antibiotic in the tunnel is required. And then second thing was same-day discharge. So we take lot of pre-procedural, intra-procedural events to decide whether the patient can be discharged same day. A young patient, no comorbidities, a procedure which went off very well, the closure is perfect. These are the patients whom we discharge, and moreover, the access to hospital is very important. If they are coming and going to Guwahati for 3,000 kilometers, we don't allow them, but if they can stay outside for one day where they can access back to us, they are these patients who can be allowed to go home rather than...
Mohan?
Gastrographin we don't do now. That again depends on how confident is the doctor who has done is the closure device, whether there were mucosotomies, whether the closure was, according to doctor, was good or not. If they have doubt or mucosotomies, we do, otherwise no.
Mohan, the literature is really confusing us now, because you said initially preserve the sling fiber. Now the recent publication from your center says there is no difference. So number one, and number two, how to tailor the gastric side of myotomy. If you do less, there is dysphagia. If you do more, there is reflux.
So there are very nice important studies from Pandolfono's unit who did endoflip during and post poem at every step, and they saw that if the gastric myotomy is 2 centimeter and if you add 1 centimeter, there is no difference. So you are causing more reflux by adding any centimeter above 2 in gastric myotomy. So 2 centimeter is the final gastric myotomy, has been shown in surgical literature also. So you have to measure this correctly by retroflexing and seeing the scope thickness and the amount of bluish discoloration which you bring by the comparing the scope thickness with that myotomy. So that is the best way. Or you have to use a 2-scope method, which is cumbersome because every unit may not have the pediatric scope which can go. But if your retroflexion way is the best way. And your regarding the sling fiber preservation, there is a strong theoretical background for this theory. However, we are not including many number of patients. It requires around 600 patients to be able to, but it's not possible. So all those underpowered study may give a wrong result, but till that time, we should always practice sling fiber preservation myotomy.
Thank you.
Can I ask a question?
Yeah, please. Go on.
So first of all, excellent lectures, and I congratulate you for established poem in our country, and we are also doing poem, sir. But sir, just like you have done, after 10 years, patients are coming. Some patients may be coming with must be coming with recurrence to you after 10 years of poem. So how you approach to such patient and manage the recurrences after 10 years? Sir?
Yes, Gaurav, God give me a blessing. How to treat achalasia, I can bring peristalsis back, I bring the LES relaxation and contraction back. But what we are doing along with surgeons also is a palliative measures, where we are disrupting the LES. Now once you disrupt the LES, there is bound to be fibrosis and there is bound to be recurrence. So one has to think why the recurrence has happened. So I take the help of a time barium swallow, esophageal manometry and an endoscopy. Sometimes there can be too much of reflux and patient may have symptoms. So you can diagnose whether the IRP has come down to normal. If IRP is normal, then you cannot do any mechanical thing. But if IRP is high, there is a stasis of food, then you can say that a mechanical intervention will help. So you can offer them either lap-Haller's myotomy or a redo POEM or a balloon dilation. In this situation, the data has shown the POEM is one of the best modality to re-intervene. But you have to work hard on what is the cause of recurrence and whether a mechanical intervention will help us or not.
Okay.
Yeah.
Thank you, sir, for your excellent lecture. As we are running behind the time, so we will have 10 minutes tea break and after that we will rejoin. Thank you.
Sorry, we are running a bit behind schedule. So we are having a 10 minutes short tea break for now. After that, we will resume with the session. Thank you. Welcome back everyone. I hope you have had a refreshing tea break. After this tea break, we will now be resuming the previous session only, navigating challenges in endoscopic management. And for this, I would like to request our respected chairpersons and moderators of the previous session to come up on the stage. Next in line is the lecture on asymptomatic gallstones to treat or not to treat in 2023. For this, I would like to invite on this stage our respected Dr. Sameer Mohindra to deliver this lecture. There is small housekeeping announcement also. Those who are going to leave today, kindly do check out before 12:30 p.m. from the hotel. Thank you.
Good afternoon. First of all, I want to thank Dr. Arora, Dr. Ashish and the whole organizing team for inviting me here. I have been asked to speak on a very important topic. Why this is an important topic? Because it is very infrequently discussed. Number two, with the advent of laparoscopic cholecystectomy, our threshold of treating gallstones have come down. And number three, there is so much of variation in incidence of gallstones in the world and associated complication, mainly we are bothered about gallbladder cancer, that there are no clear-cut guidelines. What do we mean by asymptomatic gallstones? Asymptomatic gallstones are gallstones in the absence of symptom, mainly biliary colic, or associated complication which can be acute cholecystitis, chronic cholecystitis, obstructive jaundice, empyema, and biliary pancreatitis. What we have to realize is almost 90% of gallstones are asymptomatic, and they remain same asymptomatic throughout the person's life. Gallstones are being increasingly diagnosed because of more imaging done for various indications, and with the advent of laparoscopic cholecystectomy, our threshold of treating gallstones have come down because it has been shown that laparoscopic cholecystectomy is with less pain, better osmosis, faster recovery, and quicker return to work. If you look at the worldwide prevalence of gallstones, there is a heterogeneity. If you look at India, the incidence of gallstone is between 5 to 22%. If you look at Far East, Japan, Korea, incidence is less than 5. If you look at Eastern Europe, it is comparable to India. And if you look at South America, incidence is higher than even in what is there in India. So there's a widespread variation of prevalence of gallstones in the world. Now, when we see a silent gallstone, see, what we are looking at, if we intervene, we are treating a condition in anticipation that it will cause complications. We are not treating any chronic or any debilitating condition which the patient is suffering from. So, are we justified? Now, there can be 4 options of treating silent gallstones. We wait and watch. When patient becomes symptomatic, we treat with cholecystectomy. We do cholecystectomy in all because we feel their chances of complications are high. And number 2, we do cholecystectomy in patients when it is indicated in a subgroup of population who have got a higher risk than normal of getting symptoms or complications. Now, when we see asymptomatic gallstone, we have to balance advantages and disadvantages. We have to look at the natural history of the gallstones, whether the patient has got symptom or going to become symptomatic or can have complications. And on the other side, we have to look at complications associated with surgery, whether it is morbidity, cost of treatment, and potential mortality. When an asymptomatic gallstone person comes, 4 questions need to be answered. Will the patient become symptomatic? Will the gallstones cause complication? Is there a possibility of a life-threatening complication like gallbladder cancer? And if the gallbladder has to be removed, when? Now, if you look at the natural history of gallstone, there have been many studies with a follow-up of as long as 15 years. Chances of getting gallstone-related biliary pain is approximately, maybe you can say 0.7 to 2.5% per annum. So roughly in 10 years, approximately 15 to 20% patients can have symptoms, that is biliary colic. And if you look at complications, complication rates are less than 0.5% per annum if the stones are asymptomatic in majority of the patients. And there have been long-term studies which have shown that. There is a recent article in Clinical Gastroenterology Hepatology where they looked at a retrospective cohort where had more than 22,000 patients and they followed up for more than 5 years. And there was a chance of getting symptomatic gallstone at 2% per year. And what they found was that as the duration of gallstones increases, chances of getting symptoms are much higher. And they try to make a model which tells that which are the patients who have got a higher probability of getting symptomatic gallstone. And what they found was a female, BMI of more than 30, chronic hemolytic anemia, multiple gallstones, dyslipidemia and tobacco use was associated with higher chance of getting symptomatic gallstones, and statin use was associated with less chances of getting symptomatic gallstones. Now this has been a study from Italy which looked at almost 800 patients. What I want you to pay attention is the group with asymptomatic gallstones, which were almost 580 patients, and a mean follow-up of almost 9 years. What they found was approximately 80% patients had no symptom related to gallstones. 10% had mild symptoms which recovered on conservative treatment, and only 10% had severe symptoms associated with gallstone which needed intervention. So what it basically suggests is that patient has got asymptomatic stones or patient had one episode of biliary colic. Majority of the patients will not have symptoms with complication related to gallstones. So if we do expectant treatment, that is patient is having no symptom related to gallstones, are we justified? If you look at this slide, majority of the patients will have a benign course. And if we do surgery, we are kind of over-treating. There are associated morbidity associated with the surgery and anesthesia. It's a huge load on our health system. India with a population of 140 crore, if 10% patients have gallstone, then we are looking at a large number of 14 crore who need cholecystectomy. Is it possible? In the present scenario, it's not possible with the healthcare system. And majority of the patients who get symptomatic gallstones or complications, they have previous episodes of biliary colic in majority of the cases. If a patient had biliary colic, then we can think about whether the patient is a candidate for surgery or not. And if patient has got advanced age, significant comorbidity, our threshold of operating should be on the higher side. Disadvantage, there is a definite risk of getting complications. And we know that approximately 20% patients become symptomatic in 20 years. Studies have shown that. And studies have shown that emergency surgery is associated with more complication, higher cost, prolonged hospital stay. And of course, there are subgroup of patients which I'll discuss who definitely are candidates for prophylactic cholecystectomy in presence of asymptomatic gallstones. Now, these are the standard indications of treating stone disease. Number one, if there's a suspicion of malignancy, if there's a polyp which is more than 1 centimeter, if there's a polyp 5 to 9 millimeter with associated stones, if there is a polyp with eccentric wall thickening, it becomes a candidate. Then you have porcelain gallbladder. All porcelain gallbladder need not be operated. If it's a focal calcification, if it's a punctate multifocal calcification, that kind of porcelain gallbladder is a sure shot candidate for surgery because chances of malignancy are much higher, more than 12%. Diffuse calcification porcelain gallbladder is not a definite indication of operating these patients. Then some ethnic groups, in the context of India, North Indians, asymptomatic gallstone with CBD stones, transplant patients, mainly heart transplant and bone marrow transplant, not solid organ transplant, and of course chronic hemolytic anemia, definitely there is an indication of treating asymptomatic gallstones. Relative indications, if a person is young, he says, I have a chance of developing gallstones in the next 650 years. I want surgery. It's a relative indication but can be offered. Calculi more than 2 centimeter, calculi small enough to cause acute biliary pancreatitis or biliary obstruction. Diabetes mellitus is a very soft indication. All diabetics need not cholecystectomy as of today. Difficult medical access is a relative indication. Patient may not have access to the medical system if patient becomes symptomatic. Post-bariatric surgery, majority don't need it, only biliary-pancreatic bypass, where gaining access to the bile duct may become difficult post-surgery. In the context of hemolytic anemia, definitely there is a case for treating even asymptomatic gallstones because they are diagnosed at a young age, they have a long life to live, chances of complications are much higher, and sometimes veno-occlusive crisis can mimic complicated gallstone disease, and of course emergency surgery associated with complications. Immunosuppression is a very important factor in post-transplant scenario. sometimes symptoms difficult to pick up, increased morbidity and mortality with any surgery in immunosuppressed people, and certain drugs like cyclosporine and tacrolimus are proliferative. But what you have to realize is all post-transplant don't need surgery for asymptomatic gallstones. Solid organ transplant, there is no case for doing asymptomatic cholecystectomy, only heart transplant and bone marrow transplant. And what you have to realize is that the surgery should be offered post-transplant, not pre-transplant. But chances of having significant morbidity is much higher if you operate these sick patients pre-transplant. So we need to wait for some time, get the patient stabilized, and do cholecystectomy. This is very important. Now the most dreaded complication is gallbladder cancer. India comes in a very high prevalence area, approximately 10 to 22 per 1 lakh population. If you look at the Western data, there is no indication of doing prophylactic gallstones surgery for development, so as to avoid gallbladder cancer, because incidence is very low. But if you look at Indian scenario, predominantly dendritic belt, India should be divided into North and South. South behaves like the Western world, North behaves like South America. If you look at the incidence of gallbladder cancer, it is 10 times higher in North India. And incidence of symptomatic gallstones is also 20 times in North India as compared to the southern part. And we all know that gallbladder cancer is associated with very poor prognosis, less than 5% 5-year survival rate. The reason is, majority of these patients, I missed one slide, sorry. Majority of these patients are picked up at a very late stage. This is a study by Dr. Yogesh Gupta group where they looked at 635 patients. And what they found was almost 80% patient came in stage 3 and stage 4. And survival was very poor. What is the problem with gallbladder cancer? Gallbladder cancer is we don't have a very good surveillance method. We can't look at the gallbladder mucosa like we do in luminal pathologies. Number 2, there are no molecular markers. Radiological markers or radiological findings are very non-specific. When we look at the gallbladder risk factors, we need to identify certain risk factors which we need to pay attention so as to advise the patient. If there are multiple stones, if there are large stones, if patient has got a high BMI, if patient is a carrier for chronic typhoid, typhoid and paratyphoid, and if patient has got H. pylori infection. So these are some of the risk factors which we can tell that these patients are more predisposed to potential gallbladder cancer evolution. This is a study from AIMS group, Dr. Pramod group, where they looked at normal people versus patients who had gallbladder cancer, and the various risk factors were if they are living in the Gangetic belt, if they are having more consumption of tea or coffee, tobacco use, and family history of gallbladder cancer. So these are some of the risk factors we need to keep in mind before advising these patients. Cholecystectomy, standard of care for last 100 years, very safe surgery, no doubt about it. But what we have to realize is that it has got significant morbidity. If you look at laparoscopic cholecystectomy done in symptomatic patients, duration of surgery is much higher, significant morbidity more than 4 times, and mortality is not significantly less than 1.5%. But what we have to realize is once bile duct injury happens, the mortality is 4 times, though it percentage is 1 versus 4, but these patients are more prone to have lower survival. If you look at the safety, majority of the centers have got very good results, but it can't be extrapolated everywhere. These are the best centers in the world with very good results. And it's not only bile duct injury. There are other complications also associated with laparoscopic cholecystectomy, which I have mentioned. So we need to keep these in mind. And it's not only the learning curve. It's a concept that most of the bile duct injury happens when the surgeon is not that experienced. No. In US, almost 1/3 of lap cholecystectomy related injuries were after 200 cholecystectomies. It can be because of inflamed gallbladder, it can be because of impacted stone, it can be because of M.I.C.E, it can be because of cystic stump stone, it can be because of anatomical variation. So it doesn't mean that if the surgeon is experienced, he or she may not have an injury, bile duct injury with laparoscopic cholecystectomy. And what you have to realize is even if you do a repair, the quality of life is not perfect. If you look at long-term results, 70 to 75% patients are well long-term post-hepatic angiostomy. This is a very interesting questionnaire-based study from our center where Dr. V.K. Kapoor looked at the experience of the surgeon and bile duct injury. And what you can see that 15% of surgeons had first bile duct injury almost 10 years after their practice of cholecystectomy. And 40% patient had their first bile duct injury after 100 cholecystectomies. So these were almost 300 patients and all leading surgeons. Now, what is the case for prophylactic cholecystectomy if we look at a high incidence area like India. There is a Chile study which looked at what is the probability of reducing the risk of gallbladder cancer if we do a prophylactic cholecystectomy. When they did an elective reintervention, their policy is more than 40 years, they give the advice of cholecystectomy. There was 70% reduction of gallbladder incidence in those patients, vis-a-vis selective screening where the reduction was only 20%. But my take is, what is the probability in India? If we advise prophylactic cholecystectomy, what is the chance that we will reduce the incidence of cholecystectomy? 1 in 100 cholecystectomy to reduce 1 gallbladder cancer, 70, 80, 50, nobody knows. There is no long-term data from India to look at what is the probability of getting complicated gallstone disease and carcinoma gallbladder. We don't have an answer so far. Second issue is, how do we follow up these patients? We do a 6-monthly follow-up or longer. What do we look at the follow-up? How do we do the follow-up? We do a lab parameter, we look at imaging, and if we are based on ultrasound, which is the easily available, is ultrasound a good modality to pick up early gallbladder cancer? Answer is no. Will the patient come for regular follow-up? It's very difficult to get 6-monthly patient throughout his or her life. And what is economics? Coming every 6 months, getting investigation done, logistically not possible. So this is Indian scenario. I'm giving you a scenario. 42-year-old multiparous woman came with asymptomatic gallstone. What should be the advice? She is more than 40 years, high incidence area, India, North India, multipara who are more prone to have symptomatic gallstones. What should be our advice? The same issues will come up. We don't have an answer. What I would say is, this slide basically shows the features which, if present in a patient, our threshold of doing cholecystectomy should be lower. If age is more than 40 years in India, maybe I'll give a chance to her to talk to the surgeon and discuss the pros and cons. Female, definitely higher chance. High incidence areas, India. Multiple gallstones, large gallstones. Duration more than 20 years, chance of getting symptomatic gallstone is more likely. Family history, clinical if there is new symptom or a worsening of existing symptom. And radiology shows irregular wall thickening, there's a mass lesion, there is M.I.C.E, cystic stump stone, impacted stone. There are higher chance of getting gallbladder cancer in future and difficult to pick up. So I would conclude by saying is that we need to explore the geographic and ethnic differences in natural history, especially in the context of India. We don't have long-term data. We need to identify subgroup of patients who are candidates for surgery for asymptomatic gallstones. We can't say that all stones should be treated with cholecystectomy. Availability of laparoscopic cholecystectomy should not reduce our threshold for treating these patients with surgery. There has to be a discussion between the surgeon, physician, and the patient so as to decide which patient needs surgery, and it has to be on a case-to-case basis, and we of course have to look at quality of life and cost-effective analysis. So I would conclude by saying that no more cholecystectomy for all asymptomatic gallstones. We need to identify subgroups who are more prone to get complications, and the complication which I am bothered about is gallbladder cancer. Thank you.
Thank you, sir, for excellent talk. One question, should we go for the, to assess the GB function for gallbladder function in all patients of asymptomatic gallbladder?
Function means,
GB functioning, non-functioning versus...
gallbladder empty?
Yes, yes.
No, it's not indicated.
Because one of the criteria we...
asymptomatic
and GB non-functioning.
Actually, non-functioning, I mean, what it means basically, if the gallbladder is contracted or non-functioning, then it's very difficult to pick up lesions inside. If there's a small polyp, if there's a small stone, if there is eccentric wall thickening, then it becomes a problem. The logic is asymptomatic or non-functioning gallbladder is more prone to develop stasis of bile. And it has not been proven, it's a concept. Chances of getting stasis of gallbladder, chances of getting infections are more likely, so that becomes a relative indication. But all asymptomatic gallstones with non-functioning gallbladder is not a clear-cut indication of undergoing cholecystectomy.
Samir, the common situation, sorry sir.
Yeah, Samir, nice presentation. If you look at the indications for cholecystectomy, they are ever expanding. It is like PM Modi's popularity in G20 all over the world. So you have increasing age, you have a gigantic belt, North India, larger stones, calcified stone, and I believe that smaller stones are more likely to produce complication. You said more than 40 years. I think 20 years is an indication. Anybody with young age, gallstones are likely to be operated. If you have such a wide spectrum of indications, then I like to ask Dr. Rao, then all the data which you have presented on injuries, that is in the inflamed or patient with diseased gallbladder. Do we have a data on asymptomatic gallbladder? Maybe they are cleaner, they are far better to operate upon with lesser complication.
Surprisingly, Dr. Anil, actually most of the bile duct injuries seem to have happened on clean gallbladders, not on difficult gallbladders. So I think the incidence of bile duct injuries is mostly seen on these patients who have clean gallbladders actually. So as on today, actually I am dead against operating on any asymptomatic patient unless and until even the relative indications, as long as they are not in the city, either away from the city, then I think we can take them. But as long as they're within the reach of the medical facility, I think we should avoid doing any gallbladder.
Absolutely.
Can I ask a question?
Should I also respond to the question?
Yeah. See, my worry is, I'll tell you, large gallstones you operate, small gallstones cause pancreatitis, more than 40 years you operate, up to the age of 20 years, so you are more likely to have complications. So what is left?
See, if you look at pancreatitis, you are bothered about acute biliary pancreatitis. Long-term studies have shown less than 0.5% risk per year. But I agree with you, if a person is 20-year-old, he or she has got 60 years to live, even if it is 0.5 to 1% per year, the risk is significant over her lifetime. But if you look at clear-cut indications, large stones, multiple stones associated with thickened gallbladder wall, definitely there is an indication. But small stones, it's a relative indication. I mean, it depends upon the patient as well as the surgeon.
Dr. Samir, it was a very nice thing. I have one question. You have a clear-cut definition of incidentally detected or symptomatic gallstones. We can leave that. Those who have a classical symptom, you can leave that. But a large majority get an ultrasound done because they have relatively non-specific symptoms. Postprandial bloat, upper abdominal distension. Now, quite a few of them, if they undergo surgery, if there has been an incident that they may have a chronic cholecystitis, how do you deal with these patients?
Actually, I removed this thing, vague dyspeptic symptoms are relative indication. See, the problem is you have to analyze the symptoms, because studies have shown 30 to 40% patients who are operated for vague symptoms, they get so-called post-cholecystectomy syndrome. Because the indication of gallbladder surgery was based on very poor analysis of the symptoms. If 1/3 of the patients get the similar symptom post-surgery, then you are not justified to offer surgery. Now, studies have shown that approximately 15 to 20% patients had microliths as a cause, but 80% had non-biliary cause of symptoms. So we are operating 100 patients where only 20% are going to respond. So that's not a right indication. That's why I removed it from relative indication as for vague dyspeptic symptoms.
Samir, there was a suggestion. There was a suggestion from Swedish group that if you have atypical symptoms and patient is knowing he has gallstones, it's very difficult at times to distinguish those symptoms, contribute those to gallstones. So there was a suggestion you give them high dose of UDCA for 3 months, bile becomes less viscous, and if he improves on UDCA, then you can definitely contribute those symptoms to gallstone, and then you remove the gallbladder.
See, issue is how will you assess UDCA response? See, the problem is, and 3 months is a short period. If you see UDCA and lithotripsy, they basically have a problem is that the symptom has to be biliary colic. See, if dyspepsia improves UDCA, it can be a placebo effect. See, how will UDCA improve dyspepsia? If you look at the side effect profile of UDCA actually causes worsening. It causes dyspepsia, diarrhea, constipation. So giving a trial of UDCA and saying that patient improved, so chances of having gallstone being the cause, I don't agree with it.
Samir, the question was raised by one of our chairperson regarding function of the gallbladder. So still there is some role of the old test, oral cholecystography, to assess whether the gallbladder is functioning, and then we can remove it.
See, what you have to look at is what Dr. Usha Datta's study had shown. It's a review article. What they look at is you have to have a combination: patient factors, environmental factors, and a gallbladder factor. all three things have to, if it's a diseased gallbladder or abnormal gallbladder, chances of having complications are much higher. If host factor, for example, female, higher age, multipara, using oral contraceptive, that becomes a patient factor.
Thank you, sir.
And then, of course, the environmental factor which you have to see. For example, genetic belt is an environmental factor because of more chances of having gallbladder cancer. That is more of an environmental insult in a genetically predisposed individual with some abnormality of the gallbladder.
Thank you, sir. We are moving to the next topic. Next speaker is Dr. G.V. Rao. Topic is choledocholithiasis. When should a gastroenterologist hand over the patient to the surgeon?
Thank you.
At the outset, let me thank Dr. Anil for the honor of this podium this afternoon. Looks like very few surgeons here, and it's a very, very provocative statement, especially after the asymptomatic gallstones discussion that has happened. If you look at CBD stones in 2023, we have three clinical scenarios: gallbladder stones with CBD stones, post-cholecystectomy CBD stones, complicated CBD stones. Unfortunately, fortunately, in 2023, the primary referral of the gallstones is to the gastroenterologist and not to the surgeon. If you see the endotherapy can be done in every single patient, normal anatomy, altered anatomy, or you take the help of endoscopic ultrasound, and we have a huge armamentarium, and there is data coming up from across the globe, which shows that almost all the stones can be tackled endoscopically, depending on the expertise available. Now, based on this evidence, if you pose a question to the gastroenterologist, which of the following CBD stones would you like to refer them for surgery? Evidence-based, expertise-based, economics-based, or ego-based? The response will be absolutely dismal. Now, surprisingly, this is basically because this cartoon which has come out to show that they feel that the CBD stone should not be or cannot be referred to a gastroenterologist. But surprisingly, I think we have to look at the broader perspective of this. In 2023, we have, for patients with GB stones and CBD stones, we have two options. Either sequentially go, two-step solution, wherein you do an ERCP followed by lap chole, or you do a single-step solution where you do lap chole plus CBD exploration at the same time. Contrary to the belief that ERCP, we have two modalities on the surgical side. One is an intraoperative cholangiogram and one is a laparoscopic ultrasound, which could detect CBD stones with much more sensitivity and specificity than ERCP. This is one such beautiful study which shows that if the patients are taken up for ERCP, with this biochemical evidence, the chance of a negative ERCP is almost 22% in these patients. Very, very high. But same thing, if you take intraoperative cholangiogram or laparoscopic ultrasound, the chance of picking up these CBD stones is very high. So we can avoid pancreatitis in this patient. The biggest advantage of doing an intraoperative cholangiogram or a laparoscopic ultrasound is avoid pancreatitis, which happens in ERCP, and that majority of these coming in younger age group. So we have laparoscopic CBD exploration, which is done either through the cystic duct or through the choledochal, through the bile duct directly. And we have the same range of armamentarium that you have on the endoscopy side to deal with CBD stones, nothing less, nothing more. And the procedures are very simple. This is the cystic duct to the thing. Actually, we have all the armamentarium done on the thing. Actually, we go through the cystic duct for a small CBD stone, do a cholangiogram, and then you pick up the thing and you pass a choledocoscope through this, dilate the thing, and then you pass a choledocoscope. Size is not the criteria. Pick up these stones, and we have this similar armamentarium that the gastroenterologist has got to pick up these stones. The biggest advantage is we are not damaging the sphincter in these patients, avoiding pancreatitis or post-procedure pancreatitis in these patients. End of the day, you have to put in a stent. You can always remove this endoscopically. You can see this, that the papilla is intact. All those duodenobbiliary reflux or pancreatitis can be avoided by doing these procedures. If you see the data in 2023, the sequential two-step procedure or a single-step procedure have got equal evidence as in today. And if you see this, actually there is a lot of data which shows that if you do a single-stage procedure, it can be done in all, not only acute cholecystitis, straightforward gallbladder stones with CBD stones, and even with patients with acute cholecystitis with CBD stones, these patients can be done very effectively using a single-stage procedure. And we have umpteen number of meta-analyses that have come in the last decade or so, which shows that a one-stage procedure has similar efficacy and safety in terms of CBD stone clearance, mortality, morbidity, operating time, hospital stay, and retained stone rate. It will reduce an additional procedure. When you're reducing an additional procedure, obviously a single-stage procedure becomes cheaper as compared to a two-stage procedure. When should a gastroenterologist hand over the patient to a surgeon? There are some absolute indications, large indications actually, large CBD stones with abnormal anatomy, patients with internal fistulae, maybe some cases of Mersey syndrome, suspected malignancy, and extrahepatic portal hypertension. These are absolute indications for surgery wherein it has to be handed over. And of course, whenever you have an impacted mechanical lithotripta like this, it has to go for surgery, not for any endoscopic treatment. So gallstones, which large CBD stones, grossly dilated CBD with terminal CBD narrowing, there is data to show that as the degree of angulation increases, the chance of recurrence of these stones is very high. So patients with terminal CBD narrowing, benign narrowing, I think these are the patients with grossly dilated system. These patients obviously have to go for surgery to prevent recurrent stones. And it is not a very complicated procedure. Doing a CBD exploration in a grossly dilated system is an absolutely straightforward case. You just have to make an incision on the bile duct and then extract the stone, and then after that you can close the CBD primarily without even putting in a stent. This is what happens. Not only this, when you have these larger stones, actually it is likely that sometimes we require a biliary bypass because these patients tend to have recurrent fistulae, either a choledochoduodenostomy or a maybe hepatico-jejunostomy in this, and all of these things can be done laparoscopically. I'm not saying it is done in every patient, but we have a select group of patients who require this procedure. Now you're talking about all these endoscopic recent gadgets that you have. Actually, we have similar gadgets on the laparoscopic side. You have a patient with impacted CBD stone. Endoscopy is a simpler procedure, agreed, but we have a similar option on the laparoscopic side. We have patients with cholangitis. Endoscopy is an option, I agree, but we have an option on the surgical side which can be done with equal morbidity and mortality. We have patients with mild biliary pancreatitis. Endoscopy is best, but we have a surgical option which is as good as an endoscopic option as long as you have an expertise. So based on the current day evidence, when should gastroenterologists hand over the patient? Technically, all patients can be handed over to surgeons. That is the evidence, that's what it says. Actually, if you don't have an expertise, it can be handed over. That's what it means. Then the ego of the surgeon comes. So the problem with the gastroenterologist, you don't have endoscopic expertise, you want to refer it to another gastroenterologist. But surgeons, suppose I don't have access to CBD exploration, I would always ask my endoscopy colleague to do this. That's the difference between the surgeons and the endoscopists. So, in spite of all this is said, when will surgeon refer a case to a gastroenterologist? Primary CBD stone, I'll definitely refer to a gastroenterologist. Gallstone, in spite of the fact that I have the expertise to do the thing. Gallstone, pancreatitis, cholangitis, unfit patient, post-op retained recurrent stones, associated cirrhosis and malignant coagulopathy, I'll definitely refer this patient to a gastroenterologist. Now, you're talking about artificial intelligence. Can artificial intelligence predict which patients have to be referred to surgeon? No, as in today, artificial intelligence can only predict the incidence or predict the occurrence of CBD stones. We have some data coming up. Based on the data, we can predict which patients have CBD stones. But as in today, we don't have any data to show that which patients have to be referred by a surgeon. So we need to depend on natural intelligence as in today in 2023 till we have some artificial intelligence coming in. Surprisingly, this is what happened when these people, way back in early 80s, William Hasted operated on his mother, died of CBD stones. Now this gentleman himself has CBD stones and these associates operated on him for 6 times. Surprisingly, they didn't have an endoscopic option, and it is not the ego of the surgeon that they have done surgery multiple times, it is the non-availability of expertise that they have had to operate multiple times. If he were to be in today's time, he would have been definitely referred to a gastroenterologist. So the optimal approach as in today seems to be the clinical setting, condition of the patient, economics, stone load, endoscopic expertise, laparoscopic expertise. If you have GBD and CBD stones, the expertise is similar. Gallstone pancreatitis, ERCP is preferable but is feasible on laparoscopically. Large CBD stones, feasible endoscopically, preferable laparoscopically. Post-cholecystectomy, preferable endoscopically, feasible laparoscopically. Post-op status, preferably ERCP, possible laparoscopy. Abnormal luminal anatomy is preferable to do laparoscopic. Stones with coagulopathy, ERCP is indicated. Terminal CBD angulation is preferable to do laparoscopic. From patient's point of view, both are similar. Young female patient, I think, is preferable to do a laparoscopic procedure. From the insurance point of view, laparoscopy is cheaper. From the gastroenterologist's point of view, 2-stage procedure is preferable. From a surgeon's point of view, single-stage procedure is preferable. So, when should a gastroenterologist hand over the patient to a surgeon? Basically, can is not equivalent to should. It is not that I want to do everything laparoscopically. I want the same thing to happen to the gastroenterologist also. Just because you have the thing, actually, can should not be the thing. Most expensive gadgetry are the most expensive for the patient. It has to be an evidence-based handover. It has to be an expertise-based handover. It has to be an economics-based handover. It has to be an ego-based handover, keeping the patient on the top of priority. Thank you so much once again for the patient here.
Thank you, sir. Any question?
Yeah, very nice elaboration, GV. But most of the time, I agree, it is an expertise-based handover. Because see, the ERCP is done every corner of the India. But laparoscopy and both the things together is only done at AIG. So surgeons are not comfortable. They most of the time gastroenterologist gets the referral from the surgeons for ERCP, not us.
I think I made my statement very clear. If the laparoscopic surgeon is not adequately trained, he is always referring to a gastroenterologist. He is not referring it to another laparoscopic surgeon. What I mean to say is we have options. It all depends on the amount of expertise that you have. The number of ERCPs is more than the number of laparoscopic surgeons doing CBD exploration. Obviously, the expertise could be less. But what I am stating is when the expertise is available, please be choosy in these patients. Not
And
that
you
every
see,
patient. See, actually, I'll tell you that I see patients with large CBD stones, multiple young patients, multiple sessions of ERCP, holmium laser done, ESWL done, EHL done, stents put in, plastic stent, metal stent. By the time they come back with secondary biliary cirrhosis. I think that's what I'm saying.
And we also see a lot of patients operated by surgeons who has more morbidity in the form of strictures and then fistula and then difficult to manage.
This is actually, I'm not talking about straightforward gallbladders where you have bile duct injury. These are all grossly dilated CBDs. There is incidence of bile duct injury in CBD exploration is absolutely nil. I'm not talking about naive gallbladders. Actually, I said with clean gallbladders, simple goals are the ones which have the maximal bile duct injuries, but not CBD explorations, please.
Hi, sir.
Thank you, sir, for the wonderful elaborative discussion. Just would like to know, sir, the incidence of even post-operative pancreatitis is less in case of the laparoscopic CBD exploration. And secondly, I just would like to know if the CBD is more than 2.5, you go for biliary enteric anastomosis for the single large stone?
Yes, actually most of these patients, because of the high chance of recurrent stones, I think these patients require some sort of bypass.
Okay, sir. Thank you, sir.
Sir, in a patient of gallstone and CBD stone, What about any data on single stage, we do ERCP and then followed by laparoscopic cholecystectomy on a single?
Very good question. There is some data to show that we can do intraoperative, in some of our patients also we have done intraoperative ERCP and laparoscopic cholecystectomy can be done at the same time. Again, actually, from a perspective from my side, you can argue it both ways actually. Suppose somebody undergoes an ERCP CBD stone extraction, when do we do laparoscopic cholecystectomy? Most of them they say, actually, there is a lot of pressure from my gastroenterologist saying that you do the ERCP in the morning, you do the lap chole in the evening. I will not do lap chole in the same day evening. Some of these patients develop pancreatitis. Some of these, I'm not saying every patient develops. And we are not losing any time by waiting for about 24 to 48 hours. I personally feel that you have to wait for about 24 hours because if the patient has any pancreatitis, we don't know how to take this patient forward in the post-operative period. So laparoscopic cholecystectomy after ERCP is usually after 24 to 48 hours and there is no chance of increased infections in these patients.
Sir, a patient, a pregnant patient, second trimester, she developed biliary pancreatitis. And on follow-up after, she tolerated well, on follow-up after pregnancy, after delivery, found to have that gallbladder sludge has been removed. It's cleared, there is no gallbladder sludge now. And now the question she asked is whether she should go for lap cholecystectomy and what are the chances that in the next pregnancy she'll develop the similar episode.
This is $1 billion question actually. Surprisingly, actually, most of the gynecologists who scan the abdomen and then they detect gallstones, they clearly tell these patients to undergo cholecystectomy. They say it is not our responsibility to take care if any problem occurs. So the problem is actually the referrals we get from the gynecologist is that we have to get it done. And as you very rightly said, sludge in the gallbladder, passed out CBD stone, this is basically a diseased gallbladder. As in today, I would rather go subject these patients for an elective cholecystectomy.
Any more questions? Thank you so much, sir, for the nice talk, sir. So, next speaker is Dr. Deepak Gunjan, and he'll speak on approach to pancreatic duct stones.
Thank you, chairpersons, and thank you, organizers, for giving me this opportunity to talk about approach to pancreatic duct stones. After hearing a wonderful talk on asymptomatic gallstone and surgeon's perspective, we'll talk about the pancreatic duct stone. So I will discuss about the different techniques to remove the pancreatic ductal stone and its evidence. I will not talk about the surgery which is also done for pancreatic duct stone. So if you will see the chronic pancreatitis, almost 80 to 90% patient has pain abdomen, and that is the main reason for which patients come to the hospital. And supposedly that most important cause of pain is thought of ductal hypertension or obstruction because of calculi or pancreatic ductal strictures. However, there are various other mechanisms of pain generation in chronic pancreatitis apart from the ductal hypertension. It can be pseudocyst, it can be malignancy, it can be inflammatory head mass, it can be neurogenic or central sensitization, or it can be simply acute on chronic pancreatitis. So why endoscopic therapy we choose in cases of chronic pancreatitis? Reason being, in properly selected patients, there is low morbidity. It can be repeated, and even if endoscopy therapy fails, you can subject patient for surgery and refer to the surgeons. If you look at what are the different methods of removing the pancreatic duct stone, one is definitely ERCP. Second is you can subject for ESWL plus minus ERCP, we will see on later on. And third is intraductal lithotripsy that have both laser and electrohydraulic method to remove the stone. ERCP usually if it is a small stone and radiolucent, it is very easy to remove with the ERCP. And mechanical lithotripsy with ERCP is usually difficult in chronic pancreatitis. Reason being, we have less space as compared to the CBD, and also the tortuosity of MPD that prevent manipulating the lithotripsy inside the pancreatic duct, and also the chance of complication is 3 times higher as compared to the biliary intervention. There are various morphology of stones which is very difficult to remove, like this case you can see head stone, large chunky calcification. This is diffuse stone, impacted stone, and if there is multiple strictures in chronic main pancreatic duct. So these are difficult to remove stone in chronic pancreatitis. The second method is extracorporeal shock wave lithotripsy. The mechanism of action is that when shock wave hits the stone, the tensile strength, the shock wave strength is more than the tensile strength, so a stone gets broken down, and also from the posterior part of a stone, the waves reflected that cause more breakage of the stone. And you can see that as the shock waves increases, the stone becomes smaller and it gets pulverized. The ESWL first, the shock wave concept comes in Second World War, when those who has denotating the hydrogen bomb and the submarine crews has found they have a lung injury after the shock wave, but clinical applications started in renal stone in 1980s. The benefit of that, it is minimally invasive and it is day care procedures, so you can subject patient for ESWL. The protocol usually is 5,000 to 6,000 shocks per session. It is more than what is being used for renal stones, 60 to 90 shocks per minute, and also it can be done on conjugative disease, usually done under anesthesia, and most of the time it is 3 to 4 sessions required that completed the job. The patient selection is very important. Reason being, it should be pain predominant, it should be large ductal caliculi, usually situated in head and body, and if solitary stone, it is better, and either single stricture, but multiple stricture is difficult to flush out the stone. For large radiolucent stone, if it is not possible with the ERCP, you can put a pancreatic ductal stenting and then subject to the ESWL, because it is very easy to identify the stone. This is the large experience from the AIG group, more than 5,000 patients. Most of them are idiopathic, and 2/3 of the patient, 3/4 of the patient has single stone, and mostly liquided in head and body. And if you will see, mostly the patients require 2 to 3 sessions of ESWL, and in 3/4 of a patient, usually complete fragmentation is achieved. If you will look at the efficacy, the various studies that varies from 50 to 80% of the patients. However, in long term, usually it settles on 60 to 70% of the patients. And we have idiopathic patients as compared to the Western data, so probably they have a less, because they have a more opiate dependent, probably they have a less benefit of ESWL. Complications, usually in large series it is 5 to 10%, however in AIG series it is 1/4 of patient has complications, but most of them are minor and self-limiting. They does not require prolonged hospitalization or multiple interventions. Should we do ERCP after ESWL? There are very little data on that. 2 retrospective studies, ESWL is found to be adequate. 1 RCT that found that both has equal efficacy in long term in 2 years follow-up. However, ERCP adds to the higher cost. So ESWL alone can be sufficient, but we require more data. What are the factors that predict the complete stone removal after ESWL? If it is single stone, the stone diameter is less and a stone density is less. So these patients are suitable for complete clearance after ESWL. In this study, they have also calculated the stone density. If it is less than 820 Hounsfield unit on non-contrast CT scan, there are more chances of having complete clearance. Another studies, they have calculated that Hounsfield unit of 375, they have more chances of clearing the stone and fragmenting the stone. And if you see on the right side of graph, if there is a increase Hounsfield unit, the chances of requiring more ESWL, more sessions of ESWL is required. When you should not attempt the ESWL? Diffuse stone, head mass, multiple strictures, only parenchymal calcifications, tail region stones, and the packed stone. You should not usually subject the patient for ESWL. Meta-analysis, complete stone fragmentation in 90% of the patients, partial complete clearance in 60% to 70% of the patients, and complete pain relief around 60 to 70% of the patients. The SOC trial result is not published, just presented in last week conference, although it is shown that the beneficial of effect of ESW and ERCP, however, the result is not as good as we think of. The other method is intraductal lithotripsy, both with laser and EHL, electrohydraulic lithotripsy, that can be tried. This is the largest series having 100 patients. They have a both technical and clinical success of similar. However, procedure time is less in laser lithotripsy. If more than 3 ductal stones are there, so the chances of having more requirement of ERCP is more. This is the meta-analysis that shows that EHL has slightly less chance of technical and success rate, clinical success rate as compared to the laser lithotripsy. An adverse event usually happens in 1/4 of the patients, but usually they are minor. There is no direct comparison between ESWL versus intraductal lithotripsy. This is the one study I could find in which that the success rate is similar, adverse rate is similar. However, the intraductal lithotripsy has fewer number of total procedure and less procedure time, and also the intraductal lithotripsy is associated with greater efficiency as compared to the ESWL because they require more number of sessions. This is the one RCT that is ongoing, that is comparing ESWL versus intraductal lithotripsy from the US group. The result is yet to be published. So my algorithm is, if it is soft and small calculi, you can go for ERCP. If it is large and hard calculi, extensive calculi, multiple strictures, head mass, you refer to the surgery. If it is located in head and body, single, there is no strictures, you can subject either ESWL or intraductal lithotripsy. If it fails, subject them to surgery. However, before I am concluding, you can see that in early cases, the pancreatic parenchyma is normal. In recurrent acute pancreatitis, there are some changes of pancreatic parenchyma, but ductal, there is no ductal changes. However, in chronic pancreatitis, there are stones and ductal changes. So what is happening? Parenchymal changes happens before then the ductal change, and a recurrent acute pancreatitis patients also has pain. So most of the patients, most of the time we manage with the medical treatment. So ductal changes came later in course of the disease, and ERCP and surgical treatment does not look for the parenchymal changes in the chronic pancreatitis. When the ductal changes happens, then we look for and subject the patient for ERCP and surgery, meaning thereby you have to choose your patients very wisely. So if it is soft and a small calculi, go for ERCP. ESWL and ERCP probably the first line treatment for large calculi in properly selected patients, and pancreaticoscopy, guided lithotripsy, probably both laser and EHL has both equivalent results, but we require more data, and optimal technique should be selected based on the clinical situations, availability of expertise at your center, and we require RCTs because there is a huge gap in knowledge for head-to-head comparison for all the modalities. Thank you.
Deepak, see 40 to 50% of the patient will have a recurrent stones over a period of time. So if a patient has a dominant single stricture with multiple stones and dilated ducts, so what you will do? Surgery, fresh procedure, or repeated sessions of ERCP or EHL?
So if it is single stricture and dilated duct, you can go ahead with ERCP. There is no problem in that. Because surgery is also, it's not like that it is free of complications. In best of the centers, I think 1 to 3% mortality is there in pancreatic surgery. And most of the centers don't have a dedicated pancreatic surgeons. That's another problem. If you have a good hand, you can go ahead with the ERCP in single strictures and soft and multiple stones even though it. Awesome.
Any other questions? Yes, sir.
Deepak, excellent talk as always. If we have a patient who has got head stone which are soft, you can easily take them out. And simultaneously, patient has got few small stones in the tail region. See, will you straight away send the patient to surgeon, or you would remove the head stone, get the detailed anatomy of the duct in the head and body, and see how stones in the tail behave, whether they cause recurrence of pain or not. See, generally the concept is if it's a diffuse disease, head, body, tail, then you straight away send to surgeons. But what I am saying is soft stones, head stones you have tackled, and stones in the tail region are small, not very big. And you are able to deal with the head stone as well as the stricture if present in the head and see how the patient pain behaves. And then decide whether the patient is a candidate for surgery or you can manage endoscopically.
So if the patient improves, you can follow up. If you are thinking the tail is stone and you are not able to remove with the RCP, you are still thinking that this is the cause of pain, then definitely you require surgery, surgeon's help. But if the patient is fine, I can follow up the patient.
If there is no further questions, thank you Dr. Deepak for enlightening talk, and thanks to all the speakers. We end this session here. Thank you. Thank you very much.
Thank you all our respected speakers for such elaborate and yet precise discussion. So moving further, the topic of our next session is Beyond Boundaries, Third Space Endoscopy Revolution. For this, as chairpersons, I would like to request to come up on the stage Dr. Ajay Bhalla, Fortis Hospital, Noida, Dr. Chao C. Langkun, Niba Hospital, Itanagar, Dr. Dinesh Garg, Synergy Plus Hospital, Agra, Dr. Rabin Koirala, Nepal, and Dr. Lalit Kumar Das, Kathmandu, Nepal. And as moderators, I would request to come up on the stage Dr. Sanjeet Karki, Hospital for Advanced Medicine and Surgery, Kathmandu, Nepal, Dr. Ankur Jindal, Institute of Liver and Biliary Sciences, New Delhi, Dr. Talar Motu, RK Mission, Itanagar, Dr. Kuldeep Solanki, Solanki Gastro and Endo Center, Raipur, Dr. Rajeshwar Yadav, Koshi Zonal Hospital, Kathmandu. There is a slight shuffle in the sequence of talks now. So the first talk will be presented by Dr. Rajkumar P. Vadwa on cystogastrostomy tips and tricks. After that, we will continue with the previous sequence only.
For cystogastrostomy tips and tricks, I'd like to invite Dr. Rajkumar Vadwa.
Good afternoon, dear friends, and first of all, I would like to sincerely thank Professor Anil Arora and the team of Gangaram for giving me an opportunity to speak here in front of this august audience. We all know that pancreatitis can be followed by fluid collection, and modified Atlanta classification has defined this fluid collection based on the timings into walled-off necrosis and acute fluid collection or pseudosis depending on the duration. Majority of these requires an expectant management. Watchful waiting is the criteria in this, as majority of them, about 60 to 65%, will resolve on their own. 10 to 20% may require a drainage due to either symptoms or complications. They may be either infection or rapidly enlarging fluid collection. We have variety of options, endoscopic with or without EUS, surgical, percutaneous and combined. And we time this in the second phase of an acute pancreatitis, where drainage and debridement, once the walls are formed. Till that time, we try to avoid it, although there has been some attempt to do an early drainage also using an endoscopic methods. The basic way to drain this is using either a plastic stent when there's very little or very little necrosis, and they may be either single or multiple transluminal gateway technique, again depending on the necrosis, or you use the metal stents or lumen opposing metal stents to drain this fluid. The basic premise is we do the cystogastrostomy, and what do we do while doing a cystogastrostomy? There's certain important precautions we take actually before doing a procedure, and imaging is an essential part of this to characterize the lesion, to assess the amount of necrosis, to plan in advance whether you would like to put a metal stent or a plastic stent. Of course, discontinuation of anticoagulants and antiplatelets is a prerequisite. A broad spectrum antibiotic should be given, and only carbon dioxide should be used as an insufflation method in this. While going through the actual procedures, the guide wire we use is either 0.032 or 3.5, and the needle is 19 gauge needle or a direct puncture with a 10 French cystosome. The trick here is use the approach as less tangential as possible while coming out of the EUS. The more tangential, the more you are likely to cut through between the gastric wall and the cyst separating the two. Initial dilatation could be using a biliary dilator or a cannula. However, majority of us now prefer a cyst enterostome, either a 6 French, which can be dilated with balloon subsequently, or directly 10 French to place a stent in these situations. You can use a multiple double pigtail stents. The important thing here is, since we are putting it through the angled viewing endoscope to see where exactly we would like to actually release the stent, we should always mark the center of the plastic stent with a black marking, so that when you actually see this black mark, you release this stent inside the scope and then withdraw the scope so that the stent does not get pushed into completely things. When we use either a pancreatic drainage stent or lamps, we deploy the distal flange. The trick here is deploy the distal flange deep inside. Do not do it proximally. Once you have deployed, you actually pull back to the wall as close as possible and then turn to the right. Turning to the right gives you a slight visibility where you can see the stent, and then deploy the stent inside the scope and then pull back the stent. This could be an example of doing it. Putting in a needle inside and deploying it deep inside the cyst. Once you have deployed the proximal flange, you withdraw it back. You withdraw it very close to the wall and then deploy the stent in the through the endoscope, inside the scope preferably, and not outside the scope. Of course, the precautions post-procedure will be to make sure that all the fluid which you can drain, you drain it before. Post-procedure, keep the head in a propped up position. Always put a Ryle's tube if you have a large fluid collection, which you expect to drain even after the recovery, and these will probably reduce the chances of aspiration. These are, as far as the tips is concerned, to do a good procedure, but the problem comes is when you face a difficulty in these scenarios. We need to understand that the fluid may not be classically in the lesser sac when we are doing. So understanding the anatomy and then putting a stent is very important. So take a good look at the entire profile. You may find that sometimes you may have either a simultaneous fluid collection in abnormal spaces like mediastinum, as in this case, where you may have to modify your procedure completely. Or you may have a superior recess of lesser sac where you have a fluid collection. This looks as if it's an intrahepatic collection, but this is not actually an intrahepatic collection. As you can clearly see that there is a separate marking and this can be drained safely. While intrahepatic collections you have to be careful about, here you can drain safely, but you need to identify a classically superior recess of fluid collection. Similarly, inferior or the splenic recess can be distant from the stomach wall, and in this scenario, kindly measure the distance between the stomach wall and the pseudocyst wall very carefully. It is preferable that if you are having a distance of around 1 centimeter, then do not use either a plastic stent or a simple pancreatic metal stent, but use a lumen opposing metal stent in this scenario to make sure that you have a tight apposition to reduce the complication in these scenarios. You may find that despite taking the precautions, you may have a mild deployment of the stent, or you may have actually migrated the stent after deployment, which occurs when we are at the beginning of this to really realize you may keep on pushing the stent and the stent entire stent goes into the duodenum. It can be immediate or it can be delayed. The avoidance is careful evaluation of the site of puncture. It is important to note the site of puncture should not be in the esophageal wall. So carefully look at the crus of the diaphragm on the endoscopic ultrasound and make sure that you are puncturing below the crus of the diaphragm. You also have to make sure that you leave the guide wire inside and don't rush to remove the guide wire, because guide wire of yours acts as a lifeline, as in this case you can see that. while you are pushing the stent, you have actually pushed the stent. If you carefully look, you have pushed the stent inside the pseudocyst. Do not panic at this point of time. You can see free floating stent in the pseudocyst. What you do is leave the guide wire in C2, do a dilatation, balloon dilatation, change the scope to an apogea endoscope on the guide wire, go back inside and replace back or pull back the stent, which can be safely done. If you have deployed in the stomach, then you have not much choice left. Here in this scenario, as you can see, you can dilate the actual puncture site, leaving the guide wire inside. So don't rush to remove the guide wire when you have deployed the stent in these scenarios. You may deploy the stent in between the stomach wall and the pseudocyst, and that's probably the most dreadful of the three scenarios. Here you will have to remove the stent and close the puncture site with an endoscopic full thickness or at least an OTSC clip, and then do a fresh puncture at another site and deploy the stent in these circumstances. As in this case, you can see that there is a stent which is deployed in between the pseudocyst and the stomach wall. You can have another dreaded complication which we are always afraid of, that's the bleeding. The important precautions in this scenario you need to take is take a good CT scan to make sure that there are no pseudoaneurysms or a large amount of blood vessels in between the stomach wall and the pseudocyst. You have to have a coagulation parameters. Never try to puncture it with a needle knife, and a Doppler before puncture helps in reducing the child. You want to change the site, use an up and down knob. Actually you can use to change the location of the bleeding point. Variety of methods, if it occurs that the bleeding has occurred, you have variety of methods to control them. If you see actually the bleeding occurring during the time of procedure, then you can use balloon tamponade or hemoclips and then go for it. This is an interesting video. As you puncture, you realize that you have gone through the vessel and there is an active pumping of the blood in the pseudocyst. Here you use again the guide wire and use a balloon to coapt it with it. The bleeding stops in a small time, and then you can go ahead and complete the procedure in majority of these circumstances. You can have this bleeding even after the but if you are very close to the blood vessel when you are doing the necrosis removal, then it is better to avoid putting clips or inject in these situations and take the help of a radiologist, as in this case, where you can stop the bleeding far more safely. This you can see a blood and post embolization, a complete control of bleeding in these circumstances. So to make sure that you have all these things, kindly anticipate problems you may have during the time of cystogastrostomy. Be prepared with all the accessories. Do not go unprepared in these situations. Keep your radiology and surgical colleagues informed about the procedure so they can come to your rescue if you are in difficulty, and have a safe cystogastrostomy experience. Thank you so much.
Dr. Vadva, I just wanted to know, where would you want to use plastic stents and where would you like to use lamps? Do you have a specific condition indications? I'm sure they are there.
Yes. When you have a clear pseudocyst, then you use a plastic stent. You have a walled-off necrosis, especially if your amount of necrosis is around 20 or 30%, then you are specifically going for a lamps in this situation.
Large clear pseudocyst, also you'll be happy only with plastic stent?
Yeah, you may put a multiple plastic stents in this situation, but it still takes care of it. It doesn't require anything.
Right.
Good talk, sir. I want to ask you, if you puncture and if you dilate the tract and there is a bleed, now the problem is balloon tamponade is fine if it works fine, but the problem is applying hemoclips. where to apply, because it can be on the inside of the mucosa toward the cyst, and it can be on the stomach side. If it's on the stomach side, it's easy to apply the clip. But you don't know from which part of the circumference the bleed is happening. So, I mean, how do you deal with it? I mean, in the context of hemoclip I'm talking about. I mean, there are other modalities, but in case you have to apply a clip, how will you kind of...
In my experience, applying inside the pseudocyst hemoclips are difficult because you are dealing with a necrotic material. You don't get the grip of it. So you need to take a larger clip. Suppose majority of these, if you are doing at the time of procedure and they are bleeding, they bleed from the wall. They do not bleed from inside. It's only when you are doing necrosectomy, it bleeds from inside. So if you are doing it from the wall and you can locate the site of bleeding, then putting a larger hemoclip is the simple answer. If you can't do that, maybe you can attempt a larger stent inside, which can help stem the bleeding.
Another issue is if you apply the clip, then it's difficult to carry forward the procedure, because then you have to dilate it further and then you have to apply. What I'm saying is, in case the bleeding doesn't stop, what you can do is you can simply put a LAMS, but the tamponade effect, it may stop most of the time. So what has been your experience regarding that?
That's what I said. I would, if I can put a simple clip, carry on the procedure further, not otherwise a larger diameter stent in that situation.
Thank you.
Sir, good afternoon, sir.
We have one question.
Sir, when to remove, sir, stent after cystostomy, whether after complete resolution of collection or when the patient is asymptomatic?
Normally we reduce it before 4 weeks. We do not allow the stent to remain inside, especially if it is a metal stent. Plastic stent can be left for a longer distance. Normally before removing the stent, I would do an MRCP and see whether there is a leak present or not. And if there is a leak, a plastic stent is left indefinitely.
If there are no further questions, thank you, sir. Now I'd like to invite Dr. Surendra Singh Rana to talk about endoscopic management of walled off pancreatic necrosis.
Thank you, Chairpersons. Good afternoon, everyone. At the outset, I would like to thank Dr. Anil Arora and his team for extending invitation to me and inviting me here. I have been asked to speak on endoscopic management of walled off necrosis. So without wasting time, I'll just go to the task assigned. Before I start speaking about endoscopic management, it's important to understand the nomenclature. This has been reiterated many times in many meetings, so I'll just briefly recapitulate that we divide the pancreatic fluid collections into 4 types based upon the type of pancreatitis, the time, whether there is a solid debris present, and whether an encapsulated wall is present or not. So acute fluid collection and acute pseudocyst are seen in interstitial pancreatitis, where if the duration is less than 4 weeks, it's an acute fluid collection with no solid debris, and if it is more than 4 weeks, we'll call it acute pseudocyst. And similarly, in the setting of necrotizing pancreatitis, if it is less than 4 weeks without a well-formed wall, it is called as an acute necrotic collection. And if there is a well-formed wall beyond 4 weeks, it's called as walled off necrosis. And that's what we are going to talk about in this talk in next 9 to 10 minutes. Just to recapitulate same pictorially, you have interstitial pancreatitis. In first 4 weeks, it's a non-encapsulated fluid collection, which is known as an acute fluid collection. And beyond 4 weeks, it gets a well-encapsulated wall, and it's called an acute pseudocyst. Similarly, in acute necrotizing pancreatitis, you will have extensive necrosis, initially an acute necrotic collection without a well-formed wall, and when it gets encapsulated, it is called as a walled off necrosis. So in this talk, I'm going to talk about when do we do the drainage, in whom, what are the pre-procedure considerations, what are the technical details in brief, what are the results, and finally the complications and their management. So when only symptomatic collections are to be drained, so patient can present to you with fever, pain, gastric outlet obstruction, early satiety, and biliary obstruction causing jaundice. And of these, the most common indication for drainage are fever and pain. Why not drain asymptomatic walled off necrosis? This is a paper from our center where we followed up the patient with asymptomatic walled off necrosis, and again, as shown, majority of patients will have spontaneous resolution and only 12% of patients required surgery. On the other hand, what happens if you drain sterile necrosis? These are the studies which have looked at the endoscopic management of sterile necrosis. I want you to concentrate on last 3 columns where you can see the length of hospital stay,
mortality and adverse events were much higher as compared to expectant management. So that's why asymptomatic walled-off necrosis is not to be drained. In whom we do endoscopic drainage, it's only the collections which are around the stomach or duodenum. What about transcolonic and transesophageal drainage of walled-off necrosis? There is few case series on this, but there is very limited experience. And we all understand that transcolonic drainage will have a high risk of polymicrobial infection, so it should be done only in exceptional circumstances and also in centers who have a good surgical as well as radiological expertise. Transesophageal again has a high risk of mediastinitis, so metallic stent should be avoided, only plastic stent should be used, and one should be very, very careful with over-aggressive dilatation of the esophageal wall. What's the pre-drainage evaluation? There should not be any significant coagulopathy. Look for the amount of solid debris. Why is it important? I'll talk about in subsequent slides. You need to establish the relationship of the fluid collection to the lumen and the surrounding vascular structures, because that will help you in obviating the complications. You should do a good cross-sectional imaging, which will give you the picture of both the luminal relationship as well as vascular relationship. Why solid evaluation for solid debris is important? Like on CT scan, it will all look like a good clear fluid. This is initial days when we used to do percutaneous drainage. Once you do a percutaneous drainage, the liquid drains and you find there is a lot of solid debris which would lead on to secondary infection. So now we have an MR and EUS which will give you much better picture of the amount of solid debris. So before you embark upon endoscopic drainage of walled-off necrosis, it's always a good idea to do an MR and find out how much is the solid debris. EUS can also give you the same information, probably much better than MR. And then sometimes you can pick up unusual vascular complications like a pseudoaneurysm which has been missed in a CT angio also. Why it is important to look at the amount of solid debris? This is a paper which we published where we looked at the amount of solid debris and shown that extent of necrosis or extent of solid debris is correlated with the amount of aggressiveness you have to show. So if you have a solid debris which is more than 40%, these patients usually will require either an endoscopic or a surgical necrosectomy. So this is the flow chart which we just published, how to decide whether to use LAMs or plastic stents. So you look at the size of collection, you look at the amount of solid necrotic debris, the clinical condition of the patient, follow-up compliance and whether it is encapsulated. If it is small size collection, predominantly liquefied, say around less than 30% is the solid debris, or if there is a poor compliance for follow-up and patient is not critically ill to withstand a procedure of about 25 to 30 minutes, put multiple plastic stents. On the other hand, if there is a large collection, there is a significant solid debris, patient is not compliant for follow-up. You put up a metallic stent, he gets lost to follow-up. In those situations, don't put a metallic stent. And if the patient is critically ill, you want to quickly go in and go out, you can use a LAMS because it's a quick procedure. 5 to 10 minutes, you can place a LAMS. So in these situations, you should use a metallic stents. Then how to do a transluminal drainage? I won't go into the details, but briefly we can do it in 4 types. One is a simple drainage where we just put plastic or metallic stents. You can do a necrosectomy if the patient is not improving. You get inside the cavity and do necrosectomy. You can combine it with the percutaneous drainage, which is known as a hybrid drainage. And finally, we can do a multiple transluminal gateway technique where we do multiple punctures in the stomach and duodenum to have a more better drainage of the necrotic debris. So I'll just briefly show the same things pictorially. This is a large walled-off necrosis. You do multiple plastic stents and you can see a nasocystic drain has been placed for irrigation. And then gradually over subsequent sessions of necrosectomy and drainage, the collection has resolved. The same thing can be done efficiently by using LAMS. Now we have various types of LAMS available. So LAMS gives you a much better drainage because of the larger luminal diameter as compared to plastic stents. And as you can see that simple drainage is effective in almost 70 to 80% of patients. You don't need to do necrosectomy in these patients. Only 20 to 30% of patients would require necrosectomy. So if the patient don't respond, you get inside the cavity and do necrosectomy. And this is the end point for necrosectomy where you see healthy granulation tissue devoid of any necrotic debris. You can do a hybrid drainage. So there is a large emphysematous walled-off necrosis. Initially, patient is critically ill. You do a percutaneous drainage, stabilize the patient, and then you go and do it endoscopic ultrasound-guided transluminal drainage, place multiple stents. Finally, multiple transluminal gateway technique. There's a large intercommunicating walled-off necrosis. Initially, you drain through the stomach, put multiple plastic stents, then you go through the duodenum, another puncture there, put multiple stents, and in this patient a transpapillary stent has also been placed because of the partial disruption. So you can see multiple stents through the stomach and duodenum, and then it leads on to quicker resolution. So if the patient is not improving with drainage, then you do necrosectomy. So this is what you will find in most of the patients. The stent would be clogged by the necrotic debris. So you use the conventional exercises like grasping forceps, or you can use a snare to remove the necrotic debris. So you do stepwise necrosectomy, and sometimes it doesn't work. You can do a chemical necrosectomy where you use hydrogen peroxide as is being done. So you just inject hydrogen peroxide, it will lead on to effervescence and bubbling, and this can help in doing a necrosectomy. So this can be either at the beginning of the procedure if you are not able to see, but the flip side of injecting hydrogen peroxide at the beginning of procedure is that it sometimes obscures vision and makes necrosectomy difficult. So other is, once you have completed necrosectomy, you can leave hydrogen peroxide inside. It can help in spontaneous drainage of necrotic debris. Now there are certain innovations. You can use a grasper, which comes for a better necrosectomy. You can use a cap-assisted necrosectomy, which helps in removal of large chunks. And now we have this device, which is a powered endoscopic debridement device, PED, which can help in efficient necrosectomy, although the data is still limited and we don't have this device in India. What about the results? There are a lot of retrospective studies. I won't go into the details, but all of them show that success rates are more than 90% with complication rate for less than 10% majority of studies. But more important is how it compares with surgical drainage. So there are 3 randomized controlled trials now, Penguin, Miser and Tension, comparing endoscopic with minimally invasive surgical approach. And all these studies have shown that endoscopic approach significantly reduced major complications, lowered the treatment cost and increased the quality of life. More importantly, the rate of pancreatic fistula and length of hospital stay was much lower in endoscopic group. So these all 3 randomized controlled trials and subsequent systematic reviews and meta-analysis have shown that endoscopic drainage is superior to minimally invasive drainage in those collections which are amenable to endoscopic drainage. What about the long-term follow-up? This is a paper we published in 2014 where we compared endoscopic with surgical. So in all the parameters, recurrence of pancreatic fluid collection, exocrine and endocrine insufficiency, endoscopic drainage was better than surgical drainage. And this is a paper published in Gastroenterology last year, which looked at the long-term follow-up of endoscopic drainage and of the tension trial. Again, it shows that the rates of re-intervention in endocrine and exocrine are much lower in endoscopic arm. What about complications? There are a lot of complications reported, but fortunately they are very rare. Bleeding and perforation are 2 important complications, but most of the time they can be handled endoscopically, as in this case. Post-LAMS placement, you can see there is a bleeding going on. So you apply a clip, and with clip application, most of the bleedings can be stopped, as in this case. So this is the clip deployment being done. One clip has been deployed. You deploy another clip. So it will help in reducing the ooze, and then subsequently, in the same case, we used APC to completely stop the bleed, as in this case. So the APC has been applied. And as you see that as you apply APC at the tract, and finally you get a hemostasis in this case. So to conclude, endoscopic transluminal drainage is the preferred route of drainage for endoscopically accessible and encapsulated collections. Both plastic stents and LAMS are equally effective, but the choice of stent should be individualized based upon the clinical status, morphology of collections, patient compliance and finances, as I've talked in the flow chart, which I described in one of the slides. And we have to understand, despite availability of newer tools for mechanical necrosectomy as well as agents for chemical debridement like hydrogen peroxide and streptokinase, the pursuit for safe and effective necrosectomy tools still continues. So we still haven't reached that stage of perfection where we have an ideal tool for endoscopic necrosectomy. Thank you so much for your patient hearing.
Thank you, Dr. Rana. One question. In your flow chart, you had mentioned multiple plastic stents with multiple puncture sites. What is the indication for that, and how is it vis-a-vis comparing it? Instead of that, you could have played a LAMS, you could have placed that. So why did you place multiple plastic stents? What was the indication?
Multiple plastic stents were placed.
Multiple sites.
Yeah, multiple sites. That's multiple transluminal gateway technique. It's usually done in patients who have a significant solid debris and who are not affordable for LAMS, because it will be a cheaper course. So if you just make a puncture at one site, these patients will not have a better drainage, but if you are able to put multiple drainage sites, they will have an effective drainage. So that's an idea to cut short on the duration of therapy.
It's only economics, because
it's only economics. Now with the availability,
LAMS will take 10 minutes, whereas this 3 of them will take much longer.
There are some case series where they have described MTGT with LAMS also, making to place 2 LAMS. So that study has also shown that as compared to single LAMS, a double LAMS will have a shorter duration of therapy as well as need for necrosectomy.
In 10 French gauge plastic stents over 7 French gauge?
Normally, if you are doing a transluminal drainage, it's always better to use 10 French stents, but because of the logistics of, if you are doing an EUS scope, you can't place 10 French stent with a wire inside. So what you have to do is first stent which you place is a 7 French and second you place 10 French. Now 7 French alone will not be effective. So if you have a significant solid debris or if your collection is more than 10 centimeter, you need to place multiple stents using a 10 French also as one of the stents.
It was an excellent talk, sir. So I just wanted, recently I had 2 patients, young patients, both were around first 10 or 14 days of their onset of pancreatitis. Both had a massive emphysematous pancreatitis with a lot of air inside the fluid, that cavity. So in that scenario, what should be done, sir? Whether should we drain pigtail or should we send the patient directly for surgery, or maybe after pigtail and then do a cystogastrostomy maybe afterwards?
It depends upon your expertise, because if you have an emphysematous collection, it's very difficult to drain on EUS because you will not be able to visualize. So you have to carefully see the CT scan. If your collection is adjacent to the stomach, you take your EUS scope under fluoroscopy, puncture the collection and aspirate. If it's an emphysematous, you will get pus. So once you get a pus, then you take the wire inside and then do a transluminal drainage. But if you are not aspirating pus, it's better to do a percutaneous drainage, or if you don't have an expertise, you should get a CT guided drainage. Because draining an emphysematous collection endoscopically on EUS is the most difficult collection to drain.
And then after percutaneous, the patient should be sent for the surgery or like on follow-up?
Yeah, once you have done a percutaneous drainage, then doing an endoscopic drainage is very, very difficult if the time span is more, because a lot of air gets in, so you won't be able to see anything. So it's better to do, if patient is not improving, it's better to do a ward rather than contemplating doing an endoscopic drainage.
Thank you.
Thank you, Dr. Anand. Thank you so much for your answer.
Thank you all our speakers for such wonderful talks and discussing the practical interventional aspects in managing pancreatitis and its collections. So, and thank you all our chairpersons and moderators also for conducting the session. Moving on to the next session of the day, Pancreatic Perspective and Revealing Mysteries. For this, as chairpersons, I would like to invite on the stage Dr. Roshan Lal Bhagat, NKS Hospital, New Delhi, Dr. Sanjay Sharma, Synergy Plus Hospital, Agra, Dr. Saroj Dubey, Rajdhani Gastro and Liver Clinic, Delhi, Dr. Rahul Jain, Fortis Hospital, Delhi, Dr. Vivek Bhatia, EndoXL Liver Gastro Clinic, Delhi. And as moderators, I would like to invite on the stage Dr. Ajay Singh, Mayo Clinic, Minnesota, Dr. Girish K. Pati, SCM Hospital, Bhubaneswar, Dr. Arvind K. Khurana, Fortis Hospital, Gurgaon, Dr. Saurabh Srivastava, Pratap Gastro and Liver Clinic, Jhansi, Uttar Pradesh, and Dr. S.K. Mishra, Sanjeevan Hospital, Delhi. I would request now the chairpersons to kindly call on the stage the respective speakers for their talks.
Good afternoon, everyone. For the next session, I'd like to invite Dr. Pankaj Desai, who will be talking about second generation third space procedures.
Good afternoon, and I thank Dr. Anil Arora, Dr. Ashish, and Dr. Praveen for this honor. And quickly, without wasting time, I would like to go on to my presentation. I have been asked specifically to talk on G, F and Z poem. In the evaluation of third space, we all know that we have poem which started off with the third space concept. Then a number of procedures including fundoplication, stir, G poem, Z poem, Zenker's, Prem and poetry have started. So now going to G poem. What is G poem? It is gastric peroral myotomy. And the basic indication is gastroparesis. It could be idiopathic, diabetic, post-surgical, drug-induced, or due to other diseases. And it is usually an interplay of two independent mechanisms, that is decreased gastric motility and pylorospasm. The intensity is described by the gastroparesis cardinal symptom scale index, depending on giving with the score. And usually it is a medical management for gastroparesis, but If it is refractory, not responding to medications, then what we have in store is you can do a gastroduodenal manometry and see for antral hypomotility. If it is antral hypomotility, I don't think any surgical intervention would work, and you have to either resort to medical management or jejunal feeding. Endoflip is a very important instrument in this armamentarium, and you have to see the distensibility and the diameter of the pylorus. If you find a pylorospasm, then you have options like botulin, transpyloric stenting, or G-POEM. Botulin has been shown to respond, to show good response in a couple of studies, but it is not always used. Transpyloric stenting has been used to improve the gastroparesis, but these three gentlemen, Haru and Stavropoulos with Moen Kashab, have come out with a gastric poem based on the principles of third space endoscopy. What they do is a posterior approach on the stomach, take an injection 5 centimeters proximal to the pylorus, like we do in poem, put an incision, get into the submucosal tunnel on the gastric side. Once you get into the tunnel, what we do is create a tunnel, go slowly towards the pylorus, just making sure that you are not lost in the way. Large vessels which are encountered in the antrum are to be tackled with a coagulation grasper, and you reach the pylorus and identify the pyloric ring as you see here. Once the pyloric ring is identified, we change the knife to an insulated tip knife to avoid injury to the duodenal wall, which is quite here, and do the incision on the pyloric ring and a couple of centimeters distal, doing a full thickness myotomy here, leaving the serosa intact. And once that is done, what we can do is either close it if it is a horizontal incision with an Apollo overstitch here. If we are doing a regular endoscopy, if you don't have an Apollo overstitch, you can close it with regular hemoclips. Or nowadays what we do is there is a X-tack which has come, which is a tacking device, and this is like a full thickness suturing. So you can apply 3 or 4 tacks like this as shown in this figure here, and then you can cinch all these together like this to make a full thickness complete secure closure. So the G-POEM has come, and it is technically successful in almost 100% of cases, but the clinical success is modest. It's around 60 to 70% in all the cases. Short-term outcomes are good, as you can see here. You have a good success, but a modest clinical success. Long-term, we have seen that the clinical success decreases as the number of years go by. And these failures are associated with patients with high BMI, longer duration as it goes increase, psychosomatic illnesses, if patients are using pain medications, and a very high GCSI score. So there has been a recent publication which is a sham control study between G-POEM and a sham control. We found a modest success in 71% of the cases compared to 22%. But when there was a crossover at 6 months from the sham to a G-POEM, 75% of those patients who did not respond to sham responded to G-POEM, and therefore now it is recommended that G-POEM is shown to increase the pyloric diameter, not distensibility, and endoflip has to be used and in association with antroduodenal manometry to direct the selection of patients for G-POEM. So this is endoflip. Dr. Nagi also showed you this has to be included in the armamentarium for selection of the patients. What we do is a balloon which you can show you the diameter, and once you can see here you are inflating it with water, and once it reaches 40 ml or 50 ml, then you have to see the distensibility, and depending on that you can select the patients for G-POEM. So which patient would you take up for G-POEM? You have to have a pyloric distensibility of less than 8 to 10. Ideal case, clinical criteria, no major abdominal complaints, no psychiatric comorbidities, no uncontrolled diabetes, no or minimal narcotics, and preclinically if the patient has responded to botulin and the patient has present antral motility. If it is absent, I don't think you should have this G-POEM. So these are the optimal candidates for G-POEM. One more alternative has been described again by the Moem Khasham's group, is doing a double pyloromyotomy, that is they would do an posterior and also add an anterior myotomy to it. Doing a double myotomy sometimes is shown to give better results, but the results are still awaited. There is always also a technique where you do two incisions in the same myotomy on the posterior side and remove the central muscle core. That also has shown to be more effective. So G-POEM is feasible. You have to have good indications, good patients, and you have to have impedance manometry and antroduodenal myometry to find the correct patients. Coming to POEM-F or POEM with fundoplication, we all know that POEM has come a long way for last 10 to 12 years, but GER, as Dr. Mohan described, is a very new thing which is going to hampering the progress of POEM. And we all know that there is a 30 to 60% incidence of GER which has been described with POEM. But it's maybe true or maybe not, but then we have to decrease this reflux, and one of the mechanisms shown to which we can act with the POEM is a fundoplication. If there is GER, the standard therapy is PPI, do surveillance, add an anti-reflux surgery, or during the POEM or after the POEM, concomitant or subsequent, we can add incisionless fundoplication or a POEM-F. So what is a POEM-F? It has been described by Professor Haru Inoue again in 2019. It's based on principle of fundoplication, and this is the technique which I will show in this small video which Dr. Amol has given. So what we do is, any POEM-F, you have to do an anterior myotomy. This is something which is important. You enter the tunnel anteriorly. Once you do an anterior myotomy, you have to find out a plane to enter into the peritoneum. Once you see the liver, left lobe of the liver, you enter inside, catch hold, do a retroflexion with the scope, go to the fundus, identify, mimic a wrap by putting a slim scope through the nose. As you can see here, this is a wrap which has been mimicked. This point has to be identified, and then you mark this point here. Once you have marked, take a detachable endoloop, go to that point, fix the endoloop there with 3 hemoclips like this, then come into the tunnel, fix the other end of the snare of the loop with 3 hemoclips again to the distal end of the myotomy. Once the clips are fixed, you have to close this loop very tightly, and then you have to see that you have created a good lap. Then you cut this additional length of the loop, come out of the tunnel, and you have to just close the tunnel as you do, and you see that you have a wonderful wrap. So this is shown to have feasible outcomes, and it is supposed to be safe. Amol has presented his 3-year data, which has shown that the subjective values are less of GER over a period of 3 years with POEM-F, and even the D-Mister score decreases comparatively and stays decreased at 3 years. A small comparison multi-center study has been done to compare POEM-F with POEM plus post-operative arms, and they have found that though post-operative arms had less procedural time and less length of stay, but the repeat sessions required are more with arms. And therefore, whether we should go in all cases with POEM-F or selectively, there are ideas which are pros and cons. This, if it replicates LHM, preliminary results are promising and reproducible, but this is expensive and you need real expertise. So against, not all patients would develop significant reflux, as Dr. Mohan showed. So this basically should be reserved for patients who are having symptomatic reflux even after POEM. Now the future direction is Dr. Haru is innovating this needle, and once you get this needle, I think the durability of the wrap would be much more, and then we can use this procedure much more. So we are waiting for this needle to be commercially available. Coming lastly to the Zenkers, This is a diverticulum, as we all know, and the cricopharyngeals, and the principle of management of this diverticulum, which causes dysphagia, halitosis, and regurgitation, is to cut or sever the cricopharyngeus muscle or the bar, and which is open, and make it open into the esophagus. Traditionally, what we have doing is just cutting the septum for this so many years. Either you cut directly or you cut it with the help of the special equipment, that is the diverticuloscope. This is a diverticulum which you are cutting. You can use a clutch cutter and directly cut the diverticulum as we are showing here, and this gives good results. This is, you can do it with any other knife. The outcomes of this is you have a modest clinical success of around 60 to 100%, but there is a chance of recurrence of 20 to 25%. This has been shown in so many studies. And the reason for this is large diverticulum and or a length of the septotomy which is small, and sometimes you do not do a complete septotomy for the fear of perforation. And therefore, as you can see here, you have a significant recurrence. So the Z-poem concept came, where you have to, instead of cutting the septum directly, what we do is inject at this point here a couple of centimeters proximal to the septum. Once you have done that, what we do is, like in poem, inject, put an incision, make a small tunnel, go inside, identify the septum, dissect on both the sides of the septum, on the esophageal side and the diverticular side, and then cut the diverticulum and come out. So this had given good results in a couple of comparative studies and a multi-center study which we were a part of. And it has been shown to have recurrence which has been decreased to around 6.8%, 6.7%. This has still been modified while avoiding to make a tunnel, because there were chances of getting lost into the tunnel. There were chances of getting fibrosis in the tunnel because of a lot of stasis of food sometimes. So instead of putting an incision away from the septum, people have started now putting incision on the septum here. This is a similar thing. So this is a septum, inject on the septum directly, make a small horizontal incision, again just on the septum, expose the septum, and you can cut the septum either with a clutch cutter like this you have shown here, and close the septum on this. The same thing can be done as shown in this here with using insulated tip knife. So the modification negates the need for proximal tunneling, improves the working space, enhances your mucosal closure, makes it simplified, and there is a small theoretical risk of leak in these cases. So this modified Z-poem, now what happens with this is there is a mucosal flap which is left. Now this mucosal flap can contribute to residual symptoms. So concept of cutting this mucosa has come again. So what people do is, once you have done the septotomy, this is the residual septum which is left. This septum has to be incised, and this septum is incised as shown in this, that what we do is apply clips at two ends of the septum, cut the septum in between, again go distally, apply couple of more clips, cut the septum till you reach the base of the diverticulum. Now what we achieve after doing this septotomy or the mucosotomy is you have created a large tunnel, a large opening between the esophagus and the cricopharynx, and there is no septum which is left or no mucosa which is left. So this concept has revolutionized the Z-poem. Last month conference we saw this case which is still in evolution, is they do a septotomy and a mucosotomy and do not close the defect. This is something new which has come. This is called an open Z-poem, and this is also showing to have some good results as per Dr. Mohan Khashab, who has developed this procedure. So it's just like doing a Z-poem with a mucosal incision, removing the mucosa and the septum and leaving the entire space open, and the patients do well. So we have to wait for the results till we come here. This is the comparison which we have already told you. So basically what we can opt for is Z-poem doing incision on the septum, which simplifies your procedure, and removing the residual mucosa, leaving it open or not, we will see for the results to wait. So, any optimal approach for Zankers, yes, this is a procedure in evolution. Lot of modifications are still going on, and we need good studies and good data to see which is the best method for Zankers. Thank you so much for your kind attention, and if there are any questions, I would like to answer them.
What is the advantage of Z-poem over surgical septotomy?
What is?
What is the advantage of Z-poem over surgical septotomy?
The advantages is the recurrence. The only advantage is recurrence. There is 25 to 30% recurrence in only doing an endoscopic or a septotomy. The recurrence has been reduced to less than 5% using the Z-poem technique. The only thing is because when you are doing a septotomy, you leave a part of the septum behind just to avoid perforation or going into the mediastinum. So this can be avoided, and you have a good mucosal cover over it.
Okay. You have said about G-poem. What is the effect of G-poem on the patient's nutritional status and sugar control? Because we are doing mostly in the diabetic patients. So what is the effect on sugar? What is the effect on nutritional status?
Nutritional status has definitely been shown to improve with the GCSI score, and the diabetes part, I don't think there is any study which is showing any improvement in diabetes because of G-poem. But nutritional status definitely has been shown to improve, and as with the GCSI score.
Sir, any role of any medical therapy, sir, regarding this acosamiide or prokinetics along with this G-poem to relieve the refractory gastroparesis, which are not responding to? So any failure rate?
I am not aware of any study which has compared prokinetics. Routine prokinetics are prescribed even after G-poem, but these newer modalities, probably there is no comparative head-to-head study so far.
After G-poem, do you do again repeat intradural motility studies to see how much is the improvement?
Yes, definitely. That is, these what recommendation is that you do an endoflip during the procedure. You see for the distensive bleeding, it has to be more than 10. If it is still less than 10, then you have to still increase the myotomy or maybe do another incision. So this has to be done. Thank you so much.
We go to the next session, which is on algorithmic assessment of the pancreatic cystic lesion. The talk will be delivered by Dr. Sandeep Laktakia. Dr. Sandeep, please.
Good afternoon, everybody. At the outset, I would like to thank Dr. Anil Arora, Ashi, Dr. Praveen, and the entire team for inviting us to this conference. I'll be speaking on algorithmic assessment of pancreatic cystic lesion. In this, I would like to cover the types of pancreatic cystic lesion, what do the guidelines say, what is the role of EOS in pancreatic cystic lesion, and what is the algorithmic approach which we would follow. Pancreatic cystic lesions actually are quite confusing, and there are several guidelines for it, and that's why it adds more confusion to it. They address to the aspect of diagnosis, the surveillance, the need for surgery, and how to do forward. The prevalence of these cystic lesions in the pancreas is rapidly increasing because more and more cross-sectional imaging has been done. It's at the average rate of diagnosis between 2 to 14%, and this frequency is increasing as the patient's age is higher. For example, patients who are more than 70 years, about 40%, that is 2 out of 5, will have an incidental pancreatic cyst. Younger patients, the chances are much lesser. Also, the chance of finding a larger cyst that is more than 2 centimeters is much lesser. So most often the cysts that are found in elderly patients, and most cysts are less than 2 centimeters in size. Then the concept of several different types of cysts come into picture, and all of them have different clinical connotations. For example, they can be, apart from pseudocysts, they can be cystic neoplasm or serous cystadenomas, mucinous cystic out of all these non-pseudocyst related pancreatic cysts, the most common is side branch IPMN as from the Western literature. Now, among the mucinous cystic neoplasm, which includes MCN, IPMN and the cystic peanuts, they have the malignant potential. The mucin producing are the MCN and IPMN. Sorry, the ones which I said earlier which have a malignant potentials are, apart from mucinous cystic neoplasm, is SPEN and neuroendocrine tumors. Then the SPENs are more often found in younger patients, especially females, and they often require surgery. Then cysts which have a communication with the pancreatic duct are either pseudocysts or IPMNs. Now, some of the cystic neoplasm can have a classical appearance on imaging that has been done before they come to us, which can be either MR or CT for any other reason, and that's how they're commonly diagnosed and as an upfront assessment of pancreatic cyst neoplasm. For example, this is a serous cyst adenoma with a central calcification. You have several small cysts with a small hyperechoic center, echogenic center, and if you do EUS in some of them, you will find either a cystic lesion which has multiple tiny septa called as microcysts, and on the right panel you have a classical serous cyst adenoma which has multiple thin septa, small and large cysts and central calcifications. So if you find this kind of a feature, then you can stop there itself and no further investigation may be required. In fact, even FNA may not be done. Mucinous cystic neoplasm, on the other hand, have more of a peripheral calcifications, and they do not communicate with the pancreatic duct, and they have a risk of malignancy developing in them either then or later on. And if they are large in size or have the solid component which is much bigger, then they need an EUS and or FNA at the same time to establish or confirm the diagnosis. This is one of them which has a thick wall and one area of mural nodule in the left side. This is another cyst on the right panel which is a larger cyst with multiple thick septa and little bit echogenicity on the posterior wall. Coming to the IPM, which are much more common as we grow in age, they can be main duct IPMN or on the side branch, which hang like grapes from the side branch of the pancreatic duct. The main duct IPMN, if they're coming almost to the papilla, can have a mucin plug at the mouth of the papilla, which looks like a fish mouth appearance, and that's a sine qua non of a pancreatic cyst neoplasm of the IPN variety. On EUS, if you try to confirm these cysts, this is an side branch IPM which is hanging from the main pancreatic duct inferiorly towards the deeper part of the head and uncinate process. And the main duct, which is dilated, will have multiple soft tissue masses like inside, as like globules, or even soft stones can mimic like that. MRCP or ERCP you will have appearance differently. You will have dilated duct with filling defects, which are mucin plugs. Side branch will hang out, and they can be combination of both side branch and the main duct IPMN. These are some of the characteristic picture which I'll skip. Coming to the guidelines which have been given for the pancreatic cyst lesion, and there are several of them. As you can see, when there are more than one guideline available within a short span of time, that means there is a lot of confusion in this area. There has been one from the Sendai classification, then AGA classification, Fukuoka classification, and even AJG classification. All these add to the confusions. The common 5 ones are these which have come in last 8 years or so, and there is now a process going on of combining all these guidelines together, and hopefully next year or so we'll have a combined uniform guidelines from all the societies put together. So the current guidelines are having poor recommendations because of the lack of data supporting them. Nevertheless, one guideline which I'd like to sum it up with, which is the ACG, which is the most common one or preferred from the clinician's perspective. If you look at this chart, which shows that based on the cyst side, all these classifications are a little different. Incidental cysts is in AGA and the ACR, the radiology guidelines, whereas mucinous is only Fukuoka. All cysts are taken by the European guidelines. Based on the imaging, they can be MR or CT, which are done upfront, which diagnoses the problem, and MRI is generally more preferred in most of these guidelines. Coming to the indications, when do you decide to do an EUS when a patient has a cystic lesions? And not all cysts require EUS, they require only if they have high risk feature or worrisome features on the upfront cross-sectional imaging. So like example, if this in the AJ guidelines, the indications for EUS is only 3. If the cyst is more than 3 centimeters in size, if it has any solid component on the imaging, and the dilated main pancreatic duct. But if you look at the worrisome features from the Fukuoka guideline, there are many more apart from those 3 which were there, which includes upfront dilated duct, history of pancreatitis, presence of lymphadenopathy, CA19-9 high, and even the rise in the size of the cyst size. The radiologists look at the radiological component of it, and they look at the cyst, change in the cyst size along with some peripheral calcification on imaging, nodule or thickened wall, and if the duct is dilated. So when do we suggest more to be done for this pancreatic cystic lesion or refer them to surgery? Is when they have high risk stigmata, which suggests more chance of malignancy in some of them. About 20% of the mucinous cystic neoplasm can have malignancy. More than 50% of main duct IPM can have chance of malignancy in future. So the high risk stigmata is if somebody has obstructive jaundice with a pancreatic head cyst, nodule which is more than 5 millimeter in size, if the main pancreatic duct is more than 10 millimeter upstream to that cyst, or suspicious or a positive cytology and FNA if it has been done, or the primary cyst is more than 4 centimeters. The Fukuoka classification says about the pancreatic obstructive jaundice, presence of acute pancreatitis, and so on and so forth. So all these things, there are several risk factors and high risk features which suggest that something more should be done if these are present. If none of these are present, we can probably watch and wait and see how the cyst evolves with passage of time. So all symptomatic pseudocysts should be, not pseudocysts but cysts, we can perform EUS or consider surgical evaluation. Those who have low risk features can be observed, and those who are indeterminate can have a second imaging by EUS with or without FNA. Looking at the surveillance, how do we follow these cysts once we have found them, is that those cysts which are small in size can be surveyed at a long period in between, 1 or 2 years or even 3 years in some of the guidelines, but cysts which are 2 centimeters or more require more frequent or shorter intervals between the 2 imagings. So how do we decide further management of these pancreatic cyst lesions? The balance has to be that these cysts should not develop malignancy and they should not evade a detection. Of course, we have to look at the cost analysis and the risks of following them versus risk of operating them. We know that the mortality rate, even in a cyst which is asymptomatic, is about 2%, which is accepted, and the morbidity rate after surgery is about 30%, which is accepted. So which imaging to characterize these pancreatic cystic lesions? MRI is obviously the first choice, means it's non-invasive, lack of radiation. It also helps in detection of any communication between the duct and the cyst. But if this imaging is confusing, you can resort to a second imaging, which can be either a pancreatic protocol CT or an EUS. Both are excellent. And also consider you can do FNA if there is a suspicious of any mass lesion or anything which is more suspicious for malignancy. However, one should realize that all these imagings are not foolproof. At best, even the MRI, which is supposed to be the best, has a diagnosis of only 40 to 50%. It also excludes a malignancy from a benign disease in about half to 2/3 of the patients. I'll skip a few slides. When do we consider EUS in these patients is if you have to do an aspiration of the cyst fluid. CA used to be the common marker, but it's going down in reputation, and the new marker which has come is a very simple test, is intracystic glucose. Levels less than 50 are very suggestive of mucinous cystic neoplasm with or without malignancy, and this can be done bedside with a simple glucometer. Cytology of these cystic lesions is very poor of the pure fluid. However, if there is a solid element, we should target that as the target of getting the tissue from. Other methods of taking the tissue from the cystic lesion is through the needle microbiopsy forceps, which go through a 19 gauge needle to the area of interest, which is generally the opposite wall, So you pass a 19 gauge needle, keep it in the center, then you pass through the hollow of the needle a micro forceps, which then goes to the opposite wall and plucks out a small bit of tissues, quite similar to a cholangioscopic guided biopsy. This is a very recent algorithm and a very simple to approach. Is any patient who comes to you with a pancreatic cystic lesion incidentally found, you need to get an MRCP with an MRI and also evaluate the symptoms. If the patient has symptoms and a cyst, it's best to refer to a multidisciplinary meeting. If there are no symptoms, or if there is only one worrisome or high-risk feature, then they can again be referred. So those patients who have no symptoms, no worrisome features on the imaging, and incidentally found cysts which are small in size, they can just be observed, either 1 or 2 years depending on the size. Larger cysts can be observed more carefully and continuously. In the end, I would like to conclude by saying that accurate characterization of the pancreatic cyst is a key to management. However, the current imaging is not foolproof. Only 50 to 60% diagnosis can be made. Any high-risk features, both clinically or on imaging, should be followed up with a further investigation, which can include EUS-guided FNA. Surgical resection should be considered in patients who have high risk on imaging, with or without FNA suggestive of dysplasia or malignancy. And surveillance is based on the cyst size, location, dilation of the duct, and any high-risk features. Thank you very much for your kind attention. I would like to invite all of you to the EUS meeting, India-US Summit in Hyderabad in December 1st, 2nd, 3rd.
Sandeep, any experience with the oncogenes in the cyst fluid, like KRAS?
Okay, those are molecular markers in the cyst fluid analysis. I personally do not have any experience in that, but there are several studies from the Western world which have shown that those are quite useful and effective, but they are all done under research protocols and not available as a clinical practice.
On CT or MRI, the cyst appears benign. Patient is asymptomatic, but there is history of pancreatitis. What should be the approach?
So that's a very interesting question and a very important one. Patient has history of pancreatitis and has cyst. So it could be an acute necrotizing pancreatitis which has led to a cyst formation, depending on the course of the disease. If at the onset we have done a CT in the first 1 week or so, which is normally done, and there was no cyst at that time, then it is a pancreatitis leading to a cyst formation. But if you find a cyst right in the beginning of the pancreatitis process, then that cyst could be responsible for acute pancreatitis. And these kind of lesions are usually seen with side branch or main duct IPMN, and these cysts, if they have now got a history of pancreatitis, should always be operated. One, they have high risk of malignancy. Second, they can cause another risk of pancreatitis.
I think there is no question when we close the session.
Thank you very much.
Thank you, Sandeep. Thank you.
Thank you all our respected speakers for such informative discussions we had. Thank you all our chairpersons and the moderators also for conducting this session. We now have approached to the end of our session and our conference too. And the topic of our last of the sessions is challenges and solutions for some problems we face daily. For this, as chairpersons, I would like to invite on the stage Dr. Ajinkya Dhagne, Shirdi, Maharashtra, Dr. Akshay P. Bhangle, Bhangle Hospital, Pune, Dr. Saroj Dubey, Kailash Hospital, Noida, and Dr. Praveen Sharma, Sir Gangaram Hospital, New Delhi. And as moderators, I would like to invite on this stage Dr. Sridhar Chapidi, Hyderabad, Dr. Saurabh Algar, Indore, Dr. Ravi Mukati, Delhi, Dr. Balwant Kushwaha, Bhel, Uttarakhand, and Dr. Naresh Bansal, Sir Gangaram Hospital, New Delhi. I would like to invite all the chairpersons and moderators and call the respective speakers for the talks.
Good afternoon. Now, as we are coming to the close, we have a very interesting session, and which is something we all face on an everyday basis, managing an angry patient and relative. And for this, we have none other than the esteemed Dr. Gauradas Chaudhary. I invite him to please.
Thank you very much, Dr. Anil and Dr. Ashish, for the invitation. Time is short, so I'll just make it very brief. Listening to the last 4 or 5 talks, I was filled with trepidation that, doing such complicated procedures in complex situations, it can't always turn out the wonderful way that you show. I mean, there must be problems. And normally in conferences, we often highlight our successes, but we often shy away from talking about disasters. Right, Sandeep? So I was just thinking that all of us have faced these problems, that if things go wrong, how do you face relatives and patients? Some of them might be tolerant, some might not. So I'll talk a little bit about that aspect of communication and what the literature says. So there are these emotions which come into play: anger, anxiety, concern, frustration, dissatisfaction, and loss of trust. But today I'll just focus on only one, that is anger. And anger is actually a pretty common kind of a thing when things go wrong, especially with relatives. So here is a small question. I don't have voting pads, but just make up your answer in your mind. So if a patient or a relative is very angry because something has gone wrong, right? Like after a complex procedure, what's the best way to handle him? The initial step. Explain to him in detail about the situation and what you're doing now. Send your junior to deal with him because you're hearing a lot of noise on the corridor. Call the security. And fourth is endorse the anger. That is, you go and say, yeah, I understand. If I were you also, I would be very angry. So, have you made up your mind? All of you. So, the situation in hospitals are never smooth. I mean, if everybody says it's a wonderful place, it's all peaceful, as Chandrasekhar often tries to portray, come on, yeah, it means you're hiding something, TSC. So, the patient is often apprehensive, dissatisfied, frustrated. There are personality problems, high expectations, financial problems, long waits. The setting is also not very conducive. Lack of facilities, overcrowding, long waits. And for doctors, all the complex procedures that have been taught to you and that you have mastered, somehow communication has not been a part of our training during our formative years. And we have tried to emulate from what we have seen. And some of our teachers may not necessarily have been very good communicators. They might have been brilliant in performing procedures, okay? So that's why we often lack that little bit of communication skill, empathy, and prioritization of time. And usually when a situation goes wrong, these are the things which makes the pot boil. So something has gone wrong, you are really wondering what? Something has not really been okay, you see nurses and others hurrying in and out, but there is a delay. Then there is ignoring the anger, trying to look the other way and say, okay, you wait. Now, the longer you make a fellow wait, the pot is going to boil more. Then try explaining when he is not receptive. So you say that, look, I put in this guide wire, but because something happened, so the guide wire didn't go into the place that it was supposed to. Damn you, he is not interested in where the guide wire went. He is interested in what happened to his relative. Then retaliating with blame. This happened yesterday. There was a patient who was a very old patient of mine, and she was recounting about her father's death and says, when I took him to the hospital, they said, you have brought him very late. His condition is very sick. So you don't put the blame back on him. Do tell him that his condition is sick, but don't blame a relative who is already frustrated. Then sending someone else, which in institutes we have often done, send the senior resident to kind of pacify. And this is the chain which actually triggers a lot of anger. So this is, the next two slides are the most important. So anger is an emotion. And you know, emotion is usually somewhat blinding. It does not allow you to be receptive to logic. And most doctors will go to the patient and try to talk logic. Look, you know that I had told you 3% complication rate. So this is what actually happened. The papilla was located somewhere else, but you know, I tried. Oh, come on, he's not interested at that point in time. So this is the crux of what you should carry home, and I'll tell you my source. Listening occurs on the listener's terms, not on the terms of the person who is telling. So you have to understand that he has got a filter in front of him, and he is looking at the whole thing from one side of the prism. And if you are trying to cross-talk from another side of the prism, you're not going to make any headway, or it will take a lot of time, okay? This particular quote, I'll encourage you to keep in mind, and I'll tell you the source. So when you have unpleasant consequences in every place, the common thing is, oh, there is a lack in communication, so we can sit and talk. Sure, we can sit and talk, but you know, how do we start the talk with an angry patient? So the most important aspect is empathy. Now this word is very often used and it's confused with another word called sympathy. The two are not synonymous. Empathy means, hey brother, you're very angry, I understand how you feel. That is empathy. Not that, look, I'm sorry for you. Okay? And endorsing the emotion by just telling that, yeah, I think I understand how you feel, I would have felt the same way, that is actually empathy. Okay? So, pause for a while, emotions take time to settle, it takes an angry patient to actually understand your communication, so you can't immediately rush to your guide wire. Okay? And help is, let me try my best to see how I may help. Talk in general terms, not in technical terms. So this is a beautiful book I was reading, and I'll just share that with you. There are 4 types of broad personality types. You know, earlier we used to think there are 2, the type A and type B personality. And according to Briggs-Myers, there are 16 types. But for general purposes, remember that there are 4 types. One are the drivers, the aggressive leaders who will always come in front. The others are the socializers, the very talkative ones who would froth up passions. One is the cool analytic type, the type, you know, who is keeping quiet, but he might make a case in court and drag you to court. He is not going to show anger there. And then the amiable passive type, you know, often you find some relatives behind, some in front. So the analytic and driver types are task oriented. Okay, they have to get hold of you in some way, either through anger and catching your collar, or by taking you to court. The other 2 are more sociable. They will accept it passively. Okay, my time is up, so I'll go forward. So if I now ask you the same question, if the patient and relative is very angry, what's the best way to handle him? I hope you have got the answer. The answer is D, endorse the anger. And you know, when I gave this talk in another meeting, which was more full, the young people didn't actually guess that it was D. They thought it was 1A. And all the mature guys, Anil Arora types, they all guessed that the D was the right answer. Right, Anil? Now I'll just go to the next step. So calming the angry patient is the first step before you can get him to be receptive to what you are telling. And then you give the explanation. And this is what is often missed out. And this is the book I was talking about. It's called Surrounded by Idiots. It's a very, very provocative title. It's by Thomas Erickson, who's an international expert on communications and, you know, on personality traits and how to do that. It's a fascinating book. And don't think that they are all idiots. There are different types of people. But often doctors think anybody who doesn't come on his frequency is an idiot. And that is what this book refers to. But you have to understand personality types when you communicate. So when they get angry, poor communication is the primary problem. And what it means is that first endorse his feeling and then go to the logic part of it. Last slide, if you do not learn from mistakes of others, you will learn from accidents. It's a beautiful African proverb, and it's absolutely true. So if I see another colleague of mine getting into trouble, I must know what made him get into trouble, and I should avoid that. Whereas you think, oh, it happened to him, it won't happen to me. And then it happens to me the next day, then you realize, oh, it could happen to me. I mean, that's actually what this African proverb is all about. So all the best. I hope you have a good time with your angry patients and you develop the art of dealing with them. Thanks a lot.
That was a very fascinating talk.
Yeah, excellent talk, sir. So many times the anger is towards the whole system. For example, the resident has delayed and he has not attended, and then it comes back to the consultant and all that. So how do...
So I think the first step is agree that, look, if I were in your situation, I would feel the same way. That's the step which would make him receptive. Then you would say that, look, this is a crowded hospital. I do understand that there must have been shortfalls, shortcomings. In fact, the best thing is to admit it in a way that there have been shortcomings in any organization where there are so many human beings and so much of stress, so many demanding patients. Problems do occur, but if I were you, I would feel the same way. But let's see what has happened now, how can I make it better? So that becomes a starting point for conversation. Any other thoughts? No? Thanks a lot.
Thank you so much, sir. Thank you. And now we come to the last lecture of the day, of the session, is screening for HCC in cirrhotic patients. Why is it not delivering? And may I invite Dr. V.A. Saraswat to please come.
Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. As always, GC is a tough act to follow, but then I've been following him all my life, so I'll continue doing that now. At the outset, I'd like to thank Anil and Praveen and Ashish for having me here. I am the tail ender, the last batsman for the second consecutive year in the CHBD meetings. And I'm thankful to them for accepting my request for a change instead of Friday to do it today because of prior commitments. So now it always happens, you know, they give me a topic for 15 minutes and then the clock says 10 minutes. Well, I'll try, but I don't promise to be as efficient as GC has been. So Anil asked me that a lot of HCC surveillance is happening, but why is it not delivering results? Why are we not getting what we expect from HCC? So I'll try to answer that question in the next few minutes. And some general things are that, as you all know, HCC is the fourth most common cause of cancer death today, particularly in Africa and Asia. And a very large number, 854,000 new cases are occurring every year, of whom over 800,000 die. And this number is set to increase dramatically over the next couple of decades, not only because of the aging population, but because of NAFLD rising and the number of cirrhotics living longer. Globally, that is the scenario. In Europe, about close to 80,000 deaths in 2020, scattered all over the continent and costing over $4 billion euros to deal with. In UK, there has been a threefold increase over the previous 20 years in the occurrence of HCC as well as mortality rates. And their own assessment and audits say that the surveillance there is poor, and only 1 in 5 of eligible patients actually manage to receive curative treatment. Data from India are very deficient, but one review that Abhijit Chaudhary and his colleagues had done from Kolkata had shown that probably 23.6 per million is the number of deaths due to HCC in our country in 2016. Probably an underestimate of the total numbers and accounting for something like 34,000 deaths every year if this number is to be accepted as it stands. So with this background, now what is screening? Screening are tests done to detect a disease when an asymptomatic patient at an early stage with the intention of offering curative treatment and thus reducing mortality in that condition. And when screening is done at regular intervals, we call it surveillance, which requires that we should have sensitive and specific tests which should be non-invasive. Not only that we can detect it early, but that entity should be amenable to effective curative interventions at that stage of detection. Now, almost all current guidelines, some of which I have listed here, say that we should screen all patients with liver cirrhosis who are at high risk of HCC at intervals of 6 months using ultrasound alone or ultrasound with alpha-fetoprotein. This approach has several limitations, not the least of which is that the 3 A's, poor awareness on the part of the physician and on part of the patient, poor access to these resources for screening or to programs where regular screening is offered, and even if there is such access, there is poor adherence on the part of the patient in complying with the timely interventions and investigations that are needed. So with this background, why exactly are we offering surveillance? We are offering surveillance because of these landmark studies that were done in Chinese patients, which clearly show that the way it was devised, HCC surveillance does work. In this large randomized controlled trial from China, over almost 20,000 patients who were surveilled and followed for a period of 5 years, there was a significantly lower mortality rate in those being surveilled vis-a-vis those not being surveilled. Since it's very difficult to carry out such large RCTs, meta-analysis of over 59 studies involving over 140,000 patients confirms that those who are detected in the course of surveillance have a lower mortality rate, and that in fact we are successful in detecting tumors at an early stage where more often curative treatment can be offered. So since the evidence shows this, so all guidelines will recommend that 6 monthly ultrasound and alpha-fetoprotein should be offered. Who should we surveil? Well, EASL says that if the annual risk is more than 1.5% per year, then that category of patient should be offered surveillance. But there are again studies from radiologic literature which show that ultrasound is cost effective and is non-invasive. So even at a lower risk of a 0.4% per annum risk of HCC, surveillance can be offered. And this includes people in Child's Pew class A and B, where the HCC risk is above the threshold of 1.5, and in the subsets of non-cirrhotic patients with active hepatitis, family history, ethnicity, where they have a slightly lower incidence rates but still fall in the group where surveillance can be offered. There is a debate about chronic hepatitis C with advanced fibrosis, should it be offered, and many subsets of porphyrias, regardless of severity of liver disease, also have an increased risk of HCC. One proviso that must be paid attention to is that screening should generally be offered to patients who are fit for and can undergo active treatment for early HCC were it to be detected, rather than people who will be unfit for such therapies. Again, current guidelines do not recommend HCC screening in advanced CTPC patients who have a short survival unless they are on a transplant wait list, people with inactive HBV infections, and in the NAFLD-NASH group, because of the very low frequency of cancer that is seen, it is only recommended once cirrhosis sets in and not in the non-cirrhotic population. Again, patients with comorbidities and poor performance status cannot be offered thresholds. So this summarizes who are those at the high risk, and since I'll skip over this. How we do surveillance is 6 monthly ultrasound scans. Why? Because the sensitivity is shown here is quite low for small tumors. It's acceptable for larger tumors than but 4 centimeters, but then they may not be at a stage where they can be cured. Why 6 monthly? Because literature suggests that that is HCC doubling time is about 120 days, and we can detect tumors where something can be offered. The CT and MRI are generally reserved to explore patients where abnormalities are found on screening, but the sensitivity of ultrasound and alpha-fetoprotein for HCC detection combination does get better. Nevertheless, still 1 in 3 who are screened with ultrasound and alpha-fetoprotein will miss 1 in 3. Sorry, I'm barely halfway through the presentation. I'll try and go a bit faster. So how we follow up these lesions and is shown. This is the Lyrad's algorithm, and I will not spend time on this because of the shortage of time that I have. Now, what are the real world scenarios? Several of them are available from UK, USA, Canada. I'll just stick to this from the NHS. A survey was carried out about the efficacy of surveillance programs, and as you can see, fewer than half of the centers actually responded. What they responded was that there seemed to be an acceptable 80-85% levels from part of the doctors in communicating, giving appointments, in choosing the patients, and even there was a fair bit of compliance with the patients. This shows the centers, but the adherence was only 2/3. And comparison with a similar survey done in 2014 and 8 years earlier in 2021 showed that really nothing much had changed in their practice for the last 8 years, and although the numbers of patients had trebled, the screening had not kept pace and had not picked up similar levels of patients. So how can we improve this surveillance? Well, recently the EASL has come out with a policy statement in 2023 which talks about risk-based surveillance. And what is this? Something that's being found effective with breast cancer, lung cancer and similar conditions. And it basically says that instead of using one size fits all with ultrasound and AFP being offered to everyone, you should individualize the screening to those based on the risk of development of advanced disease, using stratifying the target population using risk scores which offer specific cutoffs, and identify a high risk group who are likely to develop HCC, which may be fatal for them before the patient dies of other causes, and they must be offered the best surveillance, including targeted MRI screens rather than the ultrasound to pick up early lesions in time to offer curative therapy, and identify the low risk group who have advanced disease or may die of other causes rather than HCC, and this number may be as many as 10%, while the high risk group is about 20% according to some studies, where you can then withhold and not offer any surveillance, because surveillance entails further interventions to clarify the false positive responses. And the advantage of risk-based screening is that it allows you to focus with more advanced imaging and approaches on the risk which is most likely to benefit from screening. So instead of a one size fits all for 100%, you can have a risk-based strategy where 10% may require no surveillance, 20% may require MRIS surveillance, while in the intermediate group we may continue doing what we are practicing till better evidence is available. So this one pilot study I'll talk about from Scotland in 482 patients with a median follow-up of 5.3 years, used 4 different high HCC risk scores for assessing the risk and stratified them into low, intermediate and high risk. And what they found was that while overall over 5 years 4.5% of these patients did develop HCC, that is 22 of these cohort of 482 patients, 4 times these patients actually had false positive scans, and this triggered cross-sectional imaging costs, and the number needed to show benefit was very high, almost 250, while the number needed to harm, that is to do tests which were not required and could have severe harm as well, was actually quite low. 1 in 36 required further evaluation by CT, MRI often repeatedly, and a few even needed liver biopsy because of inconclusive screening results. Now, a variety of models have been advocated, and I think I've run out of time. The REACH-B score for hepatitis B, HCC score again for post-hepatic cirrhosis. There is this Toronto HCC risk index for different cholestatic as well as viral forms of hepatitis, and recently a risk score for HCC risk in NAFLD and alcoholic liver disease has been proposed. So work is ongoing. Thresholds for low, intermediate and high risk are being set up, and there are now strong proponents for using risk-based strategies for this. The AMAP is another one of these scores which has just come out in a couple of years ago in 2020. So these are present. So in conclusion, screening for HCC seems to be at the crossroads. While we all guidelines still recommend 6 monthly ultrasound and alpha-fetoprotein, there are a host of problems and a high numbers needed for benefit with low numbers needed for registering harm. Lack of awareness, access and adherence continue to plague screening programs, which will work even once strategies improve, and we need to work on that area. There is dissatisfaction with the one-size-fits-all approach, and improved approaches like risk-based surveillance strategies using better HCC risk prediction tools and establishing cutoffs for risk stratification so that we identify those who will be harmed by screening, like those with a low risk of HCC can be excluded from surveillance programs, are required. So precision screening for HCC is on the way, but not here as yet. Thank you very much for your time and attention. Well, actually, in India, first you set up surveillance programs. There is no organized surveillance of any kind going on in India at all. So centers which are seeing a lot of cirrhosis patients and people who are transplanting them, I think surveillance programs need to be set up, maybe not by the government alone, but by initiatives taken by the individual hospitals for their populations. They've identified them. And I guess the risk-based screening strategies probably you can leapfrog the standard screening programs and move on to risk-based strategies, since the scores are now available and can be validated in our populations.
So actually you answered what I was about to ask, actually why the surveillance is not delivering, because it is not happening. It's in all the patients who come with large HCC, and I think the last ultrasound must have been done quite years ago. So it's not happening. Or only a minuscule of population whom ultrasound is being done regularly, but though hardly we are seeing any tumors. But the large majority, especially NASH related, where there is not even cirrhosis, only advanced fibrosis is there. So
right. So I think in India the problem is very different from what I have reviewed. I have reviewed the world literature and where the world is going and where the best available strategies are being implemented. There are formal programs. Even there is significant room for improvement of surveillance strategies, is what I've tried to communicate. In our country, where nothing is happening, the first step is to start something. And as I was saying, that now that risk-based HCC risk scores are available, doing a more effective way of screening with the risk-based surveillance strategies may actually yield results even with a smaller database of a few hospitals, or say a city like Delhi, which has such tremendous resources and so many groups. So I guess it is worthwhile and something that needs to get started.
Yeah, my question is to Dr. Vivek, Dr. Chaudhary and T.S. Chandrasekhar. Most of you have at least 4 decades of practice, and a significant proportion must be coming to you for follow-up. And I'm sure, you see, you will be asking them and doing a surveillance. How many have you picked up during surveillance HCCs? I'm sure you will never say no to a person with 6 months alpha-fetoprotein and ultrasound. How many have you picked up over the last 30 years, all 3 of you? Or if you don't pick up, where is the problem?
The 3 A's that I talked about: awareness. So you are aware, you are telling your patient. The patient is not convinced. He comes, he does once, twice, in deference he gets it done, but he doesn't. Adherence is very poor. So surveillance and yielding results doesn't happen in 6 months or 1 year. It has to go on for quite a few years, 5 to 6 years, where you will pick it up in this risk group. So adherence is not there, access is not much of a problem here, and the awareness. Most physicians are not counseling their patients.
So you are right that I do not think that I can recall too many patients maybe in low single digits that we have picked up, mainly because despite every reiteration, patients do not adhere. In the private setup, I'm finding with a one-to-one rapport with the patient, probably compliance may be better. But in large public sector hospitals, all of us have worked in these places, each time the patient is seen by a different doctor who has a different emphasis on the need for surveillance. So that is, could be a reason, and I think.
No, I would entirely agree with Vivek, because I think my practice in Lucknow, you see, people were not aware. So you told them, I mean, it was either bordering on the side of scaring them or making them into a routine, and it didn't often yield results. In my practice here in Gurgaon, most of the people have been on the internet, so the awareness levels are high. So when you tell them, they actually do it not for my sake, but for their sake. And therefore, I would have picked up at least about less than 10, but over a period of time, and reasonably early for some actionable thing. But it all depends on the awareness creation, which I would endorse what Vivek is talking about.
Nice talk, Saraswat. I think the point is, we have not made a national level protocol. The leaders in this field and should have a multicentric protocol. And the diabetologists have succeeded. Any patient come to the clinic, let it be private. I know more about private. They have to have the screening for retinopathy, nephropathy and neuropathy. And they pick up the early level, the diabetic foot therapy. It is very successfully managed in Chennai, I know that. Such a level of protocol, we need to form it. Whether I am seeing 5 cases or 50 cases, they have to go through the process. Ultrasound is very cost effective, alpha beta protein also. And affordability will not be issue in private sector at all. Only thing, the will is not there.
I think you're very right, TSC. And I think, well, the INAZL is one association that has been very proactive in making a lot of consensus statements, recommendations and guidelines. And some of the leaders in HCC workshops, I think Anil and Ashish and Praveen are right here. So possibly, Anil, I think some thought for you to work on, that this seems to be something on which guidelines should be put out, and eventually not just guidelines, most of our guidelines, their penetration needs to be improved. So sessions to ensure that guidelines are followed by the practitioners also in INAZL should be organizing at some point.
Yeah. So far as guidelines are concerned, you are passing the buck to the general public. But my issue was even seasoned people like you, senior level, how many have we seen in 40 years? I'm sure there is no lack of awareness on your part. Adherence,
the awareness and the patients is the issue. Once the patients are informed, their compliance and their adherence to these guidelines over a period of 5 years or 10 years may not be as good as it can be. It is there in selected patients. We are picking them up and they are coming. But to ensure it across the board and consistently over a period of time is where we are faltering.
Anil, I may disagree with you that we are not doing it, so we really don't know the statistics. Even if you pick up one case also, that will be beneficial for the patient. Not that you should pick up 50 cases, but should be level and percolate to the entire
I
nation.
totally agree, but I think the problem lies where the patient is getting the ultrasound done also. Because all the radiologists, they are not tuned to see the cirrhotic patients, and sometimes they even miss that patient has cirrhosis. They just write down patient has a fatty liver. So if we are not training our radiologists to see for that small SOL, it may be possible that even the patient is adhering, they are missing most of the things.
You are very right, Praveen. I think this is almost all guidelines and all critical reviews point this out, that the sonologist training, following a particular protocol, algorithm and reporting it according to a particular protocol is important for this to be picked up. And I think this is where actually the risk-based strategy would actually work. If you really identify the high-risk stratum on scores, you actually are moving to an objective thing like MRI to pick it up earlier. It may be more cost-effective, but head-to-head strategies of large cohorts being screened by one versus the other modality will probably give us the answer.
Sir, you talked about limited MRI scan for surveillance. So it is non-contrast MRI or contrast MRI?
It's a normal non-contrast MRI is what is...
so there are studies which have shown that even non-contrast MRI is better in picking up smaller lesions. So do you think in selected patients, at least those who can afford or where the facility is available, should we change our surveillance strategy from ultrasound to limited MRI scan?
So limited MRI scan actually is being recommended for those who are at high risk. As I talked about these, I didn't really get time. I skipped through most of the stratification scores. 4 or 5 very good stratification scores are now available which give different cutoffs. And if you can identify patients who are at a high risk, even in the among cirrhotic patients of HCC being picked up, in them this would be roughly 20% of all cirrhotics, 1 in 5. In them it may even be cost effective to offer MRI scan. And otherwise, where cost benefit doesn't matter, where my patient can afford and I want to do the best for my patient, I think periodic MRI scans can be offered. But this is not as yet standardized, like 6 monthly ultrasound scans. So how often should I do MRI scans? 6 monthly, yearly, once in 2 years. All those data and that information has to be generated. But it is an option certainly.
Thank you so much, sir. And with that, we close the meeting. Dr. Praveen.
Thank you, sir, for your wonderful lecture and the discussion. So, in the last, on behalf of all the organizing members, I would like to say big thank you to all the speakers for making such an excellent presentation. All our moderators and chairpersons for taking out time and making a good discussion from all the attending delegates. I would like to thank all the pharma people for their support, the Pranav and his team members for making this conference a big success. Our endoscopy staff, they have done a good work, and I think all the members who have attended and who have made this conference a big success. Sometimes there are certain shortcomings, and because we have made a group, so it is, I think we want some suggestions from you the next time how we can improve ourselves. So you are all free to say some comments on the group which we have made, so we can improve ourselves. Thank you. Thank you all.
Lunch is open. Request everyone to join for lunch outside.